Good morning, everyone. I can't see your faces. I got my computer glasses on, so I'm assuming you're all neuroblastoma families and doctors and everything. I want to welcome you to, I think it's our 20th Parent Education Conference, and I'm very, very happy that you're here, very sad that you're here, but happy that you're going to be able to get the information and education and knowledge that you're going to need to take on this journey. So just to give you a quick background on myself, we started Children's Neuroblastoma Cancer Foundation in 2000 after losing our son Nick to neuroblastoma back in 1999. He was in treatment for 4 years, and unfortunately not a whole lot of treatments available at that time. And so we started it because there wasn't a whole lot of information. I think we had actually one of Dr. Yannick's, Valerie Castle. I had one sheet of paper about MIBG treatment, and that was really about it. That's all we had. So that's why we started this. We got to be together as a group on an online support group, and I said, well, why don't we just meet? Why are we doing all this stuff online? Why don't we meet? And it's forged some, long-lasting relationships. We've got 20 years, almost 20 years going. So it's just a very, very nice feeling to be able to be together. And I hope you make some, friendships and everything along the way. Again, our whole scope of services to provide the resources that you're going to need. We have awarded almost close to $3 million in research grants, at hospitals across the country. That's our another main goal of ours. We have a parent handbook that we have online that was written by parents. So if you haven't had an opportunity to take a look at the parent handbook, it's an awesome tool, and resource for yourself. I've had people tell me that it was a Bible, that they used during treatment when their child was first diagnosed. We have a great medical advisory board. Dr. Yamashiro, Dr. Chung, Dr. Reynolds, Dr. Bagatelle, Dr. Julie Park, Sue Cohn, John Maris. They're all part of our medical advisory board. That's a little bit about us. Now, the next thing the way we do the conference is our presenters will be up here for approximately 30 minutes or so, and then we will do a 15 to 20 minute question and answer session after that. And what I do ask that we set up 2 microphones. If you could come up to the microphone, say your question, but keep it as general as possible. Because we don't want it to be very specific. I mean, some of the questions will be specific to your child, but we want it as broad as possible so that everybody can gain, as much information out of your question as possible, and then the response from the doctor. Let's see. We are videotaping, so just so you know, we are videotaping it, and we ended up getting it live streamed as well. So that will be available for families. And if you have questions, feel free to write them down. And if you don't want to stand up and ask a question, write it down. We'll wave it, and we'll come get it, and we'll ask the question. So if you're embarrassed or anything and don't want to be up front, because there are no stupid questions. So I just want you to know that there are no stupid questions. Let's see, use the mics. If you want to hand wipe the mics off, you can. We're trying to be as safe as possible. The other thing is, if anybody feels sick and you want to do a COVID test, Abbott donated a bunch of COVID tests for us. So if anybody's interested and wants to do it, you're free to take a test. The kids' room, they will not be coming when we have breaks. They're not going to be coming for the breaks. So any lunch and dinner and stuff like that, they'll be with you. I think they'll have a great time in there. We are doing some family photos, so if anybody's interested and would like to go down to the hall in the Oak Room, Karen Haberberg is doing family photos. So if you're interested, I think it would be a great thing to have for you. And again, the kids' room will have, they got plenty to do. They've got an Xbox, they've got all the games. They have also a face painter coming this afternoon, and then a balloon maker, and both of them are awesome, and they both donate their time to us, and we're very appreciative of that. If anyone, again, feels sick, if you want to take a COVID test, please do that. Friday night, tonight, we will be having dinner and a DJ. We get a little wild, so if you guys, if you want to loosen up a little bit, we can even do a little karaoke if you'd like. We've got a great DJ coming and everything. Again, the whole point is to relax. Get the information, relax. There's no beepers. There's no, nobody's doing this, nobody's poking or anything. It's just relax, have a good time, and take the information. I want to thank my assistant, Nikki DiBenedetto, for all of her hard work putting the flights together. I don't know where she's at, if she's here. She's very good at that. So, and I wouldn't want to do it. It's too much work, too much work. And then thank my friend Sherry and her daughter Cassie for running the kids' room for us. Again, looks like they've had it all set up really nice for them. I want to thank our sponsors, YMABS Therapeutics, Jubilant, United Therapeutics, Friends of Catherine, the Nick Foundation, and it's just, again, this wouldn't happen, without all of our sponsors and their ability to support us in this fashion. So I just wanted to thank them, and if you want to thank them, please feel free to, go up to them. They do have some materials out on the tables and everything, so you can, feel free to take them, and there's some other books out there that are free for everyone. Let's see, Mike Elbaum for videotaping our presentation, Alvaro for live streaming it, and for all the staff here at the Weston. I just wanted to say thank you for everything. Okay, we will start our presentation. Our first speaker is Dr. Ami Desai. She's an attending physician at Comer Children's Hospital at the University of Chicago. Dr. Desai received her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital of Philadelphia. Her areas of expertise are sarcomas and neuroblastoma and other solid tumor cancers, as well as developmental therapeutics and adolescent and young adult cancer care. She is a member of several associations, including American Society of Clinical Oncology, American Society of Pediatric Hematology Oncology, and numerous others. Dr. Desai is involved in many clinical trials at Comer Children's Hospital, and her talk today is an introduction into neuroblastoma. As we know, a lot of you are first, diagnosed recently, and so I think it's important that you get the basics, down to it. And if you, again, have any questions, we will go ahead and do those after her presentation. Dr. Desai.
Probably going to sit or stand to the side of the podium so I could look at the screen. Thank you to everyone, and thank you to Pat and CNCF for the invitation today, and it's wonderful to see everyone in person. My talk will basically go through, as the title implies, the basics of neuroblastoma, and hopefully set the foundation for the rest of the talks that you'll hear during this conference. So neuroblastoma is the most common solid extracranial malignancy in children, or solid tumor that's not a brain tumor. It originates from neural crest tissue, which is in the adrenal glands or anywhere along the sympathetic ganglia that traverses from the neck into the pelvis. And it is classified as a small round blue cell tumor, as you can see as to how it looks under the microscope. There are approximately 800 new cases per year in the US, and it affects about 7% of all, or encompasses about 7% of all childhood cancers, but 15% of childhood cancer mortality. So there is a disproportionate mortality from this malignancy. And about half of all newly diagnosed patients will have high-risk disease. And what we do know is that there is a higher prevalence of high-risk disease in Blacks and Native Americans. And as you can see on the right, again, this is a malignancy of infancy and childhood, and really the highest incidence is in the first year of life. Neuroblastoma has a broad spectrum of clinical behavior, and it really is reflective of the biologic heterogeneity. So from the low-risk side, where there can be spontaneous regression or treatment just may include surgery, you then move into intermediate-risk disease, which is treated with both chemotherapy and surgery. And then finally, high-risk disease, which requires intensive multimodality therapy that we'll talk about during the course of this talk. So a big question that I get from families when we have our day one talk is, why did this happen, or what is the etiology of neuroblastoma? And, there is no consistent environmental factor that has been identified. And as for genetics and family history, we're learning more and more. But what we know is that family history or bilateral or multifocal neuroblastoma occurs in a small proportion of patients, about 1% to 2% of cases. And often this is secondary to a germline FOX2B mutation. And these cases are associated with congenital central hypoventilation syndrome and or Hirschsprung's disease. And germline ALK mutations have also been identified in the majority of familial cases. But for the vast majority, it is not familial and is sporadic. However, there have been some syndromes that have been identified to predispose certain children to develop neuroblastoma. And this includes Costello syndrome, Noonan syndrome, Beckwith-Wiedemann syndrome, and Li-Fraumeni syndrome. And I've listed some of the germline mutations that can occur in these syndromes. And these are syndromes, again, that can be passed on through families. So then the question is there a role for screening in the general population? This is another question I feel that comes up when speaking to families about neuroblastoma. And decades ago, there was population-based screening in certain countries for infants 3 weeks of age to 12 months of age. And what they found was that there were increased rates of diagnosis of early-stage tumors, but this did not decrease the mortality. And virtually all of those tumors had favorable biology, or tumors that may have regressed on their own. So we were now intervening in this population and potentially causing other side effects or morbidity from acting on it. So the conclusion was that tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease, and many are likely to spontaneously regress. So populations at risk, some of the syndromes that we talked about earlier, what are the screening recommendations for these patients? So a few years back, there were consensus guidelines developed by experts in the field. And what they proposed was that for children ages 0 to 6 years of age, that they should have an abdominal ultrasound, urine catecholamines, chest x-ray, about every 3 months in that early time span in their life. From ages 6 to 10, an abdominal ultrasound, urinary catecholamines, x-rays, and do this about every 6 months now as they're sort of aging out from potentially developing neuroblastoma. And then for ages greater than 10 years, no screening is recommended at this time. As for the clinical presentation, as mentioned before, this can be very heterogeneous, and patients can have an asymptomatic mass, which could just be a mass that a parent may identify or see in the neck or on exam in the pediatrician's office. Again, it could be a mass in the thorax, abdomen, and pelvis, because that's where the sympathetic ganglia traverse. Patients may present with Horner syndrome if they have compression of one of their sympathetic ganglia. They can have spinal cord compression, which may result in back pain or neurologic deficits and is an urgent situation or emergent situation. They may have a big liver or hepatomegaly, pallor, because their bone marrow may have neuroblastoma in it, and they have a low hemoglobin. Skin lesions, systemic symptoms such as weight loss, irritability, fever, hypertension. There is a syndrome, VIP syndrome, where they can have intractable diarrhea, which is more on the rare side, and opsoclonus myoclonus, or a condition where there is neurologic symptoms that also present with a mass, as well as bone pain or limp or refusal to walk or raccoon eyes, or the bruises that you could see on the screen on the bottom right. So we talked about how neuroblastoma primarily affects younger children. However, this does present in older patients as well too, but really presents as a phenotypically different disease, or presents in a very different way. And Again, it's very rare to occur in the older population. It's more of an indolent disease course, so their tumors may not be as responsive to some of our conventional therapies. And they do have inferior outcomes compared to younger patients. And there has been some identified unique tumor biology in these patients having segmental chromosomal aberrations or ATRX mutations. And there is a need for novel therapies for this population. So as for evaluations and tests, so of course, we do a history and physical exam. We will draw baseline laboratory tests, which include a CBC or blood counts, chemistries to look at organ function, urine catecholamines. We'll often check an LDH and ferritin. And of course, we'll image the tumor, looking at it with a CT scan of the chest, abdomen, and pelvis, or sometimes an MRI for masses that might be near the spine. And as well as an MIBG scan that we'll talk about in a little bit, or sometimes a PET scan. And to get the diagnosis, we do a biopsy of the tumor in the very beginning, and bilateral bone marrow aspirates and biopsies, again, to identify where the cancer may be. And how do we diagnose neuroblastoma? So either we get the diagnosis from the biopsy and the tissue biopsy, or for certain patients where it may not be easy to get a biopsy or they may be quite ill, sometimes we can make the diagnosis with the presence of neuroblastoma in the bone marrow combined with elevated catecholamines. So many of you have heard of MIBG scans or have children who undergo getting MIBG scans. And this is a scan that detects certain types of neuroendocrine tumors. And MIBG is an analog of norepinephrine and is labeled with radioactive iodine and taken up by the neuroblastoma cells. So these tracers are taken up by the neuroblastoma cells and then help the cancer cells light up on the images. And something called a Curie score is determined based on the extent of uptake, and we'll go into that a little bit, and Dr. Yannick's talk will go into that in more detail as well. But that helps us quantify how much disease may be present. And what we do see on the scans too is there's sometimes normal uptake in the salivary glands, bladder, and liver, and that is something that we see and doesn't really represent disease. And we will make sure that our patients have thyroid protection when they get this scan before they get injected with the tracer to help protect their thyroid from MIBG uptake. So this is a little picture of what we call a Curie man, which this individual is broken up into different segments, and that helps us quantify how much disease a patient may have. And we break this down into bony lesions as well as soft tissue. So as for prognostic markers in neuroblastoma, stage and age were the very first prognostic markers, where younger children did better than older children, and those with lower stage disease did better than those with higher stage disease. And then other important prognostic markers that have developed over time was a change in the cancer cells or amplification of MYC-N, which is a worse prognostic marker than not being amplified. Ploidy, again, another type of change in the cancer cells, as well as histology, or how the tumor looks under the microscope. And these 5 factors have traditionally been used to assign risk assignment, or whether a patient should perhaps receive low, intermediate, or high-risk therapy within the children's oncology group. And more recently, an updated schema for risk stratification now includes segmental chromosomal aberrations or other types of genetic changes in the tumor cells for certain subgroups of patients. So again, as for prognostic markers for age, we sort of draw the line in the sand at 18 months. For stage, we previously used the INSS staging system, which was a surgical staging system, and have moved on to the INRG staging system, which we'll go into in a little bit more detail, which is a pre-treatment staging system. MYC-N status, histology, or again, how the tumor looks under the microscope, as well as tumor cell ploidy, and again, further biologically describing the tumor. And here is sort of how we put this together to determine certain risk groups. And this was the COG neuroblastoma risk group schema until very recently, and is still quite relevant. And again, you could see how the 5 prognostic markers help us define what kind of therapy a patient should receive. And the one thing I wanted to point out is that for patients who are greater than or equal to 18 months of age and have stage 4 disease or metastatic disease, or what we call stage M now, we know that those patients are high risk despite any of the other biologic markers. So again, age and stage, some of the earliest markers really continue on to impact or are important prognostic factors. And I'll very briefly go through our updated COG risk classification system. And essentially, these schemas start with the stage of the tumor, and again, use the common prognostic markers that we've talked about, but have added in either, again, extent of surgical resection for these lower stage tumors or an L1 tumor, or have also added in segmental chromosomal aberrations for stage L2, M, and MS tumors. And I wanted to briefly touch on the International Neuroblastoma Risk Group, or INRG task force. And this task force convened in 2005, and what it was, the goal of it was to really address the problem of non-uniformly defined risk groups, how we do things in the US versus in other countries. And there was also, through this group, the development of a pre-treatment staging system, or as I mentioned, the updated INRG staging system. And this now includes image-defined risk factors, which I'll go through briefly as well too, and is not dependent on the degree of surgical resection. And this group also developed a new risk classification system that we don't traditionally use in practice now, but is an example of how we could risk classify patients and more uniformly perhaps group patients across the world. So again, the International Neuroblastoma Risk Group Staging System. This is pre-treatment now, before surgery, and it's based on really radiographic findings. So we now use something called image-defined risk factors, or if tumors are wrapping around really major blood vessels and may perhaps lead to a more difficult or risky surgery. So L1 tumors are localized tumors without these image-defined risk factors. L2 tumors are local regional tumors with one or more of these image-defined risk factors. Stage M tumors are those where it's not just the primary tumor, it's now moved on to other places. And MS tumors are, again, this very small, or this very select group of patients that are younger patients, less than 18 months of age, with either L1 or L2 tumors, or with metastatic disease that's very much confined to the skin and or liver and or a small amount in the bone marrow. And these patients do quite well. So these are examples of image-defined risk factors. I won't go through all of them in detail, but again, it really is about the tumors wrapping around really important blood vessels or local regional organs. And this slide just again compares the older staging system that we have, the INSS staging system, and the newer INRG staging system. And this slide is just an example of the risk group pretreatment classification schema that came out of the International Neuroblastoma Risk Group, which is, again, very similar and includes age, histologic category, but now breaks down histology a little bit more into degree of tumor differentiation, and MICN amplification, LQ aberration, and ploidy. So as I mentioned on early in the talk, the neuroblastoma has a broad spectrum of clinical behavior, and we group patients as to either having low, intermediate, or high-risk disease based on the factors we just talked about to help us guide what kind of treatment a patient may need. Again, low-risk patients may have spontaneous regression of their tumor or just may require surgical resection. Patients with intermediate risk disease often receive chemotherapy and surgery, and those with high-risk disease receive multimodality therapy. So again, therapy is tailored according to patient risk, and we are continuing to try to identify treatment strategies with optimal survival rates and minimal toxicity. And the way we do this is through successive clinical trials. So clinical trials in neuroblastoma really tailor treatment according to predicted behavior based on clinical characteristics and tumor biology. And a series of clinical trials for children with low, intermediate, and high-risk neuroblastoma have been ongoing for decades to identify treatment strategies with optimal survival rates and minimal toxicity. So I wanted to touch on a few trials over the years that have led to how we currently treat our patients. So for low-risk neuroblastoma, there was a trial, P9641, where the objective was to demonstrate that surgery alone would achieve 3-year overall survival of greater than or equal to 95% for patients with asymptomatic lower stage tumors, these INSS stage 2A and 2B tumors, where asymptomatic patients would receive surgery alone and symptomatic patients would receive a small amount of chemotherapy plus surgery. And what we saw was that this was possible, that we could maintain excellent survival with decreasing therapy in a subgroup of patients. So again, patients with low-risk disease may just undergo observation, surgery, and a small group of patients may require some chemotherapy. And then moving on to intermediate risk neuroblastoma, I wanted to touch on the study A3961, where the objective was to determine whether a 3-year estimated overall survival of more than 90% could be maintained with reductions in the duration of therapy and drug doses using tumor biology-based therapy assignment, where those with favorable biology received 4 cycles of chemotherapy and surgery, and those with unfavorable biology or an incomplete response received 8 cycles of chemotherapy and surgery. And again, what was seen was that we could reduce therapy while maintaining excellent outcomes in subgroups of patients. And next, another intermediate risk study, COG ANBL 0531, was now a response and biology-based trial for intermediate risk neuroblastoma. And the objective here was to reduce therapy for subsets of patients using a biology and response-based algorithm to assign treatment duration while maintaining excellent 3-year overall survival of greater than or equal to 95%. And what was seen was that based on this response and biology-based system, that patients could receive anywhere from 2 to 8 cycles of chemotherapy, depending on their response, and surgery, and excellent outcomes were maintained for the majority of patients. And now we move on to high-risk neuroblastoma. And again, this is what I like to tell families as well, too. I know many families are like, oh my goodness, we're put in this high-risk category. But I like to think of it as a way of risk helps us define how we need to treat a patient and how much therapy we need to give a patient to try to get the best outcomes that we can. So an earlier study, CCG 3891, conducted by Dr. Methe, who you'll hear from today as well too, looked at whether the addition of myeloablative chemotherapy plus autologous stem cell transplant versus continued chemotherapy improved outcomes in patients with high-risk neuroblastoma. And what was seen was that this high-dose or myeloablative chemotherapy and stem cell rescue did improve event-free survival in patients after induction therapy. And then moving on to the COG study ANBL 0532, ANBL 0032, now looked in the post-consolidation setting and saw that does the addition of immunotherapy or targeted immunotherapy targeting anti-GD2 on neuroblastoma cells, plus the differentiating agent isotretinoin, improve outcomes compared to receiving isotretinoin alone in the post-consolidation phase. And what we saw here was that the event-free survival and overall survival is improved with immunotherapy plus isotretinoin following autologous stem cell transplant. And that is our current standard of care in the post-consolidation setting. And then moving on to ANBL 0532, this now looked in the consolidation setting, whether getting 1 or 2 transplants was better for patients with high-risk neuroblastoma. And what was seen here was getting tandem or 2 autologous stem cell transplants improved event-free survival, especially when followed by immunotherapy. So this is our current COG-based standard of care treatment for children with high-risk neuroblastoma. So as you can see, patients undergo a biopsy at the very beginning to help with the diagnosis, receive 5 cycles of chemotherapy and surgery during induction. Consolidation consists of tandem autologous stem cell transplant. There are some subsets of patients who may receive one stem cell transplant, and then radiation to the primary tumor or any sites that may be positive on MIBG scan prior to consolidation. And then the post-consolidation phase includes the targeted immunotherapy or anti-GD2 antibody and cytokines and isotretinoin. And Dr. Mathay will go through some more of the current COG trials and directions for the future. So this slide just shows the successive increase in overall survival for COG patients with high-risk neuroblastoma over the time span of 1990 to 2015. And as you can see, we have made some strides in outcomes for our patients. However, there is clearly room for improvement, and this helps drive our current trials for neuroblastoma. And I very briefly just wanted to touch on some targeted therapies for neuroblastoma. As we talked about anti-GD2 antibodies, which play a really important role in the frontline setting and in the relapsed setting for patients with neuroblastoma. MIBG therapy, again, different from MIBG scans, and Dr. Yannick will go into this in more detail. And ALK inhibitors, one of the other targeted therapies that we can use in neuroblastoma. So anti-GD2 antibodies. So GD2 is a disialloganglioside that's essentially ubiquitously expressed on neuroblastoma cells. So again, a targeted therapy for neuroblastoma. And there are a variety of anti-GD2 antibodies. Many are familiar with dinutuximab. Dinutuximab beta is used in Europe, and these two antibodies are chimeric monoclonal antibodies. And then there's nexitamab, which Dr. Morgenstern will go into in a little bit more detail as well too, which is a 3F8 humanized antibody, and also being used in various settings for neuroblastoma. And the side effect profiles really reflect sort of the off-target effects of the drug. So GD2 is also expressed on some of the long nerves in the body, so pain is one of the big side effects of this drug. And also allergic type reactions are important side effects that we review with families. MIBG therapy, again, is a similar concept as the scans, except there's a higher radioisotope attached to the MIBG tracer, allowing us to provide some localized radiation to areas of disease. This generally requires a lead room or shields to protect families and staff from radiation exposure, and generally requires stem cell rescue afterwards, as it can impact the bone marrow. And it is currently being studied as part of frontline therapy for high-risk neuroblastoma in the current high-risk study. And this is just an example of a scan, and sorry, the images are not the best, prior to MIBG therapy. And then one thing I always bring up to families is, we get a scan wall after they get their MIBG infusion prior to their discharge, and often or what we would like to see is the lesions look brighter, or it looks a little bit worse than their baseline scan, but this is what we want to see. We want to see the uptake in the areas of disease, and then we get a follow-up image 6 to 8 weeks after therapy when the MIBG has left the system, and to see what the response has been. And this is just another example of a patient who's had a very nice response to their MIBG therapy. ALK, we talked ALK potentially leading to familial cases of neuroblastoma. It can be in the germline, that's very rare. However, in the tumor, we can see ALK mutations, and that does not mean that it's the hereditary form. It can just be in the tumor cells. And we see that in about 10 to 15% of children with high-risk neuroblastoma. And we do have targets for this. So crizotinib is an ALK inhibitor that has been investigated in neuroblastoma and was integrated into the frontline study for patients with ALK mutations at diagnosis. And we will now be using lorlatinib, which is another generation or newer generation ALK inhibitor for patients with ALK mutations. And I'm just going to end by talking again about some of the late effects, which you'll hear about throughout this conference. But we know that high-risk therapy is quite intensive and can impact various organs, can lead to infertility, can lead to neurocognitive effects and secondary malignancies, and we take this very seriously and, again, want to develop and eventually have therapies that have less toxicity. and improve and optimize outcomes for our patients. So there is a study within the Children's Oncology Group that's led by Dr. Tara Henderson and Lisa Diller, and this is, again, trying to really understand what are the late effects in our patients. You know, it's great that we of course want to have optimal outcomes for our patients, but you know, what are these long-term effects, and are there ways that we could prevent some of these late effects? So they are investigating the late effects of patients receiving current era therapy, and we hope that we will be able to see some of this data very soon. So how can we continue to improve outcomes? By investigating novel therapies, collaborative work between those in the lab and those running trials, further refining risk stratification and having more precise treatments for our patients, learning more about biomarkers of therapy response and resistance and how that might help guide therapy, and again, collaboration across the world as well. So I wanted to end by saying thank you to everyone, especially our patients and their families who go through so much every day. And of course, the Children's Neuroblastoma Cancer Foundation and Pat for all of their work in putting together this wonderful educational conference. Thank you.
If anybody would like to come and ask questions, you can turn the microphones on and come up and ask.
Testing. All right. Good morning. Thank you, Dr. Desai, for your presentation and for all the doctors and families who are here. My name is Megan Nelson. I'm a parent out of Children's Hospital Los Angeles. I have a few questions, but I will just ask one because I know we are short on time. I'll go with your first slide. Your first slide, you mentioned that there is a higher prevalence of high-risk neuroblastoma in Blacks, and I think you mentioned Native Americans or Hispanics. Has there been any research done as to why this is?
That's a really good question. So, you know, there was a study done about, gosh, it might even have been about 10 years ago now, that showed that the prevalence was higher in Blacks and Native Americans, but the outcomes were the same as, you know, all other races and ethnicities in that study. But there has been some work looking at the genetics within certain patient groups and races and ethnicities that may impact why certain subgroups of patients may develop higher risk disease. So there has been some published work on that, and there is some ongoing work in that area. And there's some newer work looking also at, you know, even aside from race and ethnicity, looking at social determinants of health and, you know, the impact of, you know, beyond race and ethnicity, again, looking at how poverty can potentially impact outcomes for our patients, and there's some ongoing work in that area as well.
Good morning.
Hi, good morning.
My name is Kimberly Turner, and my daughter is 14. She was diagnosed at age 4 and relapsed at age 8. When she was diagnosed at age 4, they went back and forth between stage 3 and stage 4. They didn't know if they wanted to just hit it with everything or just treat it as intermediate risk. I'm sorry. You guys can hear me. I'm sorry. My daughter was diagnosed at age 4, and she relapsed at age 8. In the staging, they were kind of going back and forth. They didn't know which to put her in stage 3 or stage 4, but they did ultimately decide to do stage 3 and just do chemotherapy. And I always wondered if they had staged her at stage 4 the first time, which she had relapsed the second time. And they always say if they relapse one time, they will relapse again. So it's always in the back of my mind, will she relapse again, even though we had all of the stage 4 treatments. We had the chemotherapy, the stem cell transplant, but we only had one stem cell transplant because she only had 7,000 when she's supposed to have 15,000. And I did not want to risk, you know, doing 2 because it was such a hit to her body. So do you think if we had staged her at 4 the first time, would she had relapsed the second time?
Yeah, not knowing all the other characteristics of the tumor and just knowing the stage alone, I think that's hard. And I think there are patients that could fall into either category, and we try to use all the other information that we have to pick what might be best in that moment of time. And sometimes we do want to give patients the benefit of the doubt and, perhaps try intermediate risk therapy. And there are some patients who progress on intermediate risk therapy and then go on to receive high risk therapy. So that does happen. And in fact, some of our high risk protocols allow that for happen, that someone may have received a little bit of intermediate risk therapy and then perhaps there's something that made us think that they're high risk, or after they relapse may receive high risk therapy. But there's so much we still need to understand, even beyond what we do know when we classify certain patients into groups. And we draw, again, a line in the sand somewhere, but there is a little bit of give and take. But I think that's where all the research comes in to understand how can we be more precise for each patient. And it's just really hard, I think, to in retrospect, you think about these things, of course, as a parent, but I think we take whatever information we have at the time that we think will provide the best outcomes for patients at that time.
With her being treated as high risk, like if she does relapse again, I don't see any protocol for treatment if she relapse again. Is that like a doomsday type situation for us if she relapse again? Because they always say, like I said, if she relapse once, she'll relapse again. So it's always in the back of my head, but I don't see anything else that we should do if it does. Do we do the same thing over again versus something else?
So I think there is going to be a talk today or tomorrow, actually maybe tomorrow, on relapsed neuroblastoma, and that will probably hit some of these therapies. And you are correct in saying that treating relapsed high-risk neuroblastoma is difficult. There are certain patients that may have certain patterns of disease that might be easier to get rid of that disease than other patients, and we are learning more and more. There are a lot of clinical trials out there for patients when their disease comes back. We need more, of course, as well too. There's a combination of chemotherapy plus anti-GD2 antibody that's been very effective in the relapsed or in patients who may not have responded to therapy the way we wanted to, that I'm sure you'll hear through the other talks as well too. So my talk didn't really hit on a lot of the therapies in the relapse setting, but I'm sure you're going to hear more about that during the course of these 2 days. Mm-hmm.
I don't really like talking in front of people.
Pretending all day.
Easier said than done. So I saw that you mentioned the 11q on here, but I didn't see anything about the 1p deletion. Do you know where that stands?
Yeah, so that is also, I didn't hit on everything in the talk. They sort of, they can fit into this group of segmental chromosomal aberrations that we see, and I didn't pinpoint it here, but you're right, there has been some work looking at that and in the intermediate risk group of patients as well too.
Okay, good. I think that was all I had.
And if you have more questions, I'm happy to talk, if you don't want to talk in person too.
Okay, anyone else? Okay, yeah, go ahead.
Hello.
Hi.
My daughter, she had the tumor encapsulated. They surgically removed it before doing any chemotherapy. And it was decided not to do chemotherapy at the time. But then they found that, not through the MIBG, this was in Mexico, because we had they didn't see anything in the MIBG. But then in an MRI, they started seeing spots, and then it was decided that it was a relapse. Now, is that considered a relapse or not? Is it safe to assume that it wasn't a relapse, it was already there, like the metastatic disease?
I think that's, again, hard to probably answer without knowing all of the information as to how she presented, but, it's hard to say whether that was part of her original disease versus something coming back.
Okay.
Yeah.
Thank you.
And I'm sorry, I wanted to touch on one thing about the race and ethnicity. That I mentioned the paper about 10 years ago did talk about how the outcomes were the same even though the prevalence was different. But there was newer data presented in our recent oncology meeting that did show that outcomes were disparate in some of the current era high-risk trials. based on race and ethnicity and poverty as well too. So again, still things that we're learning and different populations that we're treating. But those are patients who are treated on trial and trial data, whereas the study from about a decade ago was more of a population-based study of those who were on a trial or just on a biology trial and not actually on a clinical trial too.
I'm sorry, I have one more question.
Go ahead.
I have a million, but I won't. Like she was saying, you guys said it's different with race. The first thing I did was Google this, like all parents do. And when you look it up, it says white boy's disease. I have a black daughter, so I'm looking like, wait, what happened? So why was it categorized like that, a white person? And then I see all different races with
Yep.
this particular disease. I don't understand why was it just in that particular race and to a particular
Yeah.
sex group.
Yeah, you're right. And I think, at least in the studies, what they did was sort of use what we call like a composite variable, including both race and ethnicity, knowing that, there is some variation within that. And again, some of the genetic studies, because you're right, we group patients into different categories, but they may have an ancestry that might be a lot more broad than that. And that's where some of the germline genetic studies and their outcomes have been a little bit a different way to classify patients as well, rather than what someone reports as their race and ethnicity as well.
Anyone else? Okay. Yeah, please do.
Thank you, Doctor. I'm a grandmother of a little boy that was diagnosed at a year. And, all the great information that you shared with us about diagnosis and staging and symptoms and all that. And my grandson is MYBG amplified.
Omicron amplified.
So it's
yeah.
genetic. And anyway, he had all the symptoms. My point in coming up with a question is really to kind of declare, what is going on with pediatricians? Why aren't they doing early screening? I mean, we ran this kid around to pediatricians. He was given antibiotics. We went to emergency. They said, take your baby home. He's just a cranky kid. Teach him how to sleep. He had a 13-inch tumor between his liver and his kidney, and they couldn't diagnose that because they just refused to scan him. Yeah. So how do we pleaded, and here we were, rushed to Lurie's Children's in an emergency chemo and surgery situation.
No, I hear you, and I'm sure as a parent, as a grandparent, as a relative, you always wonder, could this have been diagnosed sooner? Why did this happen now? I will say, we're lucky in pediatric oncology that it's not common. As an oncologist, I think about cancer all the time, and, if a patient gets referred to me, I have my top X number of things I'm thinking of. I think when a patient comes to the pediatrician's office, there are a lot of things that you can think of, and some of the symptoms of neuroblastoma can overlap with a whole lot of other things as well, too. I remember as a fellow, one of the very first patients I consulted on was on a general pediatric service, and with fever of unknown origin and a limp, and there were a lot of things that were being worked up at that time, and after some imaging, we saw what it was, and, again, I think once you know what it is, it's very hard to be like, how could we have not known sooner? But I think, again, cancer is rare in the pediatric population, and there are a lot of other things that we think about when someone comes in with generalized sick symptoms. And of course, I don't know the details of everything from your grandchild's diagnosis, but it's not uncommon for kids to feel unwell for a period of time before imaging is done, and we sort of go through a stepwise process often to try to understand what's going on. Yeah. Yeah. Yeah.
There's we have a pamphlet out in front. There's an organization out of California too that's kind of bringing up this exact same topic. I don't know how far they've gotten, you know, as far as trying to reach out to pediatricians or not. It's the Friends of Catherine Foundation. There's a pamphlet out front you can take. But yeah, that's basically the same questions they had, and how can they treat or teach the pediatricians, you know, to at least be a little bit more aware of what cancers might be out there in the children. So you might want to talk to, you know, the Susan Justo, and she can maybe help you a little bit more too.
And you're right, and I think, you know, a lot of subspecialties, you know, even beyond oncology, for what they do, will often have these seminars and, you know, discussions with pediatricians as well, and just to, you know, raise everyone's suspicions if they're coming across certain symptoms too. All right, thank you.
Sorry, Jen, I just wanted to make a quick comment,
Yes.
which is, I think, the other thing to bear in mind is, although it's super distressing when there's delay in diagnosis,
yeah.
I'm not sure it's clear that it actually
impacts.
changes the outcome for the patients. You know, in adult cancer, we're very used to thinking, oh, we've got to catch it early because otherwise it will spread. And I think in neuroblastoma, it's a bit different in that it's predetermined to a large extent by the genes, by the genetics in the tumor, and it's going to do what it's going to do, and it's going to respond to treatment as it's going to respond to treatment. And as long as the child is well enough to receive the treatment, actually it doesn't matter from an outcome point of view whether they were diagnosed today or last week or last month. I don't think it changes that quickly.
Yeah, I just want to reiterate what Daniel said. You know, adult cancers are, you know, often environmentally driven, or, you know, there are screening procedures for breast cancer and colon cancer, and a lot of childhood cancers are very biologically driven. The tumor was going to do what it was going to do. I think that's what you're trying to get at Daniel, and that's why we have so much of the biology impact the way a patient is grouped into treatment.
Okay, one more question.
I was curious, are cancer rates increasing with either overall pediatric cancer or neuroblastoma? And if so, does it just reflect like population growth, or is it outpacing population growth?
Yeah, I have to say the most recent, I don't want to misspeak as to whether the rates are similar or are going up for the most recent data. I don't know if anyone in the audience would like to comment on that as well too, but you know, we don't screen for this, so it's not increased screening, but there might be increased awareness that may bring more cases to presentation. I know during the pandemic we were worried that patients weren't coming in, maybe perhaps as soon as they would have otherwise, that maybe could have impacted things as well. Right. Thank you.
We're just going to take 1 second to change out the microphones. Yannick. He's a pediatric hematologist oncologist at the University of Michigan. He received his BS in chemistry with summa cum laude from the University of Detroit, and his MD at Wayne State University. He did his residency in internal medicine and pediatrics at William Beaumont Hospital, his fellowship at Children's Hospital in Cincinnati. He is currently a clinical professor in pediatrics, hematology, oncology at the University of Michigan in Ann Arbor. His research interest is in neuroblastoma, the design of novel investigational therapies for patients with refractory disease. Dr. Yannick has presented here at our conferences many times, and we're very happy to have him back. It's been a little while. And I would cite the 65 or 70 pages of articles that he's written, but I just can't do it. I really appreciate him coming back, and he will be talking about MIBG.
You know, it really is a pleasure to be here. As Pat said, I'm Greg Yannick from the University of Michigan. And I don't even think I'm going to talk about my talk. I may just talk about the questions that were just asked after Ami's talk. Those are some of the most in-depth and sincere questions that I've heard at any talk ever. Ami, you did a good job fielding them. And in fact, I was thinking about some of the questions that were asked, and you know, from my opinion, I'll just give you a few answers from my opinion on some of them. And they were just beautiful questions. I don't find that the rates of neuroblastoma are increasing. I find that the rates of detection are increasing. Patients are also living a lot longer. When I started my fellowship, the 3 to 5 year survival was only around 20%. You know, now we're up this is for patients with metastatic or stage 4M disease. Now we're up in that 60 to 70% range. So our detection is improving and our therapy is improving. The average pediatrician will see 0 cases of neuroblastoma during their career. That's quite a staggering thing. 0 cases. We did a quality control study at our center to look to see what was the length of time from the initial onset of symptoms to the diagnosis being made. What do you guys think it was? A year? That's a good year. A month? About 4 months. So the average child was taking about 4 months to make a diagnosis. And oftentimes it's because, you know, they'd have, let's say the typical child, and I'm sure Kate and Daniel and Ami and Brian Kushner, some of my colleagues from around the country, would agree that the average pediatrician starts focusing on the hips with x-rays or on the feet with x-rays or something. They're missing it totally. And then eventually it becomes obvious. I love the question from the gentleman, where is he? His child was in Mexico. There we go. What's your first name? Avalto. You know, it was a great question because we're never sure of the answer ourselves in terms of is it just persistent disease or is it relapsed because of this. And I wasn't going to show it during my talk on MIBG therapy, but the definition of remission really means what can we detect with the limits of the scans that we have. And Kate's seen it with MIBG therapy. We'll say we'll take a child into our MIBG therapy, we do a scan before, and the child may have, let's just say, 2 sites of disease. Then right after MIBG therapy, we're giving a dose that's 200 roughly times what a scan dose is. We rescan the child immediately. And we prep our patients and our families that we may see a lot more. So now we do a scan and maybe they'll have 4, 5, 6 sites of disease. Did that mean that they picked up 3 or 4 more sites by going through MIBG therapy? No, we just gave them a bigger MIBG dose. Our detection sensitivity improved. And thus, is it a relapse? Is it just refractory disease? In many ways, it depends on the limits of sensitivity of the methods using to detect it. Okay. With that said, I also want to speak, I'm sure I can speak for all the physicians here. We have the best job in the world. We really do. Being able to take care of the thing that you value most, and that's the lives of your children. I'm honored to actually be here speaking to you, but I'm actually really honored to be able to help to take care of your children every day. So with that, we'll start. By the way, this is one of my patients, a young man. MIBG therapy does not do this to you, but it is amazing what you can do with those little otoscope speculum ends. And if you ever wonder why healthcare expenses are going up, maybe it's because oh God, I loved it. So I have no disclosures or conflicts of interest. This is just an outline of my talk. What is MIBG? How does it work? Ami talked a little bit about it, but when is it used to treat neuroblastoma? As she mentioned, Curie scoring. I'll talk about how it's done, what have we learned from it, and some of its implications for all of you and your children going through therapy, okay? I'll actually teach you how to score it today, okay? Let's just start with this. AMI had the name on it. It's actually on the National Spelling Bee. It's meta-iodobenzoguanidine, okay? And so what the bleep does that mean in English? You know, by the way, MIBG is similar to a hormone called norepinephrine. Norepinephrine is a signal. It's a chemical. It's a signal between nerves, okay? It's a signaling protein. Norepinephrine, like epinephrine, is a form of adrenaline, all right? I'm not going to make you a biologist or biochemist, but you can see on the left-hand side the chemical structure of norepinephrine. And then on the right-hand side, you see the chemical structure of MIBG. That little, you can see there's a lot of similarities there. That little red circle is where our radiochemists, it was invented at our center at the University of Michigan. They attached a radioactive iodine particle to one end of this compound, in essence making it look like radioactive adrenaline or radioactive norepinephrine. All right? So that's what it really is. There's no test on this, by the way, guys. If you, I don't know if I have a pointer here. Do I have a pointer? There we go. So this is a tumor cell, a neuroblastoma cell. This is the inner core of it, the nucleus. This is the outer core called the cytoplasm. Neuroblastoma cells actually have channels, and it's right here in brown. These channels typically allow adrenaline or norepinephrine to come in and out of the tumor cell. So what MIBG therapy is we've actually made a compound that looks like norepinephrine, and we put a piggyback on it with this radioactive iodine. That MIBG, it's just shown in yellow, will get taken up through these same channels. The tumor thinks it's taking up norepinephrine. Once it gets into the tumor, then that radioactive iodine is released. It causes damage to the nucleus of the cell and this entire cell per se. This is IV radiation therapy, okay? The beauty of it is, I think I'll show it in another slide, is that it, unlike regular radiation therapy, well, let's say we're radiating my wrist, and we just have to focus, we have to focus the beam, we have to focus the beam on the wrist, the radiation goes through the skin, through the muscle, through the tissue, hits the bone, and back out the other side. MIBG therapy goes to all sites of disease at once. It can hit the wrist, the knee, the skull, the shoulder. We don't get radiation damage to the other tissues around it. It doesn't go through the skin, through the fat, through the muscle. It's localized right inside that tumor. Okay? We can have a mass right up against the spine, and we're not going to be damaging the spine with our MIBG therapy. Okay? So MIBG basics, in low doses, it's used as a scan. In high doses, it's used to treat patients. It is, as I said, IV radiation therapy. The beauty of it is it targets all sites of disease. Neuroblastoma can get into bones. It can get into tissues, adrenal glands, other soft tissues per se. It gets into the bone marrow. MIBG therapy can get into all those sites. That's part of the beauty of it. Unlike standard radiation therapy, it's tumor specific, okay? Common side effects. How many people here have actually been through MIBG, had their children go through MIBG therapy? We've got a handful. That's actually pretty good. Maybe I'll ask you at the end of the talk or on the side where you got it at and how was it and what advice did you give to centers doing MIBG therapy. There's nearly 20 centers now in North America doing MIBG therapy. Common side effects, you know, it's actually really well tolerated. The first week, when you're actually in the radiation protection room, I'd say about a fourth of our children will get some nausea, vomiting for a couple days. About a fourth of them will get, I just call it chipmunk cheeks. They get these jowls. The MIBG will localize into the saliva glands, and you'll get what looks like mumps for a few days. I typically just put warm compresses on it. All of our patients have to have a Foley catheter, so we have to watch for problems with that. Rarely do we see some blood pressure changes where the blood pressure goes up for just a short period. So the first week, first month, you know, as the MIBG passes through the bone marrow, it tends to beat up the cells to get collateral damage of the cells in the marrow, especially if there's a lot of tumor in that marrow, because now that MIBG gets locked into the tumor in the bone marrow and you get collateral damage of some of the blood cells around it. So what we see in the first month is typically blood counts can drop down. And depending on the protocol, we may or may not give stem cells, a boost of stem cells, your child's own stem cells back, just to boost their recovery. And then in the first year, downstream, oftentimes, you know, the radioactive iodine, it's iodine that they put in salt because it'll help to strengthen your thyroid gland. that same radioactive iodine can get into the thyroid gland here and actually damage it. I'd say about 10% of our patients will become hypothyroid as a result of treatment. And as Ami said, they take those drops, that SSKI drops, not for 2 or 3 days, for 6 weeks after therapy. And then we always have to watch for secondary cancers. We've treated about 150 patients at the University of Michigan with MIBG therapies, at least that I've treated. I've seen secondary cancers develop in 2 children. And what does that mean? Like leukemias, bone cancers that occurred downstream after the therapy. So I don't know if my physician colleagues have even seen this slide. It's a picture of the first ever MIBG scan reported in publication, okay? So MIBG was developed in 1979 by Don Wieland. He was a radiochemist at our center. You can see the scan right here. You know, how many people have seen MIBG scans? They're tough to read. They look like a series of dots. I have to admit, I'm not sure what I would even be looking at here. The circle is around the left adrenal gland, the right adrenal gland, left adrenal gland there, right adrenal gland. Ah, good heavens. This was this was the first ever publication of an MIBG scan in the literature when it came out. The first MIBG scan, for neuroblastoma was published by Kate's group. Kate Matthews comes from UCSF, and her center has had a long and storied history of giving MIBG therapy, and Don Hatner at her center was the first one to use it for childhood neuroblastoma. And then the group at University of Tübingen, or Tübingen University in Germany, was the first to use it for treatment in 1987. I think the take-home point for parents as you're watching this is that this is not a new drug. This drug has now been around for roughly 40 years, either as a scan or as therapy. So in one slide, I figure I'll just show you an overview of MIBG therapy, just kind of summarize what's been done. Its focus to date has been to treat patients with relapsed or refractory disease. There's been over 2,000 patients treated at least. As a single agent, where it's just given by itself. I always view this as the landmark study. It was published by Kate Matthew, who's sitting right there at this table. She'll be speaking later this afternoon. And Kate reported 164 patients who were treated with just MIBG by itself. This study actually helped establish our dosing. What dose do we give? You know, we needed to see how much can we give? Can we give a second dose? What side effects do we see? It was this study that laid the groundwork for it, I feel. And you can see it was published in the Journal of Clinical Oncology in 2007. MIBG was incorporated into the bone marrow transplant process. How many folks here have had their children go through a bone marrow transplant? Almost 2/3 of the group here. Think about the fact that in these studies that I've got outlined, 2 by our group at Michigan and 2 by other groups, the MIBG therapy was incorporated directly into the transplant itself as part of the transplant regimen. And you can see some of our reports there. We actually had the toxicity of it. We didn't find it added hardly any toxicity at all to the transplant. It was very well tolerated. Some of our responses were dramatic, but in the end it became logistically difficult to do with transplant. Maybe I'd like to have seen better responses than I actually saw, and we've kind of stopped doing it in this way now. One of my colleagues who trained with Kate, Steve DuBois, is now in Boston, has done a number of studies combining MIBG with different agents. And then he just published a landmark study showing that MIBG actually is taken up better, has better effect when it's given with a drug called vorinostat, okay? So if you get MIBG therapy now, you're likely to get it with this, quote, radiosensitizer, this drug called vorinostat, that actually makes the MIBG in essence stronger, okay? So we should just stop the talk right now. I should just talk to everybody who's had MIBG therapy, the handful, and just see how your kids handled it. As Ami pointed out in her earlier talk, patients are in a lead-lined room or behind lead-lined shields. Our typical patient, just depends on the size of the dose, is in the room anywhere from 2, 3, up to 5 days. The longest I've ever had a patient in the room was 7 days. The larger the child, the larger the dose, the more radiation that has to be cleared. Each center has their own guidelines. So our guidelines at Michigan are different than Cincinnati's, are different than Kate's at San Francisco. They'll be different than the group in Philadelphia. Standards are set by the radiation safety services at each center. In fact, as parents, if you could even ask us, maybe as physicians, guys, can you get your act together and come up with a common set of standards? How we treat patients at U of M is not how, in terms of how conservative we are in terms of allowing the patients in the room, or liberal, varies from center to center. Our center is really strict in the first 24 hours. You know, typically the treatments are in an afternoon on a Tuesday or Wednesday. The parents actually can't be in that room for the first several hours after the infusion. They have an ante room, which is a side room, but they can't be in that room for that child. On the second day, we do measurements, and then we tell the parents, all right, you can be an X length of time, and the parents will go in and out, all right? The parents will help with the feeding. The parents will help give medications. We actually use them to partner with the care, as a lot of centers do. At our center, we actually asked, we did a study at one time where we did intake questions and outtake questions of both the patients, the children themselves, and the parents. I was actually struck by some of the responses by this. So here's some of them, some of the outtake. I'm just going to show you examples. So this is parent one. So this is at the end of therapy, after the child was in the room about 3 days in this lead line room. I'm grateful for therapy, but saddened by the price he had to pay. Here's the exact same child paired with that parent's response. It wasn't that bad. It would have been better if your hospital had corn dogs. Clearly, this child was traumatized by the entire experience. Parent two, therapy was tough. I had never left her side before, as many of you I'm sure would attest to, during any of her prior therapy. I know how agonizing it was for her. Here's the response from that child, from that parent. It was pretty easy. Plus, I didn't have my mom hanging around me all day. So, I think MIBG therapy has taught me a lot, not as how well it works, it's taught me a lot as a parent. And in many ways, how our children have that ability to handle things. You know, you can learn a lot from a 5-year-old. So MIBG therapy, where has it been used? As Ami pointed out, neuroblastoma therapy comes in cassettes. The first cassette's right now called induction therapy. This is the Children's Oncology Group model. So it's 5 cycles of chemotherapy called induction. The second phase is transplant, 1 or 2 transplants. XRT stands for radiation therapy to sites of disease. That's the second cassette of therapy. If you were to meet with me for a consult, I actually draw all my consults. Cassette 1, induction. Cassette 2, consolidation, transplant and radiation. Then cassette 3 is where you get that antibody, typically with that drug tretinoin that Ami was talking about. So where's MIBG therapy fallen into this? Well, for the most part, it hasn't. It's fallen outside of this. It's been used for relapsed or refractory disease, and historically this has been its primary role. For probably, let's say, the 2,000 patients treated, I would venture to guess probably about 1,600 of them all had it as relapse therapy, okay? The Dutch, though, this is pretty avant-garde. Take a look at this picture. There's that same cassette. They did the MIBG therapy up front. Think about when your child was diagnosed. If myself, Greg Yannick, said, all right, the first thing we're going to do is MIBG therapy. We're going to put your child in a lead line room. They actually did this in 2 Dutch studies. And here's what they did. You can see 41 patients. They received as their first therapy MIBG twice. So 2 consecutive MIBG therapy doses. They're split apart by about 6 to 8 weeks. And then those patients that were in CR, complete remission, or had a partial remission, it was 24 patients, they went on to get surgery, no chemo, and then they had transplant. Those that didn't have a complete or partial remission went on to get chemo, induction chemo, and then surgery, and then transplant. This is amazing. And their response rates were actually 71% or 73% in this study. I shake my head at this, how they were able to pull this off. Obviously, they did it in a small country with a uniform healthcare system, they could get things approved. It typically takes me about good 4 to 6 weeks sometimes to get MIBG therapy approved. We couldn't do this here in North America. We can't wait 4 to 6 weeks to get approval to start therapy. This is the current COG model on the current high-risk study. It's called ANBL 1531. In fact, do you folks ever wonder, I'm going to get off track on this talk a lot. Don't worry about it. You guys ever wonder where these numbers come from? Yeah, you know, Ami gave you a bunch of numbers, and I was looking at it as she was talking, thinking, dang, I should just tell you guys. These numbers are pretty simple in some ways. Yeah, insider trading information here. So ANBL, obviously, the A means an active treatment trial. NBL, neuroblastoma. 1531, 15 means the year it was written, 2015, okay? The 3 means it was a phase 3 trial where typically it's run up against a gold standard. Half the kids will get the investigational arm, the other half will get the standard arm. So that's a phase 3 trial. 1 means it was the first phase 3 trial written in 2015 for neuroblastoma that year. There can always be 2 or 3. And thus, you'll see the next high-risk trial, when it comes down, will have the number 2131. The study was being written in 2021. It was a phase 3 trial, and it was the first of that type. Make sense? Yeah. You know, it's interesting because that's the way I remember it now. I can remember it based on that logic. I'll try not to give away too many trade secrets, though, Daniel. So right now, MIBG therapy is given 3 to 5 weeks after the 3rd cycle of chemo, and stem cell rescue is mandated 2 weeks after the MIBG infusion. At our center, we've often done an MIBG detour. This is for patients who persist with high Curie scores. And what this means is that at the end of 5 cycles of induction, that first cassette, if you have a high Curie score, those patients are often shunted to get MIBG therapy at our center. And then once we get that score lower, then they come right back. It's just a detour. Then they come right back on track. And then they'll go on to jump back on the track where they get transplant, local radiation, and then their dinutuximab. Well, I guess that leads to the question, A, what's a high Curie score? And B, what the heck even is a Curie score? And thus the rest of the talk, okay? So what is Curie scoring and what have we learned from it? This right here, the 5 individuals across the bottom that you're seeing the picture of, I guess myself included, but this is the group that's really pioneered the Curie scoring that you're about to hear. Kate Mathey, again, I've talked about Kate many times. Love Kate dearly, we're great friends. It was a lot of her work in the 1990s at the Curie Institute in Paris that helped to give rise to how we do this now. So I put a special red around her because in many ways she was, you know, the foundation of what a lot of this was built upon. In fact, Kate, you can just give the rest of the talk. My colleague Barry Shulkin and Meg Parisi, 2 outstanding nuclear medicine physicians. Carrie Strebe from Ohio State. In many ways, Carrie is one of my closest colleagues. You should think about what I'm saying. You've got a physician from the University of Michigan saying that one of their closest colleagues is at Ohio State. And Arlene Nerano, who is just the backbone of our statistical venture. You know, I stole this slide from Shahab Asgharzadeh, who's at Children's Hospital Los Angeles. Shahab used this slide 10 plus years ago. I love this slide. I said, Shahab, I'm going to use this slide whenever I'm talking to folks like parents and some of our trainees. So Shahab always calls neuroblastoma the portrait of a tumor. And how do we look at it as physicians, and how do you look at it as parents and patients? Well, you can paint the portrait in many ways. You can paint it using clinical factors such as age and stage. You can paint it based on biologic factors. You know, Ami mentioned the ALK gene, the NMYC gene. But you can also paint it based on MIBG scans. Think about what I'm about to say here, is that MIBG scans is the only tumor-specific scan that I can think of. If you have lung cancer, you'll get a CAT scan. That's not specific for that lung cancer, it just shows a mass. You may get an MRI for a brain tumor. It's not specific for that brain tumor, it just shows a mass. MIBG scans are specific for neuroblastoma and for a couple other tumors that are in that same category. So Curie scoring is performed from MIBG scans. It was developed at the Curie Institute in the 1990s. The initial studies were led by my good friend Kate Mathey, again in the 1990s and 2000s. And this Curie scoring has now been incorporated into all COG therapy studies for high-risk neuroblastoma over the past 20 years. Ami showed a slightly different slide how it's done, but the body is divided into 10 regions. There's 9 bone regions. You can see they're outlined on the figure there, and 1 soft tissue region. So that means, let's say, the primary mass. If your son or daughter had a mass in the adrenal gland or in their abdomen somewhere or chest. So each region is scored 0 to 3. We add the scores up. So if you do the quick math, the maximum you can have is 3 times 10 or 30. Obviously, if you have a score of 0, that means that you've got no uptake. That's a completely negative scan. We score the bone sites 1, 2, 3 based on the factors. There are 1 lesion, 2 lesions, 3, or more than 50% of a segment. And then we score that 10th region called the soft tissue region. You can see the scoring there. 1 is 1 soft tissue lesion, 2 is more than 1 lesion, and 3 is the mass occupies greater than 50% of a region like the belly or the chest. You can just see the numbering. For example, 5, that's the pelvis. So you got a right side of the pelvis and left side of the pelvis. 8, region 8 is our upper legs, the femurs, and region 9 is our lower extremities. I stole this slide. I steal a lot of slides from folks. I stole this slide from a friend, Matthias Schmidt, in Tübingen. He actually had a great slide on doing the scoring. So this is the patient in red. You can see where the disease is. So that's 1 spot of disease in that right thigh bone or femur. So that's a Curie score of 1. Curie score of 2, in this case, the patient had 2 red spots. The patient who has 3 red spots, though, is still a Curie score of 2. A Curie score of 3 means you've got at least 50% or more of a region being involved, okay? This is how we do the scoring. If I just took some of your scans from your children right now, we could put them up on the screen, and you could probably do the scoring with me, okay? It's not rocket science, okay? So Curie scoring, at least within the children's oncology group, initially we looked at a study, we called it a discovery set, just to see how well it would work within the COG setting. So we used a study called COG A3973. Our nomenclature is a little different then. A, again, was active therapy trial. 97 meant the study was written in 1997, okay? We looked at over 1,500 MIBG scans. We went to Providence, Rhode Island, where the scans are housed. The people that you saw the picture of before, and we scored these scans. We then did a validation set. We looked to see what they were doing in Europe. They have a slightly different trial, different methodology, and a core group of us flew out to Vienna, Austria, and scored their scans. That was our validation set. Again, you got that same cassette, induction, consolidation, immunotherapy. We scored scans at the beginning of diagnosis and right before transplant, so at the end of induction. Here's what we saw. So if you just look at the impact of Curie scores at diagnosis, there's no impact on survival. So in COG A3973, whether you had a score at the time of diagnosis of 25 or 10 or 3, it didn't impact survival. The cut point we used here, a Curie score of 5, greater than 5 I should say, or less than 5, we could have used, Arlene Naranjo did the statistics. She looked at all different cut points, 10, 12, 15. 5 was selected for this slide just because it had the widest disparity in outcome. Well, the outcomes look pretty similar there. These curves, how you read them, by the way, years are across the bottom, and the survival, whether it's overall survival or what we call event-free survival, I'll walk you through that in a second. It would be on the y-axis, and you can see that everybody starts at the top at 100%, and then you can see as you get out, 4 or 5 years survival here for this study. So then we actually looked at the impact of the Curie scores at the end of induction therapy right before transplant. Same study. And now we did see a big difference. We found that the optimal cut point was a Curie score 2 or less versus those that had a Curie score 3 and above, or greater than 2. I think it's pretty sobering that for those patients who had a Curie score greater than 2 going into transplant at the end of induction therapy, you can see their long-term survival here. So it was based on this slide right here that the mantra has been over the last decade plus, you try to get down to a Curie score of 2 or less at the end of induction. Is that really true? I'll walk you through it though, okay? By the way, the next thing we did, I said that we sent a bunch of investigators out to Vienna, Austria to score their scans and see what we get on our methodology on their study. They actually sent investigators from Vienna, Austria to Providence, Rhode Island, because they had their own scoring method. So we actually crisscrossed in the air. The sad part about this whole thing was I had to stay back at Providence to greet the group coming from Europe, where everybody else on my team went to Vienna, Austria to do the scans there. Yeah. So when we scored the European study called SIOPIN NBL1, HRNBL1, we found the exact same statistical cut point. Unbelievable. Totally different patient population, even a slightly different number of cycles, transplant regimen. We still found a cut point of 2 or less was the optimal cut point. So that was our validation set. And thus, Curie scores greater than 2 are associated with inferior survival in 2 totally independent studies. Well, how about this question? Is it better to have a Curie score 2 or less? Or how about just to have a large change in score, meaning go from 30 to 5? We looked at that too. So in red here, I've got the Curie score at diagnosis, the Curie score at end induction, and then what's the percent change in score? So if you went from, let's say, 20 to 10, that'd be a 50% change. And then we looked at the absolute Curie score. And so again, absolute score at the end of induction versus change in score, which matters? Well, here's the data right here from those same studies. Patients who had a Curie score greater than 2 and greater than a 50% reduction, that meant they started with 20, they went down to a score of 5. You know, it's greater than a 50% reduction, but their score is still over 2. Their 3-year EFS, does anybody know what EFS means? You know, sometimes we talk in doctor language. EFS stands for event-free survival. OS stands for overall survival. Overall survival means your child's alive. Event-free survival means that they've survived a certain time point, in this case 3 years, and they either A, haven't died, or haven't relapsed or progressed. The events would be, let's say, relapse or progression of disease, okay? So for those patients in this, you know, the Curie score was 5, they went from 20 to 5. The 3-year EFS was only 18.8%. Ugh. As you can imagine, those that the score went from 20 to 13, so the score was still over 2, but it was less than a 50% reduction. It was still poor. Then we said, well, let's raise the bar, 75%. So if your score was still over 2, but you had more than a 75% reduction, you can see that the 3-year EFS was 22.9% versus those that had less than a 75% reduction. What's the take-home point from this? The absolute Curie score at the end of induction therapy or post-induction matters more than just how much your child's Curie score has dropped from diagnosis. And for patients getting therapy similar to COG A3973, I'll stand by it because we've now validated in 2 studies, you want a score of 2 or less to go into transplant. At our center, and many centers, will pull those patients off therapy and do that MIBG detour, or they may get chemoimmunotherapy with dinutuximab and chemotherapy to lower it if at the end of induction they have a high score. Well, I stand by this cartoon, this Dilbert cartoon. What does this all mean? You can read through it. This looks like my staff there. Is this being taped? Hopefully my staff will never read this cartoon. Be careful how we interpret the data, though. The majority of patients in COG A3973 did not receive dinutuximab. In fact, if you look back at that, what I showed you, everyone received a single transplant. Well, we're currently doing tandem transplants, and now virtually everybody's getting dinutuximab or immunotherapy. So when we stand up here and tell you we want a Curie score of 2 or less, well, that's based on single transplants when only about 20% of patients in the study we looked at even had the antibody. So what do we know about Curie scores in tandem transplants? My Ohio State friend, Carrie Strebe, just gave a talk at this at the ASCO, which was here in Chicago a month ago. And you're one of the first individuals to now see Curie scoring with tandem transplants. So it's the same cassette, induction, consolidation. There's 2 BMTs now. That's tandem transplant, radiation, and antibody. Again, scans are scored by the same group, Providence, Rhode Island. I love Providence, Rhode Island, by the way. Got great restaurants. Diagnosis and end induction. That's just my plug for Providence. So this is the distribution of Curie scores at the time of diagnosis, and then you'll see at the time of end induction. The bottom, across the bottom, it's hard to read, but you can see the numbers on the, it's called a histogram on the bars. If you had a score of 0 to, 1 to 3, 4 to 6, 7 to 9, things like that go across the axis down here. So roughly 25%, almost 30% of patients had a low Curie score at the time of diagnosis, meaning 6 or less. Approximately 60% of patients at the time of diagnosis have a Curie score that's 18 or above. In fact, the average Curie score for children in this country at the time of diagnosis is 20 out of a maximal score of 30. By the way, you should ask me, do kids that have a score of 30 do worse than kids that have a score of 20? No. Just get the score down, all right, to 2 or less, okay? How about, what have we seen at the end of induction chemo? How well does our induction chemo work? Well, our patients are generally responding well to our induction within the Children's Oncology Group. 60% of patients actually have a Curie score. This is on the tandem transplant trial called 0532. 60% of patients actually had a Curie score of 0 at the end of induction or pre-transplant. That means that they had no MIBG positive disease. You don't need to do scoring. The scan's just negative, okay, 0. And you can see how many patients persisted with really high scores at the end of induction therapy. So Carrie, Barry Shulkin, Meg Parisi, myself, we did the exact same thing. We scored scans of diagnosis and post-induction with tandem transplant and immunotherapy. And now you can see this. Again, you're some of the first folks seeing this data. Curie scores of diagnosis from the tandem transplant trial 0532. Patients with a Curie score at the time of diagnosis less than or equal to 12 actually did better than patients who had a Curie score over 12. Well, that's sobering because the average Curie score, remember what I said, was 20. Well, how should we interpret that data? I'd go back to the Dilbert cartoon cautiously, all right? Many patients with a Curie score over 12 at diagnosis actually did really well. The largest subset of patients at the time of diagnosis of neuroblastoma, with high-risk neuroblastoma, have stage M or stage 4 disease, and their tumor biology is MYC-N non-amplified. MYC-N is this gene that it's like a light switch that's turned on. Non-amplified means the light switch is off. So the largest population of patients, and many of you will have had children that fell into this, would have had stage M or stage 4 disease and MYC-N non-amplified. Those patients actually did well with a Curie score over 12. Oops, dang. Specifically, that subset had a 3-year event-free survival of 71%. It's really good. What that tells you is that a lot of the other subsets brought this curve down for patients who had a Curie score over 12. So does this mean that everybody should say, geez, what was my Curie score at diagnosis? It was 21. Dr. Yannick just showed me this curve. Ugh. No, for the vast majority of you that have, your children have stage M disease that's MYC-N non-amplified, no, that group did really well still. It was a lot of the other subsets that obviously brought the curve down. What do we find at the end of induction? Well, this is an easy one. Now it's not 2 or less. Now it's a Curie score of 0. We don't even have to do a score. It's whether your scan still positive or is your scan negative at the end of induction therapy. Patients who have a Curie score of 0 at the end of induction therapy did better than patients who have a Curie score greater than 0. So the optimal cut point, as Carrie reported at ASCO, is a Curie score of 0. If this Curie score is greater than 0, the 3-year event-free survival is 46%. And if it's 0, the 3-year event-free survival is 73%. I guess I'll ask a question that you could ask me. I was thinking about, as I was listening to the questions asked of Ami, I'm thinking, what are people going to ask me? Well, here's one. Dr. Yannick, you just showed that anybody over 0 doesn't do as well as people who are 0. What if they're a 1 or a 2? Do they do better than somebody who's a 5 or a 6 or a 10 or a 20? The answer is yes. Okay? Meaning if your child is a 1 or a 2 at the end of induction, don't despair. The cut point means that this was the optimal cut point for seeing a disparate response. That if you had a Curie score of 0 versus anything above that, that was the greatest difference in survival. A Curie score of 1 or 2 at that time point, you still did pretty good, but the difference wasn't quite as great as the other group that was over, let's say, 2. But I would say that Curie scores that are 1 or 2 at the end of induction do better than Curie scores that are 10 or 20 at the end of induction therapy. And then this one. How many of you have been through antibody therapy with dinutuximab so far? So a good portion of the group. So we looked at it. We started to look at it, and we're about to go next week. On Monday night of next week, I'm flying out to validate this question. Flying out to Providence. Do Curie scores right prior to dinutuximab therapy matter? This are the results from ANBL 0532. So we looked at patients who had a Curie score of 0 going into the immunotherapy or dinutuximab, and you can see their 3-year event-free survival is 71%, versus patients who had a Curie score greater than 0 going into dinutuximab. Again, those that were 1 or 2 didn't do poorly, they just didn't do as well as this group. Well, what does that mean? It needs validation. Look at the sample size. If you read the little thing in parentheses right here, it says Curie score greater than 0. It's only 25 patients. I'm not going to stand on a pulpit and say that everybody who has a Curie score over 0 going into dinutuximab should come off therapy. That's just based on 25 patients. Next week, several of us are meeting in Providence, Rhode Island, to look at a large subset of patients going into immunotherapy. I hope to be able to come back, let's say in a year, and say, all right, going into immunotherapy, here's what you want your Curie score to be. We hope to increase this 25 sample size dramatically, okay? And then there's this study. This is my last 2 slides or so. This group, it was in Korea. They published a study recently. 150 patients all received a similar induction transplant immunotherapy as we give in the COG model. All patients underwent tandem transplant. This is really interesting. They looked at MIBG scans at the end of scheduled therapy. So you'd finished all 3 cassettes, and what was your MIBG scan at that point? So, and then they asked 2 questions. 5 years later from the end of your therapy, what were the chances that your disease would recur or progress? And what was your overall survival? If your scan was MIBG negative at the end of therapy, your chances for disease progression was 17%. If you're positive at the end of therapy, your chances for disease progression were 17%. Interesting. Overall survival. If your MIBG scan was negative at the end of therapy, it was actually slightly lower than if your scan was positive at the end of therapy. As a parent, you should be just dang confused right now. And thus, be careful of single center studies with smaller sample sizes. Everything needs validation. However, I'm sure Kate, Daniel, Ami, Brian, these are all physicians I'm looking out in the room, have all seen these patients who ended therapy and had 1 or 2 positive sites of disease. And the take-home point that these authors stated was this, that patients did well that had Curie scores of 2 or less at the end of therapy. I have a patient right now that finished therapy almost 6-7 years ago and still had a Curie score of 1 or 2, and I just kept treating. And then after a couple of years, I just stopped. It's now been 5 years later, and the patient's never progressed. That patient actually met this definition. Patients did well that had Curie scores of 2 or less at the end of therapy. Why would that be? Because MIBG scans are stupid. And since I'm being taped, you can quote me on this. Oh, good heavens. But MIBG scans pick up neuroblastoma. They'll pick up neuroblastoma, whether it's the really aggressive neuroblastoma. They'll pick up neuroblastoma that's really matured or differentiated, turned into a less aggressive form. And thus, a lot of these patients that did well at the end of therapy, they literally had what we call a ganglioneuroblastoma at the end of therapy, this really mature, well-developed neuroblastoma that was never going to progress, okay? That's why the scans are stupid. They can't tell you, is this a really aggressive tumor still there or the more mature tumor? So this is my conclusion slide. What do we really know? It's a cautionary summary. Curie scores in single transplants. I'll stand on this. You want a Curie score 2 or less at the end of induction therapy. It does matter. It's been validated in 2 studies. Curie scores in tandem transplants. All data were derived from ANBL 0532, that COG study. Keep in mind that study ended 10 years ago. It just takes us 5-10 years to analyze all the data. The sample size was small. It was 100 patients. A post-induction Curie score may be prognostic. We're going to validate that in the next high-risk study. Prior to antibody, this needs validation. I'm flying to Providence next week to get a much larger sample size. And post-therapy, keep in mind this one. Patients with low but positive Curie scores sometimes do well. Okay? All this needs validation. The current COG high-risk study, ANBL 1531, will examine many of the questions and provide many of the answers that I've shown on this slide. So I just want to thank the following folks here. Kate, obviously, I've mentioned her several times. My colleagues Barry, Meg Parisi, Carrie Strebe, Arlene, Fran Laurie, who runs the group in Providence where our scans are. Sandy Kessel works with her, the staff in Providence. But our patients. I don't know if you can read the quote at the bottom. I'll read it for you. We're all working so hard to be self-fulfilled, individually successful, and personally healthy. And we've forgotten the real purpose and path to health and healing is to make a joyful connection. I have to admit, that's why I'm here. That's why I do what I do. That's why I'll never retire. Because every day I swear I'm making more joyful connections with my colleagues, with all of you. In fact, the other day, a father gave me this note. He wrote it out and handed it to me. I'm going to read it to you again. Affliction produces endurance. Endurance, proven character. Proven character brings hope. And hope never fails. Actually, he told me it came from St. Paul in a letter to the Romans. I said, I thought that was really intelligent. He said, no, St. Paul wrote it. But that quote, I decided to show it because it's a testimony to everybody here, to your children. The picture on the right is Kellen. Kellen was diagnosed at age 4 with neuroblastoma. He passed away this past year at age 14. Through 10, 11 years of therapy, he kept playing hockey at a fairly high level, being checked into the boards. The things we let him do, I sometimes shake my head. His parents, Jennifer and Corey, his whole family, they were special to us. And actually, I just want to end this talk by dedicating this talk to Kellen. I think many of you see on the schedule, I'm talking again in a couple hours on lessons I've learned from my patients. I'm going to be dedicating the next talk, not just to Kellen, but to all of you. Thank you.
Anyone have questions? Come up to the mic.
Good morning, doctor. My name's Amber. My daughter was treated at Children's Hospital Philadelphia. She was diagnosed at 4, received MIBG therapy at 5. She's now 10. So my question is, does the chance of the secondary cancer lessen or increase as they age?
That's a good question. It'll lessen, but I wouldn't say that you're out of the woods yet. Okay. When I think of secondary cancers, what's your first name again? Amber. So Amber, when I think of secondary cancers, I kind of divide them into leukemias and then everything else. So the leukemia, as MIBG therapy, to be honest with you, even the chemotherapy that your children have already had, as it runs through their system, they're beating up the blood cells. They're already at risk for leukemia, about a 2 to 3% rate. Leukemias typically occur within the first few years after therapy, not 10, 15, 20 years later, but typically within the first 1, 2, 3 years. Some of the other non-leukemia secondary cancers that we've seen, we've had 2 children develop osteogenic sarcoma, which is a form of bone cancer. And both children developed that osteogenic sarcoma approximately 8, 10 years out from their MIBG therapy. I've never seen anything after that. Kate, have you seen anything?
No, thyroid cancer.
Thyroid cancer, true, yeah. Thyroid cancer, obviously, too, is a risk. I have not seen any cases of thyroid cancer. Kate, have you seen it? How late out did you see it?
I think about 8 years.
8 years? So your child's out 5 years, you said, Amber? So, you know, I'd feel good about things, but you just heard me now say that we had a couple children get bone cancer. Kate had a patient with thyroid cancer, you know, in that 8 to 10 year period. I haven't seen anything ever after that, though. Okay. Kate, you're not allowed to ask questions.
I'm Kate Mathia from San Francisco, and Greg, that was lovely. I wanted, a big problem for me has been discerning whether an MIBG positive spot is cancerous or is a matured tumor. Because, as you said, the MIBG can even be taken up in ganglioneuroma at times. And we see this, first of all, in the very young children with favorable cancers that mature, but sometimes their bone spots on MIBG do not go away for a couple of years, and we don't know whether to keep treating them. And then I've had patients with very high-risk disease after MIBG and transplant whose MIBG, as you again mentioned, takes a while to go away. And I've been recommending FDG PET scans, which measure their glucose metabolism in a tumor, to see if these tumors are active. And it's reassuring if there is no FDG uptake in these spots, but I don't know if there's any evidence that that's a reliable test. And I wondered what your experience has been and what you think.
Yeah, and Kate's group has actually published on this, comparing MIBG, the sensitivity of MIBG scans and PET scans too. At our center, we've actually found this situation where it becomes Darwin's survival of the fittest, or a process of natural selection. And what the tumor is on the third relapse may not be what it was at the time of diagnosis. The ability for a tumor to pick up MIBG and be seen depends in part on how many of those channels, you remember that one picture I showed at the beginning, that it has on the outside of it. Well, as these tumors go through their own cycle, you start to pick up clones that may have less channels. They may not pick up the MIBG at all. Kate, we had a patient not too long ago that was MIBG avid for a diagnosis, the first relapse or so, and then it became negative, but the PET scan, like Kate said, picked it up perfectly well. And what happened is that tumor lost those net norepinephrine channels to pick up the MIBG, but they could still pick up the PET because it's a totally different mechanism. And thus, Kate, to give you a roundabout answer to your question, we now use PET scans at our center in patients that were previously MIBG positive, and we still think there's strong suspicion there's disease because we find that the PET scan is a really high sensitivity for picking up disease too, especially in patients that were MIBG negative. So, yes, Brian. This is Brian Kushner from Sloan Kettering. I got these docs asking me questions. Come on.
Just, I was waiting for parents to ask. We have a huge experience with MIBG positive patients whose PET scans are negative. And we consider that evidence of no active disease.
Yeah.
And we have protocols, for example, that require somebody to be NED, have no evidence of, we actually say no evidence of active disease, because there's evidence of disease since the MIBG scan's abnormal. But the PET's negative, the bone marrows are negative, and we have a lot of, although sometimes actually the bone marrow shows ganglioneuroma, the benign form of neuroblastoma. So PET scans really can be very helpful in establishing disease status.
Are you doing it, PET scans, at the end of therapy then, if you're
Not
MIBG
routinely,
negative?
but if somebody has a positive MIBG scan, bone marrows are negative, and we have strong reason to believe that the MIBG is showing a benign form of neuroblastoma, meaning the ganglioneuroma, we'll do a PET scan.
I see.
And we have patients, high-risk patients. In fact, when I give a talk later today, I'll show a scan, and many patients come to us with, quote, refractory disease, and we say this child probably does not have refractory disease.
Right.
Bone marrow's negative or shows ganglioneuroma. MIBG can have a Curie score very high. PET scan's negative, we stop therapy. So patients are being overtreated because of positive MIBG. So another thing I just want to mention is, you were going to say something?
Oh, no, it'd been interesting, that Korean study that I showed, if they had done PET scans too in those patients. Especially those patients that had those low Curie scores at the end of therapy that were still positive.
Yeah, so see those kind of patients, you might think about doing PET scans.
Right.
Yeah. Now the other thing is, I have to say about MIBG therapy. We have a huge experience with MIBG therapy. And we actually published on it, that we carry out our MIBG treatments in a regular room. We do not have a lead light room. We showed that the amount of radiation beyond the room is safe. So it's done on a regular floor, regular room. Parents are in there right from the start. They don't have to be outside of the room for any hours. They're with the child the whole time. We actually even have our lead shield, lead line shield. It's actually transparent. It's not, it's not that high, but it's transparent. So families are together. And we've had patients come from elsewhere where they didn't want to do an MIBG therapy because it seemed so difficult. And then they saw how we do it and they say, oh, fine. So just to point that out.
Our center, thanks, Brian, that's a great point too, because every center handles it a little differently, and I appreciate what you said. I've been doing MIBG therapy now for 25 years, and we've actually had to move our site. Just life changes. We had to move to a different location where we do the therapy. Where we do it now is like Brian's center. We don't have a lead line room. They wouldn't build us one in our new hospital. So we just use the lead shields. And we use the top floor of the hospital so that the radiation goes out, corner room. But we're like your center now, Brian. We do not have a lead line room.
And then we just do it on the regular floor.
Yeah, so it's done on a regular floor. We don't do it in our ICU. It's done on a regular floor. We have a great training session for nurses. We've actually worked out, Brian, all the data for what happens in a sentinel or emergency situation, how long ICU personnel can be in there. We use, like Brian does, we use transparent shields. So these are shields you can actually see through. It's like a door that you can see right through. I mentioned that our patients can't be in the room for the first several hours after therapy. How far away are they? Well, it can be from here to the chair, I guess. But you can see right through the shields. So, okay.
Yeah. Oh, maybe
Anyway,
one more
let me
question.
Let me also just say how much I appreciate Dr. Mathias and your work in terms of advancing the use of MIBG imaging, the Curie score, and the treatment. So I can think of many patients who I would say are cured because of the MIBG treatment that they were able to get thanks to you folks.
Right.
Thanks,
Okay.
Brian.
Maybe two more questions because we're still running late, but go ahead.
My son was diagnosed and first treated with high-risk neuroblastoma in 2018, and he still had a Curie score of 4 at the end of induction, and then he went and did one of the detours with 3 rounds of dinutuximab IT to bringing him down to 0. You also mentioned doing these detours. But it's still not 0 at the end of induction. Do you think you're actually affecting the long-term survival by doing that?
Yeah, so Meredith is your name, right? Yeah.
Meredith Goldsmith, I'm from San Francisco.
Yeah, I met Meredith at breakfast. No, it's a good question. If you do these detours, so you got at the end of induction therapy, you have a Curie score of 4 or 5. we typically will just try to get that Curie score down to 0, 1, or 2, and then we'll go back to transplant. In some cases, we've never even gone back to transplant. We've had a number of patients at our center that they responded so well to immunotherapy, they went from a Curie score of 4 or 5 at the end of induction to 0 after a couple cycles of immunotherapy. We just kept the chemo immunotherapy going with the dinutuximab and the chemo, the irinotecan and temozolomide. So, in fact, in some ways, it's not only a parallel path. They never come back to transplant in many of those patients. And go back to also what I said, Meredith, is that the patients who have a score of, so let's say your child's score is 3 or 4, do they do significantly? Is it a total fall off a cliff once you hit a score over 2? No, it's not. You know, it's a graded decline. So we've had a lot of patients go into transplant with scores of 3 or 4 at our center and still do well, actually. So, okay. But I get nervous when the score gets over 3 or 4, at least when we're doing single transplants. But we've done that with patients too. At our center now, if you have a Curie score 3, 4, 5 or so, we likely will do immunotherapy with dinutuximab and chemo or MIBG therapy to get that score down. If they have a rapid response, we may just stay on the immunotherapy. If they have a graded response, we may then go to transplant. So each patient is taken individually.
Okay, one more question.
Yes, Ami.
We're going to take a break too after this, so if you want to discuss. Okay.
I just wanted to follow up on that last question, because we recently published a paper, because we have the exact same question. Does this quote unquote bridge therapy or chemotherapy plus antibody that we sometimes give in between induction and consolidation, does it help at all? Does it do anything? Of course, this is looking backwards. It's retrospective data. It's not looking at it forwards, but a few key points that came out of there is we grouped patients. One, these were all patients who did not have a complete response at the end of induction. So group 1 were patients who went straight on to transplant. Group 2 were patients who got what we call this bridge therapy and moved on to transplant. And group 3 was a small group of patients who got this, after induction therapy, but, for one reason or another did not move on to transplant. And I'm sorry, group 2 was the bridge and then moved on to transplant. So anyways, a few key points that came out of, again, retrospective study was, of course, this group 2 patient that got bridge therapy were a little bit biased because they had a worse end of induction response. But what we did see was that their survival outcomes were now similar to group 1 that went straight on. So maybe there's some benefit from getting bridge is, one takeaway. And the second takeaway were when we compared patients who had what we called stable disease in the areas of metastatic disease, when we compared the patients who went straight to transplant versus those who got bridge, we saw that those who got bridge therapy did better than those who did not in the certain metastatic stable disease. So anyways, that at least meant to us that perhaps there was some benefit to give bridge for certain groups of patients. This, of course, needs to be looked at prospectively, which I think we will have the opportunity to do in the upcoming clinical trial, but it gave us some semblance that perhaps there are certain groups that might benefit from getting sort of that in-between therapy.
The upcoming clinical trial, thanks, Ami. The upcoming clinical trial, the next high-risk trial, will bring that, quote, bridging therapy up front. So now patients will be getting immunotherapy during induction. Okay.
Okay. We're going to take a few-minute break now, and we'll get back in about 10, 15 minutes. There's some snacks and stuff up up against the wall there. So if we could get everyone seated, we'll get this taken care of and get us on a roll here. Our next speaker is Dr. Morgenstern. He is the staff physician of this. It's okay. Okay. Keep going. Okay. All right. Okay, we'll get everybody here. All right, our next speaker is Dr. Daniel Morgenstern. He's staff physician in the solid tumor section of hematology oncology at Sick Kids Hospital in Toronto. He also holds the position of Director of New Agent and Innovative Therapy Program at the Hematology Oncology Department and the Director of Therapeutic MIBG Program. He is the co-director of the Neuroblastoma program at Sick Kids Children. He has received his undergraduate degree from the University of Cambridge in the UK. His research and specialty training has also been in the UK, and his postdoctoral fellowship at Sick Kids Hospital in Toronto. His research interests include immunotherapy for high-risk neuroblastoma, the use of immune checkpoint inhibitors in pediatric cancers, and the development of precision medicine approaches for solid tumors. He has been a presenter for our neuroblastoma virtual symposium for the past 2 years when we partnered with Solving Kids Cancer for our virtual events. This is the first time he's been with us in person, so it's very nice to have him. He will provide a brief update on the naxitamab trial, and we'll delve into a second presentation a little bit later. We'll do the naxitamab first, and then we'll talk about the different subsets of neuroblastoma and the possible therapies for those groups. Dr. Morgenstern.
Behind schedule, I should have been here ready to come up to stage. Okay, it's me. Right, go. Thanks very much. So I've got two separate topics, so what we've decided to do is to split these. So I'll give just the first part of the talk now, and we can discuss that, and then I'll come back to the second topic, so don't feel that you're shortchanged, we will get to it. just briefly, these are my disclosures that I do to some consultancy for drug companies, including these couple of companies that make anti-GD2 antibodies. So let's talk about the naxitamab antibody and the naxitamab trial. So some of this you've heard already, but I just kind of give a bit of background and to recap on this topic. So really what I want to talk about is antibody therapy for neuroblastoma, where we're using antibodies targeting this specific thing on the surface of neuroblastoma cells called GD2, which is a protein sugar that is expressed on pretty much all neuroblastoma cells and not expressed on most other normal tissues. And therefore, it's quite a helpful way of targeting a treatment specifically to the neuroblastoma cells. And although I'm going to talk about several different drugs, several different antibodies, the important thing is that all of these target this same molecule. So they're all targeting GD2, even if they're a little bit different. And the reason these antibodies are different is because they were either they target different bits of the GD2, different bits of the molecule, or because the antibodies were made in different cells, or the antibodies are slightly different, or they're different in how they're administered. And so these are the three antibodies that are out there in clinical use at the moment, or at least the ones that have been commercialized. There is another antibody which they developed just at St. Jude, but that's only available at St. Jude, which is a variant of one of these. And these you've already heard about from Dr. Desai earlier today. So dinutuximab is the one that probably most people are familiar with, which is the anti-GD2 antibody that has been developed through the Children's Oncology Group and is now used routinely in patients with high-risk neuroblastoma after their high-dose chemotherapy to consolidate, to maintain that response, and to get rid of any remaining neuroblastoma cells. And typically that's given us quite a long infusion over 10 to 20 hours for 4 days. You're in hospital, and as we'll talk about, it's quite significant side effects in terms of pain and low blood pressure and that sort of thing, which are actually common to all of these antibodies. Then there's an antibody called dinutuximab beta, which the name is a bit of a giveaway that this sounds very similar to dinutuximab, which is because it is, because essentially it's the same antibody, it's just for various complicated reasons, it was made in a different cell in the lab, and so technically it's a different drug product. And so that has been developed in Europe and is not used very much in North America at the moment, but is the standard treatment in Europe in the same situation. The interesting thing about that antibody is that originally it was given in the same way as dinutuximab was given, which is as an infusion over 8 hours or so on multiple days. But the European group noticed that one of the ways of reducing the side effects of the antibody and to make it easier to give was to give it more and more slowly. And in fact, what they did was ending up giving it so slowly that instead of giving it over 8 hours on one day, they give it over 10 days continuously, 24 hours a day for 10 days. And actually in some hospitals, it's then possible to do that completely as an outpatient. The patients have a little kind of plastic pump and they get given the drug continuously for those 10 days and don't need any of the morphine pain relief, at least once things are going. So that's just kind of, again, a difference of approach. And then naxitamab, which I'm going to talk a bit more about now, is a different antibody. It's still against GD2, but it's a different antibody from the first place. And it's what's called a fully humanized antibody. And this is a bit technical and doesn't matter hugely, but you'll just see on the slide here, this thing here is called CH1418 is the name of the antibody. And that CH means chimeric, which means the way that the antibody was put together was that originally it was made in a mouse cell, and the antibody then had some human stuff stuck on it so that the body, when you give it to the patient, doesn't say, oh, I've got a mouse stuff here and react against it. It's a little bit human and a little bit mouse. And this antibody, naxitamab, is fully humanized, so it's much more like the human protein. How much that actually matters, I think, is a separate discussion. So this antibody was originally developed at Sloan in New York, and until recently was only available there, but has now been commercialized through this company called Y-mAbs, and there is now an international study going on, which I'll talk about, and this antibody is now potentially available in other sites to use. And the interesting thing about this antibody is that it's given in a very different way than either of the two that I've already spoken about, which is that it's designed to be given much more quickly, so over 30 minutes to 60 minutes. The important thing for all of these antibodies is that they all have at least the same risk of the same side effects, and those two major side effects, and those parents and families who've been through this will know this very well, are pain, because unfortunately these antibodies all seem to cross-react with pain fibers. We don't fully understand the mechanism, but all of these antibodies cause pain. And The other problem is sort of allergic reactions, low blood pressure, difficulties in breathing, wheezing, cough, those sorts of issues. And so there's different ways of mitigating those with each of these antibodies. So this specific trial that's going on at the moment is designed to confirm the results of when the antibody was first developed at Sloan. And so the antibody called naxitamab, the anti-GD2, is being given together with this cytokine, this drug called GM-CSF. So for people that are not familiar with this, it sounds a bit like G-CSF that everyone will know about, but it's got an extra M in there. And the reason it's got the extra M in there is that it's designed to stimulate more than just the granulocytes, more than just the neutrophils, but to also stimulate macrophages, NK cells, a whole bunch of other immune cells that we think are important. And so the idea, which is the same thing as we do with dinutuximab, is you give the antibody plus you give this GM-CSF to try and boost the immune system and to make it work more strongly. The study is a little bit complicated in terms of exactly who it's designed to include, and it's really for patients with relapse or refractory neuroblastoma, but not for patients with progressing disease at the time that they go on the study. It's for patients with relapse or refractory disease where they've had something to get some control of the disease, but there is some neuroblastoma left over that you want to try and get rid of. And in addition to that, the neuroblastoma that's left over is only in the bone or the bone marrow. There isn't any soft tissue disease. And the reason for that, as we'll talk about in a minute, is increasingly we think it's useful to combine the antibodies with chemotherapy if you're trying to get control of active progressing disease. And this study is designed specifically to test the antibody without any chemotherapy. And that's why the patients who are suitable to receive antibody on its own have to have this pattern of disease where it's relatively under control. And for what it's worth, this indication here, this kind of slightly complicated set of criteria here, was what the FDA granted accelerated approval for this drug for back in 2020. So this study is going on at the moment. The results are kind of coming through, showing essentially quite impressive response rates from this antibody, sort of as one would expect, because we know that anti-GD2 can be effective in residual neuroblastoma. I think that the next big topic is kind of how does this all fit together? What is the context of us using anti-GD2 antibodies at the moment? And where does naxitamab fit? Where does dinutuximab fit? Where is all of this going? What's the bigger picture? And that's what I wanted to kind of go on to talk about here. So in terms of the current uses of anti-GD2, most institutions that I mentioned currently use dinutuximab plus this GM-CSF at the end of upfront treatment. So you've had your induction, you've had your high-dose chemo, and then you have maintenance immunotherapy together with retinoic acid, isotretinoin, whatever you want to call it, and then dinutuximab and GM-CSF. And that's pretty standard. Naxitamab is still being used at MSK and I think at a few other institutions. And then the big change for the future is going to be that I think we're going to see more and more use of the anti-GD2 antibody at the beginning of treatment. So as people are probably familiar with, there was a lot of excitement in the field about the results from the COG ANBL 1221 study, another big long number, but essentially a study for relapsed neuroblastoma that showed when you combined chemotherapy together with dinutuximab antibody, actually it looked like you got quite impressive response rates in patients with relapse or refractory disease. So as I'll talk about in a second, that's kind of become our go-to treatment for relapse. But because that combination of chemo and antibody seems so exciting, we're now all trying to think about ways of bringing that into upfront treatment, because obviously it's better if ultimately we can improve the outcome for our treatments the first time round. And so relatively recently, St. Jude published their data looking at combining anti-GD2 antibody together with induction chemotherapy and showed that it was possible to do it and that actually the response rates looked pretty impressive. And so there's a lot of work going on at the moment to prepare the next high-risk study for the Children's Oncology Group, and the plan is that that next study will incorporate antibody into upfront treatment. Obviously, that leaves open a whole bunch of questions which we can talk about, like how feasible is that going to be? What are the side effects going to be like? What does it mean for giving antibody on its own at the end of treatment? Does that still make sense? What about patients who relapse? What are we going to give them if they've already had chemoimmunotherapy at the beginning? A whole bunch of stuff that we can talk about if you want to. So that's kind of upfront. And then in the relapse setting, as I've mentioned, chemoimmunotherapy, so the combination of maybe dinutuximab with temozolomide or irinotecan, is now considered, I think, standard of care at most hospitals in North America for patients with relapse disease. The ANBL 1821 study is the follow-on study from that original 1221, which is ongoing at the moment. And we're privileged to have the PI for that study here in the room, my dear colleague Meg over here. And that study is testing the addition of this drug called DFMO to see whether adding that drug can help to make the chemoimmunotherapy even more effective. And then in the same way as we've combined dinutuximab with chemo, naxitamab has been combined with chemo, and there's this protocol called HITS, which is the combination of the naxitamab with chemotherapy, and that's also being evaluated and has also shown good response rates. And then, as I've mentioned, naxitamab on its own, there's this opportunity to treat with antibody on its own without chemotherapy for patients who've got residual disease in bone or bone marrow. And then the next step for anti-GD2 is, I think, where are we going with more novel approaches? And this begins to get to questions about how do we treat relapse, what's coming down the line in terms of new treatments. And we'll talk more about this in some of the other talks. But these are a couple of the more novel approaches that are going on at the moment. So the NANT group, which is the phase 1 consortium for neuroblastoma, is currently looking at the combination of dinutuximab plus GM-CSF, which actually should say plus MIBG therapy is really what that was intended to say. So the idea of combining therapeutic MIBG that we've just heard about from Dr. Yannick together with the anti-GD2. So really that should say MIBG plus dinutuximab. Those are the real two active agents. And then in this other network called the Pediatric CITN Cancer Immunotherapy Trials Network, we're testing the combination of dinutuximab, anti-GD2, together with a completely different antibody which blocks something called CD47. And most of us have never heard of that, but essentially that is a marker on macrophages, which are another type of immune cell. And the idea of this treatment is that we can boost up the activity of those macrophages, and those macrophages will then become more active and stimulated, and then will be the cells that help to kill the neuroblastoma that is labeled by the anti-GD2, by the dinutuximab. So those two studies are going on at the moment. So I'm going to pause at that point, because that was kind of a whistle stop through antibodies and naxitamab, and I'm happy to discuss any of that, and then we'll talk about the other topic in a separate talk after lunch. Mm-hmm. Any questions about that?
Yeah, bring your questions.
I do. Again, Megan from CHLA, quick background that can hopefully provide some context to the question I'll be asking. My daughter, Ella, she's 4, was diagnosed at 2 and did induction chemo. It cleared in all but one spot, progressed in one spot. Then we enrolled her on the study that you had just mentioned that Meg is responsible for, and she cleared after 2 cycles. We did that for 17 cycles with the DFMO arm. My question is, whether it be natuximab or dinutuximab, has there been any research or any studies that are in discussions of looking at tandem transplant versus doing something like Dr. Yannick talked about, doing a bridge for some folks, but not even continuing on with transplant, continuing on with this chemo immunotherapy and the benefits. I know, as doctors, you don't want to do a trial that's going to do any harm and potentially, have a negative impact, but what are the discussions on doing something like that, a study like that?
Yeah, so that is a great question. Actually, is one of the topics that I'm going to discuss in the second half of the talk when I talk about risk stratification within high risk. Briefly, I think the challenge is that we know that the treatment we give at the moment for high risk neuroblastoma is very toxic, and we all worry about the toxicity, especially of the high dose chemotherapy and especially of the transplant. We're all super excited about the idea of using more immunotherapy because it feels like that may be an effective way of treating neuroblastoma. The challenge is how to implement that into a clinical trial, and we'll talk about that in the second talk, but it's really a challenge to not do harm in making outcomes worse by doing something wrong, at the same time as obviously trying to improve things by reducing toxicity. But let's come back to it in the after talk. Yeah.
Any other questions? No, that's it? Okay. All right. Thank you, Dr. Morgenstern. Our next presentation is Dr. Yannick again. He, like I said, he's been with us a couple of times, and I always enjoy when he does his presentations. And rather than being like heavy on the medical side and the science side, he said he had done a talk, and I said, I think this would be a great opportunity to speak to the parents about this particular topic. And he presented this to me, and I said, I think this would be great. And it's Lessons Learned from My Patients. Dr. Yannick.
Well, thank you, Pat. This talk, I prepared it last year, but really the talk has been 30 years in development through my career. I look out at the physicians that are here, though, with Ami and Daniel, Meg, Brian, Kate. I think any of us could have given this talk. And as I said in the last talk I gave half hour ago, that this talk is really dedicated to all of you. So, by the way, you got to love that first line from our boy Jackson. Tell everyone who knows me hello, tell everyone who doesn't know me hello, and tell everyone who doesn't know me that they will soon. That's the essence of our patients. Our patients are just, they've got that gift of life. I always feel, the one thing I've learned doing oncology therapy is that as adults, what do we focus on? We focus on remission, relapse, disease progression, mortality, death. Our kids don't focus on that. They focus on life. When can I go play? Sorry, can I go play Little League baseball again? Can I go to the prom? Can I ride my tricycle? They're focusing on living. And my last slide actually says we need to be more like our kids. Our kids focus on life. So that's me. That's our children's hospital at the University of Michigan. I always like to try to use a picture that's 10 years younger than I really am. In preparing this talk, I wasn't even sure where to start. And this is my office. On the right-hand side and left-hand side, you can see all the memorabilia and stuff there. On the back wall, I don't have my license in my office. These are two pictures from my dad. My dad's 93 years old and still painting. This is a fireworks scene. It's this thing right here. That, as I was trying to come up with, how do I start this talk? It's this frame right there, and I looked back and I said, I'm going to show it to you. There it is, blown up a little more. And here it is right here. This came from a patient named Lita, who did not have neuroblastoma. But she gave this to me during the course of her therapy. Read what it says. It should be a model for our lives. Own your own days. I don't even have to look at it. I've got it memorized. Own your own days and name them. Every one of them, or else the years will go by and none of them will belong to you. When I think about lessons learned from a patient, I can start by just looking right behind my chair at this frame picture from Lita. So, in terms of lessons learned from my patients, we have a lot to learn as a community, we have a lot to learn as parents, we have a lot to learn about ourselves. We need to be more like our children. So I'm going to walk you through all four of those things right now. We have a lot to learn as a community. I'm going to start with the good. There's good in us. And this quote from Diana. Diana's son Noah had neuroblastoma. He's age 5. And I love Diana's quote. People care, they just need to know what to care about. It was about, I'm losing track of the time, it was about 8-10 years ago. I wasn't on call, but I received a page, and it was just a number, 248 something. So I call it, and it's Diana, Noah's mom. Noah had been fighting neuroblastoma for several years. He has progressed. He was now on hospice palliative type therapy. It was early November, and I recognized the voice immediately. Diana, what's up? She goes, Dr. Yannick, can you come to my house? This is a weekend, a Saturday in the middle of November. I said, Diana, what's up? Is he doing okay? She goes, can you come by? I knew I lived about 8-10 miles from Diana and Noah, so I drove there. I walked in the house, and here was the scene. Noah was sitting down in a triangle with his mother and his aunt in a circle, I guess, with a stack of cards and letters and gifts piled up in between them. I said, Diana, what is it? She took me by the arm and didn't answer, and she walked me to their garage. She opened the door from the house into the garage, and there were stacks of boxes from floor to ceiling around the entire perimeter of the garage. She said, that's this morning's shipment. I said, what does that mean? She goes, it means there'll be a shipment this afternoon. I said, what does it mean? Here's what it meant, is that Noah's aunt, Diana's sister, had put out on Facebook 1 week earlier that Noah was dying and wanted Christmas to come early. She put it out on Facebook. I asked Diana at that time, I said, how many cards and envelopes do you have gotten in the past week? 250,000. Noah had received 33 Congressional Medals of Honor for people saying that Noah was the real hero. He received a handwritten letter from Barack Obama, not a form letter, a handwritten letter. If anybody here works for Facebook, this is an unbelievable plug for Facebook. Noah, virtually every sports star, just name it, LeBron James, go down the list, sent a basketball, a baseball glove, a football. Noah's dad loved the full-length picture of the Dallas Cowboys cheerleaders that came all signed. Noah died 3 weeks later with 1.25 million cards and gifts around him. If you think that's good, it's good, but it's a little sobering. At the same time that this happened, there was a young gal from Flint, from a family that didn't have many means. Same age, same disease. She died one day apart from Noah. Nobody knew about this family. Nobody knew how poor this family was. We actually had to raise money from all of us just to pay for the funeral. So here you've got one child dying with 1.25 million cards and gifts around him, and another one dying with literally nothing, where you have to scrape just to get money for a funeral. And thus, Diana's comment. It's going to be hard, by the way, guys, it's going to be hard for me to give this talk. And thus, Diana's comment, people care. They just need to know what to care about. And thus, I've run into this during my career. Steve Arzeman is captain of the Wings. The Wings are great back in the late 90s, early 2000s. Every Stanley Cup game, Steve Arzeman would call one of our patients at Mott Children's Hospital on the way out of the dressing room, telling them that the last person he wanted to talk to before getting on the ice was one of our children with cancer. Amazing. The Fab Five, they have a good and a bad reputation. Juwan Howard, a part of the Fab Five, is now the coach of the University of Michigan basketball team. If you're on scholarship at the University of Michigan, every month you have to visit the Children's Hospital and spend time with the kids. The Fab Five didn't do that. Spend once a month in the Children's Hospital. They spent every day. They took under their wing a young boy named Randy. They brought him to games, home games, away games. When Randy died from lymphoma, the pallbearers for the funeral were the Fab Five. Juwan Howard gave the eulogy. People never change. He's still the man he is today as he was as a college student. Lou Holtz, when he was quarterback, when he was coach at Notre Dame. You know, I'm a rival school of Notre Dame, but I'm a huge Lou Holtz fan. One time I was seeing a boy when Lou Holtz was the coach of Notre Dame, and I was examining him. He had Notre Dame undershorts on. He said, "Are you peeing in those, or what are you doing?" He said, "No, I hate to tell you, Dr. Yannick, I'm a big Notre Dame fan." So I walked out of the room. I said, "All right, let's just do this." And I turned to our PA, Lisa Ezzo, and I said, "Let's just call up information." I didn't know anything about the Notre Dame University, other it's in South Bend, Indiana. We call information. It's in the old days before iPhones. 313-555-1212. Give me information for Notre Dame or for South Bend, Indiana. Yes, give me Notre Dame University. Give me the athletic department. Give me the football department. I'll send this lady answers. And she says, "Hang on a second." Lou Holtz comes on the line. Literally within 2 minutes of not knowing anything other than Notre Dame University is in South Bend, Indiana, I'm now talking to Coach Lou Holtz. He says, "Put the kid on the line." The kid's in clinic with me. I walk over, "You've got a phone call." He looks and goes, "Dad, it's Lou Holtz. Like, how did this happen?" Coach Holtz sent for the family, brought them to Notre Dame, put them up in his house for the week. It was a spring. So he put them in his house for the spring game, made him an honorary captain. He designed plays for the team. They ran one of the plays during the year and scored. The young man eventually died from progressive disease. Coach Holtz went to the funeral. He then sent me a letter. "Dr. Yannick, if you have any more Notre Dame fans at the University of Michigan, don't ever hesitate to send them my way." People are amazing. I'm truly blessed to not only meet you, but to meet some of these other folks during my career. But we have a lot to learn as a community and sobering. Miguel Cabrera is our star baseball player at the Detroit Tigers. In 2014, Miguel Cabrera signed a $248 million contract, 8-year contract with the Detroit Tigers to play baseball. The Children's Oncology Group is the world's largest pediatric cancer organization. COG sponsors many of our pediatric cancer national trials. Doug Hawkins, who's the medical director for COG, sent me this slide one time. It shows the funding. Hang on a second. It shows the funding for the National Cancer Institute for COG in millions of dollars every year. Across the bottom is years, going out to 2019. In red is the funding from the National Cancer Institute or the federal government to run our clinical operations for the clinical trials that your children are being treated on. In blue is the funding for statistical operations to analyze all these results for these clinical trials. You can now see how much the federal government gives. You know, you're looking at 25, 30 million or so each year. Here's Miguel Cabrera's salary. Miguel Cabrera is making more in 1 year than the federal government is funding for the Children's Oncology Group. Tom Brady, 45 million. Mike Trout plays for the LA Angels, 37 million. LeBron James, at least LeBron James is making the same amount of money that the NCAA is funding for clinical trials for children's oncology. This slide is sobering, folks. It really is. Lessons learned from my patients. We have a lot to learn as parents. One of the wisest patients I ever had died a year and a half ago. His name is Johnny. You're going to actually hear his voice in a second. The wisdom of Johnny, as I say. Just read this quote. And I want you, if you're here with your spouse, think about this quote closely. The biggest influence in my life has not been how my parents treated me or how they treated my siblings, but how they treated each other. I watched and learned. If you want to see how healthy a family is, just watch how the mom and dad treat each other. You can learn a lot just by watching them walk into McDonald's. And what he was saying was this. As parents, we're the role models for our kids. He actually went on to say, you know, if the dad is walking ahead of the mom, opens the door going into McDonald's and lets it close, you're teaching your son, your daughter, how to treat their spouse when they're older, their close friends. If the parents are walking arm in arm, hand in hand, This is a 14-year-old boy who's telling me this. Not my dad, but a 14-year-old boy. And thus, the wisdom of Johnny. I don't know if this is going to come out, but Johnny had unbelievable, he had a form of leukemia. About a month before he died, I was asking him questions, and actually, I said, do you mind if I just tape what you said? I want to play. You may have to turn up the microphone. I want to play the question I asked him. I asked him, what are your hopes and dreams? I want you to hear his answer from a 14-year-old boy.
What are your hopes and dreams? Not for this week or next week.
I would have to say that my hopes and dreams would be not so much to always be the best person, but to at least try to be the best person that I can be. Because you can never always be the best person, and it's never going to go that way. And you can't help that. That's the way life is going to be. So as long as I know and I let the people, make sure the people around me know that I'm trying my best for them and for me and trying to be the best person, then I think that's enough to count as being the best person.
How can you top that from a 14-year-old boy? Johnny died a month later. Around the time of his death, he said, I've reached my life goals and dreams. And I said, what do you mean, Johnny? He said, I now think and realize I've been a really good person in my life. By the way, he has to go home on hospice. He said he didn't want to ride in the back of the ambulance. He wanted to ride in the front with the ambulance drivers. They came up to get him, and as he was walking out, they said, hey, do you mind if we stop off at Dairy Queen on the way to my home? Communication gaps. Lessons from our patients. The problem with big people, this is from Trevor, 4 years old, one of our transplant patients. The problem with big people, even my mom and dad, is that they always think they're the center of the world. It's from a 4-year-old boy. This picture here is Taylor Lewan. Taylor Lewan is now an NFL football player. I think he still plays for the Tennessee Titans. He would come and visit Trevor on those monthly visits that I said the scholarship players had to do at the University of Michigan. Well, here's the communication gap. I'm in Trevor's room. At the time, Taylor Lewan throws open the door, saw 6'8", 300 and something pounds of him. Taylor Lewan, U of M offensive lineman, to Trevor. Hey there, little guy, do you know who I am? Trevor's response, right with me there. Heck no, do you know who I am? And thus, Trevor's first quote, the problem with big people is that they always think they're the center of the world. We have a lot to learn as parents from our kids. How about this one? On rounds from the other day. This is one of our pediatric residents at the University of Michigan. And we do these family-centered rounds where the house staff, the attendings, the families are all there, and they go over the morning case. There's the vitals, the labs, and so forth. So the patient presents this, or the house officer presents this. The next patient is a 10-year-old male who suffers from Down's syndrome. By the way, it's Down syndrome. The boy is listening. Excuse me, I'm not suffering. I'm actually pretty happy. Again, our communications as physicians sometimes is pretty marginal. In fact, I just wanted to show you this study. You're going to start seeing several studies talking about communication now. This study was published several years ago. It looked at 52 patients with metastatic cancer. They were presented 2 options. One was hospice, one was life-ending therapy, palliative care. A 34-item questionnaire was given to the patients. And here's the responses. So again, everybody had end-stage disease. They were presented, we have 2 options for you, hospice or give you some extended chemotherapy to kind of keep things going. One patient was not aware he had cancer when they answered the questionnaire. 3 patients thought they were in remission. 33 patients thought the goal of further therapy was to cure their cancer. 11 patients thought the goal of therapy was to palliate symptoms. They got it right. That was the only 11 out of the 52 that got it right. 5 patients indicated they had talked about hospice with their doctor. No, all 52 had. Only 5 could answer the questionnaire correctly that they had talked about hospice. That meant the other 47, we never communicated it properly to them. Ugh. 33% felt they knew very little or nothing about their prognosis. Very sobering study on the inadequacies of our communication to you. Well, the reason for that is we have an optimism bias from physicians. Ken Kittich, who directs our palliative care team at the University of Michigan, has a great line: when in doubt, we tend to err on the side of optimism. You know, to all my physician colleagues, we've all been there, talking to these families. When in doubt, we tend to err on the side of optimism. Well, I want you to look at this study. This is a study that came out of, I believe, MD Anderson. They had, again, 100 patients with advanced cancer. All 100 patients were asked to view 2 videos. One where the examiner sounded more optimistic, and the other where the examiner's tone was less optimistic. Videos were filmed in the exact same environment. It was the exact same posture they had to use. They were actors who were presenting it, and the exact same statements. The only difference was the tone. The patients were then used a 5-item validated tool to determine compassion scores. You can already guess the answers. Higher compassion scores were consistently given to physicians presenting a more optimistic than a less optimistic message. Consistently. Physicians delivering the more optimistic message were more consistently viewed as trustworthy than those presenting the less optimistic message. Think about this, what you want from us to be telling you. Well, we're very similar to you. Patients want from their physicians honesty, compassion, empathy, and optimism. I'm sure you all do. As physicians, we want to be viewed as honest, as compassionate, to be able to provide hope to our patients. And thus you start running into quotes like this from a family that came to talk to me the other day. You all want an optimism bias. Dr. Yannick, we want you to be open and honest with us and honestly tell us that our son can be cured. I think this quote right here is almost the essence of my interactions with families every day. We want honesty. Tell us everything. But we want you to honestly tell us that our son's going to be cured. Okay? Anybody know what agape means? Anybody? Anybody Greek? Agape is the Greek term for unconditional love. You know, for many of us, agape is that unconditional love from the parent to the child. But what if it went the other way around? How many of us actually think about the fact that there's unconditional love from our children back to us? Cameron was a young boy. He was 16, multiply relapsed leukemia. After his 3rd or 4th relapse, we met with Cameron. CJ, he went by, and his parents. And we didn't have anything else to offer. He was going to go home on hospice therapy, but he never had a Make-A-Wish. I'm on the executive board for State of Michigan's Make-A-Wish. So I said, Cameron, I've got connections. I'm going to call up the leadership. We'll get you a Make-A-Wish quick. I called up Make-A-Wish and said, this boy has maybe 4 weeks to live. Can we rush through a Make-A-Wish? Yes, we'll do it for you, Dr. Yannick. We'll do it for CJ. They met with CJ literally the next day. A week later, I talked to Make-A-Wish. What's happening with the wish? We're working on it. 2 weeks later, working on it. 3 weeks later, we're working on it. 4 weeks later, CJ died. I go to the funeral. Make-A-Wish was there at the funeral. I said, what happened? They said, the wish hasn't happened yet. CJ's wish was to give back to his parents. He didn't want them to know what his wish was. A week after CJ died, Make-A-Wish showed up at his house, and they redid the entire parents' bathroom and bedroom because CJ wanted his parents to have that from him as a gift of thank you for all that they had given him over the time that they cared for him. That's truly agape. I think many of us know the 5 stages of grieving from Kubler-Ross. There's denial, anger, bargaining, depression, acceptance. There's now a 6th stage. Anybody know what the 6th stage is? It's finding relevance, purpose. And that's why you start running into Alex's Lemonade Stand, you know, St. Baldrick's Foundation, Chad Tuff at our center, a number of childhood cancer funds. It's what many of us do, golf outings, things like that, to find relevance in the life that our child led in the journey and battle they fought. Well, typically this stage is reached by the parents after the child has died. This is a talk on lessons I've learned from my patients. And thus, what if the child reaches this stage before the parents? This is from Lawrence, from our center. He's 15-year-old. Does anybody know what this picture is of? Anybody recognize who these people are? I see some people shaking their heads. Shout it out. Yeah, you two, exactly. That's impressive. That's Bono on the left, or to the right, I should say, of Lawrence. Lawrence is in the young boy with the soccer jersey. Lawrence had a glioblastoma multiforme, a terminal form of brain cancer. His make-a-wish was to meet U2. U2 was on tour in the United States. Make-A-Wish approached Bono and U2 and said, we got a boy who'd like to meet you for the Make-A-Wish. They said no. I didn't stop Lawrence. What Lawrence told Make-A-Wish is that he wanted to donate his entire Make-A-Wish funds to U2's fund. I think it's called One World. It's for poverty and hunger in Africa. He donated his entire Make-A-Wish to U2's foundation. This got back to U2 during their tour, that they had turned him down in the selfless act that this 14-year-old, 15-year-old boy did. They called up our center and said, can we talk to him? They said yes. Not only did they talk to him, they brought him on tour. They brought him on stage. In the last remaining months of Lawrence's life, he raised personally $100,000 for U2's foundation. Not as parents, but as a patient himself doing this. Truly a tribute to all of our children. This is one of the most influential studies ever reported. It was called Coping with Cancer. It was done 15 years ago, and it was really a quality of life study. It was a prospective, multi-centered, multifaceted trial. This Coping with Cancer study had a lot of different sections and subgroups to it. But one portion of the study examined a patient caregiver's assessment of their life expectancy and how they came to that conclusion. It asked 229 patients. Everybody had cancer, and the life expectancy was less than 6 months. It was a simple study. How long do you think you have to live? And what is the source of your estimate? All right, and then they analyzed overall survival, the frequency of hospice use, the location of death. Everybody had terminal cancer, everybody did die. These are the results. Only 11.9% of patients estimated their life expectancy within 3 months. 39% accurately estimated their life expectancy within 12 months. Patients who reported their physician as the source of their estimate were 2.5 times more likely to have an accurate estimate. I guess that means we're conveying something correct. Patients with inaccurate estimates of life expectancy were less likely to receive hospice care and more likely to die in an ICU setting. What hit me from this slide, from this study, isn't this part right here, it's the next slide. As physicians, we may have less influence than we think when talking to you. And I think as physicians, maybe this talk isn't to you as parents. It should be to all the physicians here in this room. So the basis for the patient estimates, 229 respondents, 70% said that their basis for the life expectancy estimate was based on their own personal beliefs. Only 18% said it was from their oncologist, talking to their oncologist, religious beliefs, and other. But then when they broke it down by demographics, racial and ethnic groups, look at this. Both whites and African Americans, their life expectancy estimates and what they made their their thoughts on were based on their own beliefs, 72 to 65% of the time. How about this one? 21% of whites made their estimate based on talking to their physician. Not one African American respondent made their estimates based on talking to their physician. Religious beliefs, 2% for Caucasians, 35% for African American respondents made their estimates based on their religious beliefs. Regardless of race, over 80% of respondents did not use their physician as the source for their response. What that tells me when I saw this study was that, there's a communication gap. We're not communicating properly with you, but we're probably not even the ones you want to listen to, okay? With minority populations, the gap is wide. Religious beliefs, I've not learned about this, carry huge impact. We as MDs can do better, a lot better. Our communication has to improve with you. When in doubt, this came from one of my colleagues, bring in the family's pastor. This actually happened the other day. We had a family that was waffling between hospice and further therapy. And knowing this data, I actually said, I knew they were a religious family. I said, can we bring in your pastor? We met with the pastor for the hospice discussion. The pastor then met with the family and they made the decision, okay? So studies like this can impact even our physicians. So let's talk a little bit about religion. This is often a taboo topic. Lessons I've learned during my career from my patients, the impact of faith on our patients and families. This came from Stephen, who was in our ICU with, he had this erosive fungal infection in his esophagus, his lungs, multiple places. And I asked him one time, I said, how do you handle it? He said, faith over fear. He died 1 week later. So I want you to look at this study, the impact of faith on our patients and families. Religion, spirituality encompass a wide array of beliefs, feelings, and practices. Go back to the same coping with cancer study. I said it was a multifaceted study. They actually looked at the impact of religion in patients with cancer and families going through this. The data are clear. 88% considered religion to have some level of importance. 47% felt that their spiritual needs are minimally or not met by their religious community. 72% felt the spiritual needs are minimally or not met by the hospital staff. And virtually they all agreed that higher spiritual support increased the quality of life. This study was published in JAMA. They asked patients and then their corresponding physicians to rank the attributes of importance at the end of life. You can see the patient column right here, and then the physician column right here. And then these are the attributes that they are asked to rank. Well, just look at some of the disparity. In fact, the number 2 attribute listed by patients was being at peace with God. The number 5 attribute was prayer before death. This is from 340 patients. That alone tells me the impact of faith in religion, all types of religion, on what you as parents, what our children, what your families go through. I also told me the disparity that we have between what physicians estimate was important. So you can see that for being at peace with God, only 65% of physicians felt that was important compared to 89% of patients. That's a very sobering slide. Not for you as parents, but for us as physicians. I only have a few more slides here, 3 or 4, but I have to share this one with you, my Championship Parenting Award, because many of you have been in the situation I'm about to say. I was in our clinic not too long ago, husband and wife sitting there, we've all seen it. Child has a dressing on over their line, their port, whatever. The nurse is trying to take it off, and if you've done this to our nursing staff, the mom is screaming at the nurse. She can feel the pain. Stop. Put more of that detach-all on. She can feel it. Don't hurt her. Don't hurt her. And the child's crying and screaming. Stop, stop, stop. The Championship Parenting Award didn't come from the mom. It came from the dad who just sat there like this. Finally, dad, this wasn't my patient. I was just close by, so I watched the whole thing. It was in our infusion room. The dad turns to one of our nurses and said, can you hand me a stack of Band-Aids? And they handed the dad a stack of Band-Aids. He's sitting next to his daughter now, and he puts a Band-Aid on his forearm. He says, pull it off. She goes like this. He goes, pull it off. Pull it off fast. Rip it off. Puts another Band-Aid on. Rip it off. Puts another one on. Rip it off. Turns his arm over. Pretty hairy guy. Puts 2 Band-Aids on. Rip them off. They rip them off. Now the daughter's laughing. He turns to his daughter and says, now it's your turn. He turned to me because he saw me watching, and he said, these Band-Aids are just a start in the learning that my daughter was going to go through. If you remember that quote I gave her from my first talk, affliction brings endurance, endurance brings proven character, and proven character brings hope. Band-Aids were just a start. That was my championship parenting moment. And thus, what I've really learned from my patients is what you all know. It's the resiliency. If I could characterize one word, it's resiliency. You know, I asked this boy, Andrew, one time, how do you handle adversity? He said, with humility. The picture is Doug Brown from the Detroit Red Wings. They had a skate-a-thon with the Detroit Red Wings. Andrew had osteogenic sarcoma, bone cancer. They were going to actually amputate his leg on a Wednesday. The skate-a-thon was on a Tuesday night. He said, Dr. Yannick, I won't do anything stupid. He was a really good skater, one of the best hockey players in the area. He asked if he could skate one last time before we amputated his leg the next day at this Detroit Red Wings skate-a-thon. Basically, the wings are out on the ice and you could skate with the wings. It's a nice thing to do. Andrew goes to it. The next morning, he's in pre-op. I go to him. I said, how did the skate-a-thon go last night? He said, it was great, Dr. Yannick. I know I'll never skate again, but it was just incredible. I skated with Doug Brown and Brendan Shanahan the entire time. We just talked for 2 hours. The 2 hours went by, and we were just skating in circles. And I said, well, Andrew, did you tell them about you were having your leg amputated the next day? He said, no. Why would I want to bother them with my problems? Think about that, guys. How many of us would do that? You're having surgery the next day to have your leg amputated. You're skating with somebody for 2 hours, and you don't even mention that to them. It's resiliency. It's the courage that our patients, our children have. And thus, the gratitude circle. Jared, also a hockey player, we have a lot of hockey players in Michigan, died last spring. And he was in the hospital for several months battling leukemia, had a couple transplants. At the end of it, I asked his mom, Tracy, I said, if there's one thing you could pass on to us, what would it be? She said this line. She said, we are so grateful for the care our son received. However, the gratitude goes both ways. And thus, the gratitude circle. I know that we appreciate when parents thank us, but we don't ask for it. But I think you should expect out of us a gratitude circle, us the physicians. I think you should expect out of us that we tell you how grateful we are to be caring for your children. And I tell our trainees, our fellows, I said, it's simple. At the end of a clinic visit, just say, Mr. and Mrs. Smith, and Miss, Billy, whatever, it was great to see you. I'll look forward to seeing you again. It takes 5 seconds to do. I believe strongly in this gratitude circle, not from you to us, but from us to you. And thus my last slide. I was walking out the hospital at Mott Children's Hospital at the University of Michigan the other day, and I'm coming down the elevator, and on the elevator was a boy, just so you can picture him, he wasn't my patient again, he was 8, 9 years old, long blonde hair, clearly not a cancer patient because he had hair. There's 2 wheelchairs, one the boy's in, the other one is a wheelchair with all the suitcases. You've probably all done this, used a wheelchair for load up your suitcases. And then on top of that, they had a thing carrying the oxygen. So he was on oxygen, the mom's pushing these 2 wheelchairs. She couldn't do it all. So I just offered to take and push her for them. She said, great, that'd be great, we're just going to the parking lot here. So we walk out of the exit to the hospital and we face the setting sun. And this boy looks up, he says, stop. And so I stopped, his mom stopped. He says, just stop. And all of a sudden he jumps up out of the wheelchair and says, "Hello, fellow humans, did you miss me?" So he he walks out of the hospital. Turned out he'd been in the hospital for a month. And he just walks out, "Hello, fellow humans, did you miss me?" I think that's the great line. How many of you would have that thought when you walk out of a hospital to say something like that? And thus, the final lesson, we need to be more like our kids. I want to thank each of you, from myself, from our entire team at our center at the University of Michigan, but from all the physicians here across the country that are taking care of your children. And just how honored and grateful we are to have been part of your care. Thank you. Actually, can you guys just stop clapping for a second? I'd like everybody in this room to stand up. I don't think I've ever done this in a talk before, but what the heck. So if everybody could stand up. I want you to start clapping again, but don't clap for this talk, just a talk. I want you to clap, look around you and clap for each other, okay? Thank you.
Does anyone have any questions at all, or feelings or thoughts or sentiments you'd like to share with Dr. Yannick, or grab him in the corner and give him a big hug? You have a, would you want him to come and talk on the microphone?
My experience, a lot of people like to sugarcoat this whole thing. There is no sugarcoating with my situation. You know, I say what most people wouldn't say. I might be, most doctors see me and they be like, "Oh Lord, there she go," and turn the other way, because I am a difficult parent. I question and I push the envelope, because at the end of the day, that is my kid. I don't resent any doctors, or, you know, are never really mad at any doctor, because I know you guys have a lot of patience and only a small amount of time to spend with each kid. But it seemed like at some point in my life, well, most of my daughter's life, since she was diagnosed at 4, now 14, I put on a lot of hats. It seemed like I was the doctor, the nurse, the mom, the caregiver, the everything. And it was very exhausting. When she relapsed, I was the one who found it. And I was pushing and saying, "Hey, something is wrong, something is wrong." And it was like, as a parent, it was made to seem like I was crazy, like, "Oh, she's okay, just take her home and give her this antibiotic." And it was until I went back and said, "I'm going to really show you crazy unless you do X, Y, and Z for my child." It was then they decided to do something. And they were like, "Okay, we'll be back in 30 minutes with this ultrasound result." 30 minutes turned into 3 hours. And it was like a matter-of-fact thing when they came back in 3 hours, like, "Hey, your daughter's cancer back. Get her to this hospital. See you later. Sign this checkout form." And it's like, what do you do next? Everybody's telling you you're crazy, you're going on the internet, trying to find out where you need to go. So my thing is, we know our kids a little bit better than the people around us that have the PhDs and stuff like that. And we know you went to school for X amount of years. I just want to say, listen to the parents sometimes. Even if it comes back negative, that gave us a peace of mind to say, okay, it's okay. We would go home that night and sleep a little bit better, knowing that you took that little bit of extra time to run that test or do that urine sample. And you know, that's all I want to say to the doctors and physicians in here. Just hear us out. We may be a little bit crazy. I may be a lot, but we always know when something is really wrong with our kids. And we don't want to be that parent that has to come in there and battle with you every time to do something with our kids, because every side effect that is listed per drug and what's supposed to not happen, those things actually happened to my kid. And it got to the point where the doctor would come in and say, hey, I know she's ready to go home, but do you think she's ready? Because every time I knew if something was wrong and it was about to happen. So just indulge us a little bit, even though we may be a little crazy.
Your name's Kim, right? Now, I met Kim also after my first talk, and Kim, when you were talking there, I have a feeling that many parents here in this room, you were voicing their opinion. You were speaking for many parents in this room. My rule of thumb I have for our fellows that are going through training is, I have one mantra for them. Show the patients, the families, that you care about the care that you're giving them. And if we can't make you feel that we care about the care we're giving you, then we're not treating you right. One of the roles we serve as a physician is not to give chemotherapy, dinutuximab to your child, do transplant. It's to serve as an educator for you. Your eyes, our ears, and our hands for that child. We're not there 24/7, you are. So it's our job, you know, I tell our trainees again, it's 50% of our job is to educate our patients, parents, and caregivers so that they know what to watch for, so they know what to do when things arise. Because you have to recognize that there are, again, our eyes, our ears, and our hands. You said a lot, Kim, that kind of hit me, and I thought you were going to ask this at the end. Dr. Yannick, I'll just ask it for you. How do you want us to treat you? Meaning, as a parent, Dr. Yannick, how do you want us to treat you? I thought of that as Kim was talking because I want you to be tough on us. I actually want you to be really tough on us. I think you expect the best out of us. I just ask that you do it with kindness, okay? Kindness and humility. But you expect the best of us, and we owe it to you to give us your best. So.
Anyone else have any thoughts, comments? Nope. Thank you. Thank you, Dr. Yannick.
Thank you.
We're ready for lunch, so if you want to go into the junior ballroom, you can grab your lunch now. And we'll be back in an hour. Can we have everyone's attention? We're going to go ahead and start the afternoon session. Dr. Morgenstern is going to do his second presentation, and it's going to be on the subsets of neuroblastoma and possible treatment options. So Dr. Daniel Morgenstern.
Okay. Ready for the noise of the microphone? Okay, good. Welcome back, everyone. Hope you had a good lunch. So, going to start with a test to see how much everyone can remember from this talk that I gave an hour ago. Yeah? So I'll go through it. I'll ask individual people. If they get it wrong, then you get a forfeit. If you get it right, then you get a prize. We're not going to do that. Don't worry. So, what I was going to talk about in the second half of the talk, and now a separate talk, is this idea of risk stratification within high-risk neuroblastoma. Okay? So, first of all, what is risk stratification? So, risk stratification is the idea that we can try and predict upfront how a particular patient's disease is going to behave, and then use that information to decide how much treatment we need to give. And it's really critical in neuroblastoma because neuroblastoma has such a massively broad range of appearances, of outcomes, and of need for treatment. And you've all heard of babies who can get neuroblastoma where they maybe just have a small tumor. Maybe they have even metastatic spread to the liver, something called 4S or MS disease, that can get better on its own, doesn't need any treatment, through to other babies or children who need a little bit of chemo, other patients who need a bit more chemo, through to patients with high-risk disease. And those of you who've gone through that know that that involves a lot of different combinations of chemotherapy, surgery, radiotherapy, et cetera, et cetera, et cetera. So it's kind of one of the founding principles of neuroblastoma treatment that risk stratification is absolutely crucial to try and predict how much treatment an individual patient needs. And here's a bunch of papers. So in terms of risk stratification, I think the important and easiest way to think about this is to think about high-risk disease and not high-risk disease. And there are a bunch of factors, including the age of the patient, the stage, which is it in one place or has it spread elsewhere in the body, and crucially, the biology of the tumor that determine whether the neuroblastoma is going to be considered high risk or whether it's going to be considered non-high risk. And the long and the short of this is that at the moment, if we have a patient who's diagnosed with high-risk disease, we kind of know from the outset that we need to do sort of everything in terms of the treatment modalities that we have available, that whole combination of chemo, radiotherapy, surgery, et cetera, et cetera, et cetera. Whereas if you have non-high-risk disease, it becomes a lot more complicated because then we're trying to finesse the treatment to the individual patient. Do you need a bit more or a bit less? How much can we get away with? How little can we get away with? We want to really adjust it to the individual patient. So now the rest of the talk is going to be solely on high-risk neuroblastoma. And the details on this slide are not really important, but what I want to highlight on this slide is there's a whole bunch of patients here. Sorry, is this cutting in and out? Apologies. A whole bunch of patients here with different disease situations, all of whom would be considered to have high-risk neuroblastoma. So you can have a baby who's got MYC amplified disease. You could have a 5-year-old who's got metastatic disease. You could even have a 16-year-old with disease that's just in one place, but that could still be considered high risk. Or you can have a 3-year-old. So a whole bunch of different patients who would all be considered to have high-risk neuroblastoma. And the point of this slide is really just to say, in a way, it feels a bit strange to imagine that the disease in all of those patients is identical. But at the moment, we put all of those in a single box of high-risk neuroblastoma. Is there a question?
I don't mean to cut you off, but how do you know the age, stage, and how if that is high risk?
So for an individual patient, we find it out. So that's part of the test that we do at the beginning. And then in terms of how we make a decision, essentially it's come about over the years with a lot of work that's been done by looking back at the outcomes for patients depending on these characteristics. So these papers that I highlighted here are work that's been published looking at hundreds or sometimes even thousands of patients with neuroblastoma to say what happened to those patients. And over time, we've gradually been able to tweak the criteria to work out exactly who we think should be considered high risk. And so, the details of it are quite complicated, but simplistically, everyone who's got a MYC amplified disease would be considered high risk, and everyone who's over the age of 18 months who's got metastatic disease would be considered high risk. There are some extra groups as well and some subtleties to that, but that's sort of the headline. So, as I'll talk about now, although we consider all of those patients to have high-risk disease, we are beginning to change our understanding of how to treat, even though we would still label them all as having high-risk disease. Does that answer? Does that make?
Sort of, kind of.
So.
I'm not gonna lie, because like if you're looking at a person, you can say, okay, she's older than her, so she's aged, she's younger. So like, are you when you do this biopsy, are you taking it out, dissecting it, and it says this is older versus this is a tumor that started last?
Oh, sorry. Good question. Good question. We're talking about only the age of the patient.
No, we're talking about how do you know the age of the tumor?
We don't, but we don't care in the same way. So when I say age here, I mean the age of the patient.
Okay, so that's what I needed to know.
Yeah.
Are you talking about how long that particular tumor has been there?
No. So what we're talking about is the age of the patient at diagnosis. And so technically the way this is done is that the age you are is the day on which you had your biopsy, is when we call the date of the diagnosis. Now, the important point you're raising is, well, how do we know that that tumor wasn't there for 2 years as compared to just turning up last week? And the answer is we don't, but almost we never will. And so all of the information that we've used to define these groups has been based on the date of diagnosis, based on the date of biopsy. Now, most of the time it doesn't matter, because if you're 2 or 3 or 4 or 5 or 6, it doesn't really matter if the tumor was there a week ago, a month ago, or a year ago, because you're still going to be over the age of 18 months. Where sometimes this gets super complicated, and it's complicated wherever you have a firm cutoff, is say your child is 18 months and 1 week old when you have your biopsy, so they're technically over the age of 18 months, but then we say, well, looks like they probably had this tumor for the last month because they were unwell a month ago with symptoms. That would have been under the age of 18 months. So then it actually gets into a complicated discussion, and that's kind of the responsibility of the oncologist to then discuss and work out with the family what is the right thing to do. But that's kind of at the edges rather than most cases. Okay.
Because I was kind of confused when you just put
age. No, well, so
you're not thinking about age of the child.
thank you for clarifying, because
Age of the actual tumor itself.
exactly. So I love that question, because that means that I wasn't clear on that. So, okay. And anybody else, feel free to. This is what I love, a bit of a conversation. As long as it doesn't get too physical, then it's fine. Okay.
No, I want to fight it there.
Okay. I mean, mainly because I worry I'll lose. Okay. So back on track here, what we were talking about is patients with high-risk neuroblastoma potentially having a lot of different criteria, but at the moment all going into one box. The other concept that I want to get across is the outcome for high-risk neuroblastoma changes as you go through treatment, depending on how the disease responds to the treatment. So we know that if we take all of the patients with high-risk neuroblastoma at the beginning, that there may be a certain outcome, but as you go through the treatment, we get extra information because we then know, does the tumor respond to treatment or does it not? And if the tumor does not respond to treatment, then that means that it's more challenging to treat and makes the likelihood of a good outcome lower. But if it does respond to treatment and we're able to go through each treatment step, then that means that you're more likely to end up in the group with the better outcome. So it's quite challenging, but I think the important thing here is, on the one hand, we never know what the outcome for any individual patient is because the statistics can only tell us so much. Ultimately, nobody knows what the outcome for an individual patient is. But what the statistics also tell us is that the information that you get from your oncologist on the day of diagnosis, if you ask them what is the likelihood of a good outcome, that answer should be different if you ask the question halfway through treatment or at the end of treatment, because by that point you have extra information in terms of how the disease has responded to treatment or not responded to treatment. So the point of this is just to highlight that in addition to those factors that I've mentioned, which are age of the patient, stage of the tumor biology, response of the disease to treatment is itself a really important factor in predicting the longer term outcome.
Why is it that a kid that is under 18 months does better than a kid that's 4? A kid that's 4 does better than a teenager, and a teenager does better than an adult?
It's a great question. So the tumor itself obviously doesn't know how old the patient is. It's got no way of knowing. And so ultimately, in some ways, it makes no sense for age of the patient to be relevant to anything. I think ultimately what it reflects is a difference in the biology of the tumor. That in general, neuroblastomas that occur in younger babies, especially under 12 months and under 18 months, have better biology, behave themselves better than neuroblastomas that occur in older patients. And so in practice, we use age because it's convenient and it's easy. You know, even I can work out the age of a patient given their date of birth. But the genetics is much more complicated because we don't actually even understand what those genetics are, and so we don't have a test for that at the moment. But I think in however many years' time, we will probably, and we're getting there, a better understanding that the reason why an older patient does less well is because their tumor is different biologically from a tumor in a younger patient. And there are some genes that we're beginning to identify. So there's a gene called ATRX, which is abnormal in some neuroblastoma and tends to be abnormal in older patients, so the sort of teenagers or the that sort of age group, who tend to have slower growing, indolent disease that is difficult to control but doesn't change rapidly. And so I think this is what I'm beginning to talk about now in this talk, is that there's different subgroups of neuroblastoma even within the high risk. Okay. This little point on the bottom here is just for anyone who reads the literature and looks at papers, I don't know if anybody does, you've just got to be really, really careful when a paper says the outcome was 80%, the outcome was 55%, the outcome was 76%. Because what you've got to ask yourself is, starting from when? And the outcome, if you start at the date of diagnosis with a group of patients who are newly diagnosed, is going to be very different from the outcome if you take a group of patients who have all finished their treatment and have done well during their treatment and whose disease has responded. Okay, so just got to be careful when you're reading papers, if you choose to do that, that you can't just take a number from a paper and say that means that was the outcome. The question is, what does that mean? Where did they start the clock? Okay. So then I just want to talk about, well, why would we bother with any of this at all? What is the point of trying to think about how to break down, to risk stratify within this group of patients with high-risk neuroblastoma? And these are some possible reasons why we might want to do that. So one question is, could we maybe identify patients who will not do well with our current treatment and therefore do something else instead? Or could we identify patients who do really well with our current treatment, and could we think about reducing the treatment for those patients? This is beginning to get to the questions that were asked earlier on. Or could we identify patients whose tumor has got a particular genetic marker, and could we then use an extra targeted therapy to treat that patient? So those are kind of the three reasons why this might be something to think about. So if we talk about the first of those, I just want to introduce this other concept of ultra high-risk neuroblastoma. So this is the idea that within the patient population who have high-risk neuroblastoma, what if we could identify patients within that group who are not going to do well with current treatment, either because their disease does not respond to initial chemotherapy, which is pretty rare, maybe about 10-15% of patients the disease does not respond to the initial treatment, or more commonly, unfortunately, that the disease responds well to the upfront treatment, but then it comes back again and they have a relapse. And so really the question is there any way of identifying these patients who are not going to do well, identifying them earlier? And then the question becomes, well, what would we do in those circumstances? And another way to think about this is to think about if we were able to select out a group of patients with high-risk neuroblastoma and do something differently with them, when would we want to pick out that group, and how would we maybe want to change treatment? I'm sorry I'm going to give a lot of questions at this point because there's not that many answers to a lot of this because it's very complicated. But I just want to sort of share this is what we are as a community spending a lot of time thinking about, and this is why it's challenging to answer the question you asked earlier of, well, why can't we just do something? So one option is to get the slide thing wrong. One option is to try and identify patients at diagnosis who you know are going to have a good outcome or a bad outcome and change their treatment from the very beginning. Or the other option is to wait until we've got some response information in terms of how they do in response to treatment. And that gives us more information because, as I've already said, response of the disease to treatment is itself a really important marker of longer-term outcome. Or we could even think about it a different way and go all the way through treatment and then try and find some way at the end of treatment of identifying patients who are at higher risk of relapse and do something differently with them. So at the moment, this is, a lot of this is still theoretical, but some of this is being put into practice. So how do we do this in practice, and how are we doing it in practice now, and how might we do some more of this in the future? So one of the ways is to not continue to add more treatment for all patients with high-risk neuroblastoma. So as we mentioned earlier on today when we were talking about the protocols for high-risk neuroblastoma, one of the most recent studies compared tandem high-dose chemotherapy to single high-dose chemotherapy and showed that overall the outcomes were better. That is more treatment than we were giving before. The current high-risk study is adding MIBG therapy to induction, so that's more treatment than we were giving before. So one of the questions is that needed for all patients with high-risk disease? And in fact, the studies have already taken that into account in that, for instance, the current COG study with MIBG doesn't include all patients with high-risk disease. So it gets a bit technical, but there's this group of patients with localized disease without MYC amplification who we would consider to have high-risk disease but would not be eligible for this study, would not be eligible for yet more treatment because we think that, yes, they're high risk, but they're not as high risk as other patients, so we can't justify increasing their therapy further. Then, for instance, at our institution, we decided for the time being to use tandem high-dose chemotherapy for patients with metastatic high-risk disease, but at the moment not to use it for patients with localized high-risk disease who are not MYC amplified, again, because we don't feel that it's maybe justified to increase the treatment further. And then the other subtlety is these patients who are aged 12 to 18 months. In the past, we always had a cutoff between under 12 months and over 12 months for whether we were going to treat you as high risk or not. And now there's this group of infants 12 to 18 months who we're beginning to say maybe we could reduce the treatment for some of those. Even if they look like they're high risk, maybe we could get away with a bit less treatment. So we're beginning to make some changes around the edges. And this kind of gets to another really tricky but important message, is that the stuff that I started talking about at the beginning about risk stratification helps us as clinicians to decide how to treat the patient, what our treatment approach is. And often that is the same as the rules for going on a study, but not always. So the high-risk studies that are currently open through Children's Oncology Group are not necessarily open to all patients who have high-risk disease. Does that make sense? So they're not quite aligned because ultimately the study is about trying to ask and answer a specific question, whereas the risk stratification is about telling us as clinicians how should we treat this patient. The next example is, can we select patients based on specific gene changes and give them targeted therapy? And the answer is yes, at least we're beginning to be able to do this. And I think, we've heard some about this already. There's this gene ALK, which is mutant, which is abnormal in about maybe 10% of patients at diagnosis. And we have drugs that can target that ALK mutation. And so in the current COG study, and actually also in the current high-risk study in Europe, patients who have an ALK mutation identified in their tumor at diagnosis will get treated with an ALK inhibitor throughout their treatment, as well as all of the current high-risk therapy. So that's kind of the first time we've been able to select out a group of patients with a particular genetic abnormality and give them a targeted drug. The challenge is that that is a great example, but we don't have a huge range of other genes that we can go after at the moment because there's just not a good number of single gene mutations and not a long list of available treatments for them. I think one group that we'll increasingly hear more about is this ATRX, this telomerase, this other pathway that's involved in cancer cells, which I think will be very helpful in dividing the high-risk neuroblastoma population into different groups. The challenge at the moment is we don't really have good drugs for targeting that. So even if we could identify those patients, it's still not terribly clear what we actually do with that information. And then, of course, the important questions at the bottom there, and that's what the trials are designed to ask are, is it safe to add this other drug? And then, of course, does it actually make any difference? Does it work? So we have to wait and see. And then I guess the other challenging question is, can we begin to identify patients with ultra high risk neuroblastoma, so those who are not going to have as good an outcome as we hope? Can we identify them earlier? And there's lots of work that's gone on to look at individual factors, and I just want to give a couple of examples. So these are relatively straightforward things to look at, like how old the patient is, what the LDH is, that's a kind of marker in blood, how much metastatic disease they've got. We heard earlier from Dr. Yannick that the Curie score at diagnosis didn't impact on your outcome, but what we're talking about here is, have you got disease in your bone and in your bone marrow? Have you got disease in your bone marrow and your bone and your lung? Have you got your disease in bone marrow and liver, for instance? So more metastatic burden relates to less favorable outcome, as does being older and as does having a higher LDH. So there are lots and lots of factors. That's just a quick example of some clinical ones. And then there's a lot of work going on into trying to understand more about the individual genetics inside the neuroblastoma that might predict how that patient is going to respond to treatment. And they've just kind of put on this slide a whole bunch of other factors that we can think about using. The clinical factors like how old the patient is, the tumor biology that we've spoken about, the MIBG scans that Dr. Yannick spoke about, how the disease responds to treatment, possibly this idea of doing minimal residual disease testing. Can we look at tiny amounts of tumor in the blood to detect patients who look as though all the disease has gone away, but there's a tiny bit left? And then something over here in green that I can't read from this angle. Host factors. Yeah, exactly. So the question of the patient's own genetics and the factors within the patient themselves that might determine how their neuroblastoma behaves. So essentially the message here is there's a whole bunch of science going on, but it's challenging to know how to translate this into the design of a new clinical trial. And so unfortunately, I don't have an answer at the end of this talk for those who are hoping that you're going to get to write down the answer. I've just got a bunch of questions about why this is difficult. But this idea of ultra-high-risk neuroblastoma is challenging to implement in reality, because if we could identify patients up front who are not going to do well on current therapy, there's still the question, well, what do we actually do then? What are we going to say to you as parents? What are we going to do for those children? We haven't got in our back pocket some brilliant treatment for neuroblastoma that we're holding in reserve for a rainy day. We're using everything we've got now. And so I think we will begin to learn more about the genetics of neuroblastoma, and I hope that will lead to more treatments. But at the moment, one of the challenges of picking out a group with ultra high risk is how we actually change their treatment. And we could have it would be a difficult but interesting conversation about, if a doctor said to you up front, the chances of this treatment working is 5%, but I haven't got anything else to offer, would you still want it? If it was 1%, if it was 0.1%, how certain would we need to be that the treatment was not going to be effective to not give the treatment if we haven't got anything else to offer? And I would say we'd have to be pretty damn certain, because unless we've got something better to offer, I suspect most of us would want to take the chance of it having an effect. So this is, kind of a topic that we're in the throes of discussing, and it gets to specifically answer your question, which was, At the moment, we're concerned about the toxicity from our treatment, and we know that high-dose chemotherapy especially is associated with a lot of long-term toxicities, although to be fair, all of our treatment is associated with a lot of long-term toxicities, including the induction and the radiotherapy, maybe even the surgery, and the immunotherapy, we think not at the moment, but that's, to be fair, probably because we don't know. And so it would be great as a community for us to be able to say, hang on, maybe we don't need to do that high-dose chemotherapy anymore because we can do something else instead, and maybe that something else instead is chemoimmunotherapy because we think that that's really great. The challenge is, well, how do we do that in practice, given that we've got to be really careful not to compromise the outcome for our patients? We don't want to make things worse. And even if you think about it kind of theoretically, you could say, why don't we take the patients who do really well with our current treatment, and rather than giving them tandem high-dose chemotherapy, give them chemoimmunotherapy? What about selecting those patients? Maybe, but maybe the reason why those patients do so well is because of the tandem high-dose chemotherapy explicitly, and if we take that away, maybe we're doing those patients a disservice because we're taking away the one bit of treatment that actually made the difference for them. Or you could look at it the other way around and say, let's take the patients who are not doing well with our current treatment and say, rather than giving those patients tandem high-dose chemotherapy, we give those chemoimmunotherapy instead. And then the challenge is, well, do we really have evidence to know that that is going to improve their outcome when we've already said that it's not great? Is this really the right thing to be doing to try and make their response better? And the challenge is we don't know the answers to all those questions at the moment, but it is being discussed in the community in terms of trying to plan the study after the study that is coming next. But I can, as a parent, I can imagine how frustrating that is to hear it's coming in the future, we're starting to discuss it, and it might come in the study after the next study. I mean, that is like 10 years away. But on the other hand, all of the talk that I've just given now is designed to kind of explain why this is so complicated and how we have to be really careful not to make things worse whilst we're trying to make things better. So finally, to sum up and stop waffling on, all high-risk neuroblastoma is not the same, is I think my central take-home message, that it differs based on biology and it differs in terms of outcomes, but we still don't know how to really segregate out different groups of patients with high-risk neuroblastoma. Some adjustments are already possible, and I've spoken about that not all patients with high-risk neuroblastoma are treated identically even now. That the big changes are really challenging to implement. We've got to be really careful to not make things worse. And even if we can identify this group of patients with relatively poor outcomes, what are we actually going to do to make it better? And then I think the answer is going to come through more molecular characterization, a better understanding of the biology of these tumors, potentially more therapies that are directed to particular subgroups of the tumors. The end. Everyone did very well in the quiz, incidentally.
Did everybody pass?
Yeah, everyone was really good. Yeah, full
very
marks.
good students.
Everyone gets allowed to stay.
Yeah, there you go. There you go. Anyone have questions? Feel free, come on up.
Yeah.
Yeah, go ahead.
Hi, my name is Marna. I have a daughter who I guess falls into the ultra high risk classification. And I think for her it was actually picked up kind of halfway through induction. So I have, there's one comment I wanted to make just as a parent. In terms of offering kind of different pathways to high-risk patients, depending on whether or not you think that, the physician sees that they'll be, they're likely to do well after tandem transplant, or they're not likely to respond well, versus, the other side, maybe their disease is not as extensive, maybe they're what used to be stage 3 high risk, localized tumors. I don't know that this answers necessarily the statistical question, but in terms of the ethical question of how to treat those patients, I wonder if there's room to involve the parents in that discussion. Once again, it might not, I realize that it might not hold to the standards of study design because it'll be a self-selected group of patients, but it might be able to provide some kind of signal if there are options for physicians to have a conversation with the parents saying, this is the standard of care, tandem transplant, we know exactly what the results are going to be, but there's this, this group on the edge which your child may fall into, and we could do this for your child.
Yeah. No, I think that's critical. I think that's the difference between clinical care and a research study. The way research studies are written is that things tend to be very tightly defined, strictly protocolized. You do don't do anything else. This is what you've got to do. Whereas in clinical practice, I think you're exactly right, which is that this deserves a conversation between the oncologist and the family to decide what the right thing to do for the patient is. And so, in our practice, although our standard might be tandem, there are some circumstances in which we would not recommend doing that, or a family might not want to proceed with tandem, and when we might do something else instead because of the particular circumstances of that family. And I think that's a kind of really important point, which is that however much science and research and studies go on, at the end of the day, the point of medicine, and actually the point of having a doctor involved in looking after you rather than a computer that can access all the stuff on PubMed, is that they're in a position to have that conversation with you and make a decision that is right for the individual patient, bringing in as much knowledge as we can get, but also all of these other factors in terms of the family's expectations, the family's thoughts, the toxicities that individual patient has got before. So I totally agree.
So sorry, I've just a short follow-on question. Thank you for that. Many of the doctors that are here today see a lot of neuroblastoma patients. We all know that it's a rare disease. Many pediatric oncologists actually don't see a lot of neuroblastoma patients. They might see more leukemia. Do you have any suggestions for parents who have an oncology team treating their child who might not have the personal experience to make that call? They will follow, say, the COG standard because that's what they have data for. They know that they don't have the personal experience to say, does the child fall in or out of these? Do you have any suggestions for families?
So I'm going to go out on a limb, I hope it's not too controversial, and say I think every family should feel that it was reasonable to ask for a second opinion, not as a way of saying, I don't trust you, I don't believe what you're saying to me, but to say, this is so complicated and important, I just want an extra view on this. Certainly if one of my patients wanted a second opinion, I would be completely open and happy for that, and I hope most of my colleagues would be. I think in practice, it's best to do that in collaboration and in discussion with your oncologist, because what's very tricky as someone who might be at the receiving end of a request for a second opinion is to give that second opinion sort of through email conversation directly with the family. That's not really a good way of doing things, because you then don't have all the information and you have to be very cautious about really saying anything. But I would hope that if families have conversations with their local clinicians and say, this is a really challenging question, or this is a particular thing, I really would just like to get a second opinion from somebody else, that they would help to facilitate that. Do my US colleagues concur? Is that? Yeah? Okay, good. Phew. I'm saying that from Canada.
The other thing is I think we all know each other if you haven't figured it out.
Yeah.
So we do all talk, but we oftentimes will have conversations if it's complicated behind the scenes anyway. But I think a formal second opinion is a very welcome thing for any family, and I don't think any of us would take offense to it. We just want to make sure that you guys are comfortable with it.
But I think we all talk, but I think there are centers where there maybe is not a neuroblastoma expert who is plugged into the neuroblastoma committee. I mean, we spend all of our time doing neuroblastoma and are in that world, but I think there are other hospitals where neuroblastoma is one of the things that clinicians are looking after, and they, in those circumstances especially, I think it's totally reasonable.
Thank you so much. Thank you.
Can you come up to the microphone, because we're taping, so we want to know what the questions are.
I'm sorry, were you finished? Yes, sir. Okay, I'm sorry. Not to step on y'all toes or anything. I know you guys communicate behind scenes, but when I get my second opinion, I don't want to ask you your opinion and then you go back and ask the person that I just talk to and y'all communicate. That was my big issue.
Oh, I see what you mean. Yeah.
Yeah, I don't want my first opinion to talk to my second opinion. I want you to come up with your own opinion because I know you guys respect each other as colleagues, but is that fair to us as the parent that y'all talking behind the scene about a case? I want to know that your idea came from you and not my first opinion.
Yeah. So I think two parts of that. I think what Meg was saying in terms of us talking behind the scenes is that there's a group of us who are very focused on neuroblastoma and have a kind of real focus on neuroblastoma. So often when one of people in that group are asked for a second opinion from somebody, as it were, external to that, that second opinion may be discussed within the group to provide the best possible second opinion from multiple views. But I kind of share your concern about, I don't think there's ever, well, I really would hope there's not a situation in which any of us who are providing a second opinion are being told what to say by the referring clinician. I think our professional responsibilities would not allow that. I think what is important is that we need to make sure we've got the right information in order to give the right advice. And so that's where it becomes very important to communicate with the primary referring oncologist to make sure that we've actually got the right information, because just tiny little things can really matter a great deal. You know, the difference between MYC and amplified, MYC and non-amplified could potentially be massive difference, but I can say that in, you know, and that would be a really easy thing to get wrong in a communication. So I think
I understand that, but that's what the notes are for.
Yeah.
I would hope my first opinion has wrote down everything in detail.
Yeah.
And I did run into that situation where I wanted a second opinion because I was in Atlanta at CHOA, but like the other doctor said, it's important that we trust you guys. And I had lost my trust with that particular doctor, and I wanted a second opinion because we were talking at lunch, and like, I'm all for research. Use my kid as a research. But as we're parents, we're coming in the door, and they just told your kid they got cancer, and we're supposed to read this stuff, but we aren't reading it. We're just signing it. We're just signing it. So if you're telling me this is going to help your kid, and I say, hold up, and I'm reading it, and it answers its own question, how does it help your kid? And then it says, it doesn't. You just lied to me. You lost all my trust. So I'm wanting a second opinion at this point, and you're telling me, well, CHOP can't do anything better than what we do here at CHOA. We do the same thing, we talk, and this is what's being said to me, but this isn't making me feel better because you're trying to make me stay here when I don't trust you anymore. I don't want my first and second opinion to converse.
Yeah.
I want that to be of your own doing, your own reading, your own MRI and all that other stuff.
Yeah, no, I hear that. I mean, and I think the second opinion, the content of that second opinion should be independent of the views of the referring clinician. All I'm saying is that it's important that information is shared to allow that second opinion to be as good as possible. I can't comment on the specifics.
Right, no, I wouldn't want you to.
But I would hope that any treating oncologist would be open to a family getting a formal second opinion from another institution.
I wish it was always like that, but it's not. It's like, it's not a personal stick to you, because at the end of the day, this is my kid.
I know.
I just want to make sure if your opinion and your opinion is the same, that it came to that conclusion on your own will, not because you had a conversation behind. Because I'm pretty sure if you say, well, why did you not do this for this patient, then you guys are beefing now, because you have had this conversation and you don't want to step on their toes by suggesting something else. But that ain't my issue.
Yeah, no,
I don't care how y'all, talk in the back scenes. I just want to make sure that my kid is okay. Yeah. And I'm saying this because this is coming from personal experience. I can literally, guys, I've been going through this thing for 10 years, and I can write a book about everything that's happened, the mishaps, the good things, the bad things. I've been through some things, and it always feels like I'm fighting to get the right thing done. And I just want your opinion to be your opinion and not your colleague's opinion.
Yep.
And that's why I tell everybody that's coming behind me that's new and scared, because I was scared the first time, and there was a lot of things that I didn't know, but I was made to feel bad that I wanted a second opinion. And if you go to my records right now, they actually put this in my records, that I was a difficult parent and I was hindering her care because I wanted a second opinion. And that's not fair.
Yeah.
It's absolutely not fair.
Yeah.
I just want everybody to be comfortable
Yep.
with the decision that they make for their kid. And if their kid does happen to become an angel, they shouldn't sit at home crying and saying what I should have done, what hospital I should have taken my kid to, all because they was trying to spare your feelings.
Yeah.
At this point, your feelings don't matter to me, and I'm not trying to be funny, but it's all about my kid, and I need that second opinion without it being dipped in anybody else's opinion.
I hear you.
Right.
I hear you. Yeah. The only final thing I'll say is the challenging thing is that there is often not a right answer, because all of our discussions assume that we know enough to be able to say, in these circumstances, this is the thing to do. But the reality is we don't have that level of information. And in a lot of circumstances, it comes down to a personal judgment or a personal opinion. And so it may be that there is no single right answer out there. But in terms of getting a second opinion, I still would push to say everyone should be able to get access to one. Meg, were you going to?
Just to clarify, my thing that we talk is that we talk about difficult cases or things that aren't clear to see how other people have had experience, not that. My point is that we talk in terms of if there's a difficult or unclear case, we often bounce things off of each other to see, have you seen this before? Not that we're talking about individual specific cases, but more, have you seen X? Or what have you done in this weird case that doesn't fit? And that's where I think there is benefit from second opinions, but also from going to someone who has experience. I mean, I use Kate a lot because she's got a lot more years of neuroblastoma treatment. And I think that's one of the benefits of getting a second opinion, is also getting people who may have seen things differently. That's what my point was.
Thanks. We have time for questions over here. Yeah. Or how are we doing time-wise? Badly.
Just a little more on the second opinion thing. I ran into that. First of all, the pathology was questionable, and I basically had to get a second opinion on the pathology right from the get-go. And then the first places we went just discouraged me from getting the second opinion. And I just decided myself that I was going to get a second opinion and maybe a third opinion or a fourth opinion, whatever I needed to do. And so even though I was discouraged from doing it, I went ahead and did it. I am a nurse, so I had a little bit of background. But I said, I want a second opinion. And the second opinion was radically different than the first opinion. And then I had to decide what I was comfortable with. And in terms of what happens later, no one can predict what happens later. And whether you're in the 95% or the 5%, right, at this point, you don't know which percent you're in. So you make the best decision with the information that you have at the time. And then you can't look back. You take the information from here and from there and maybe a third place, and then you decide. And it's also complicated. Do you have other kids? Who's watching the kids? Do you have to travel? What else is involved? But I'm all in favor of the second opinion. And then what you do with that, you have to see what works for your family and the information that you got and do what you need to do. So.
Okay.
Last one, okay.
Last one. Sorry. Thank you. You did answer my question. I knew it was going to be, a former Army captain. I know the implications of difficult decisions, and I understand you guys have difficult decisions ahead of you. So I appreciate you trying to also add in the ultra high risk and low LDH and seeing how that works, because we were in that category as well, Marta. So thank you for that. Is there you talk about stratification. Is there some notion among some doctors that MICN amplification is no longer a prognostic factor?
What a great and complicated question to end on. Okay, strap in, everyone. So So MICN, for those, is a gene which is abnormal in some neuroblastoma when it's amplified, which means there's lots and lots and lots of copies of it. And the reason it's so important is that it's a gene that affects a whole bunch of other genes. And so when there's a lot of copies of it, that pathway is super active, and we think that that then drives cancer cells to become much more aggressive. Now, in some populations, MICN amplification is absolutely critical in determining outcome and treatment. So if you take babies with metastatic disease, if they have MICN amplification, their prognosis is much, much worse than if it's not MICN amplified, and they definitely need significantly more treatment if they have MICN amplified disease than if they don't. If you take a 5-year-old patient with metastatic disease, it's much less clear whether MICN amplification actually makes any difference or not. And so the data I'm most familiar with actually is from Europe, where we looked at this again in the high-risk population and showed that overall, if you were already high risk, being MICN amplified or not made no difference to your outcome. It looks as though it's probably even more complicated than that, that maybe if you're MICN amplified or your tumor is MICN amplified, your outcome early on is worse. Your tumor is maybe more aggressive and difficult to get hold of at the control of at the beginning. But if you ultimately get control of it, maybe your longer term outcome is actually even better than if you were not MICN amplified. So it's really confusing. And I think the easiest thing is to say at the moment, it looks like we've probably treated away the impact of MICN amplification because of the intensity of our treatment in the high-risk population, but it's still critical, especially in the infants. Thanks all.
Our next speaker is Dr. Kate Mathey. She is the Mildred Strauss Professor Emeritus of Translational Oncology at the University of California, San Francisco, and is internationally known for her work in advancing therapy of neuroblastoma. She led the Pediatric Malignancies Program in the Helen Diller Family Comprehensive Cancer Center at UCSF for 15 years. She received a Lifetime Achievement Award from the Advances in Neuroblastoma Research from the association, and another this past year for her international work in SIOP. She initiated several landmark randomized trials in neuroblastoma and the COG, where she continues as senior advisor on the Neuroblastoma Executive Committee. She established the NCI-funded NANT Clinical Trials Consortium for targeted therapy of neuroblastoma, which she has led for 15 years. She currently chairs the Pediatric Solid Tumor Steering Committee at the NCI. She has been a leader in the development of targeted radiotherapy for neuroblastoma with MIBG, which she initiated at UCSF in 1987. And Dr. Mathey will be talking about COG and what current treatments are going on through the COG. Dr. Kate Mathey.
Thank you very much, Pat, for sponsoring this conference, and all of you for being here. Where do I change? Is this the slide changer? Okay. Thank you so much. And unfortunately, we haven't yet cured this disease, as you've heard from many of our parents today. And I'm a little sad today, as we lost one of our patients who I treated when he was 5 years old, and he died when he was 12 just this month from brain metastases. And it's sad. He had a good life despite that. He spent a lot of time at home. He traveled to Ireland several times with his family. He went to school. A lot of his treatment was outpatient. But I think the hope lies in the fact that we did keep his disease going through multiple relapses with some of the new therapies that we found through the Children's Oncology Group trials, as well as others. He got a lot of chemoimmunotherapy. He even got some very new targeted agents, BCL2 inhibitors, and he responded to every therapy, but then his disease came back. And I think in the Children's Oncology Group, we are really, again, trying to forge ahead to find out what we can do for high-risk disease. We'd like to, let's see, this is the next. we'd like to talk today very briefly about late effects of therapy, which you've heard alluded to, and I think you'll hear more about later this afternoon. And maybe if I talk like this, it's better. You heard about risk groups, and I'll talk very briefly about our intermediate risk neuroblastoma trial, trying to decrease therapy and decrease late effects, and mostly talk about our current high-risk protocols and plans for the future. So our late effects study looked at 377 patients who had more than 5 years of follow-up from diagnosis and had been off therapy for at least 2 years to be on this study. And we wanted to learn about what kind of organ dysfunction there was, secondary cancers, growth and development abnormalities, and also neurobehavioral or brain dysfunction after all this treatment. And this study has been run by Tara Henderson and Lisa Diller. So of the late toxicities, and this included patients who'd had single transplant, tandem transplant, immunotherapy, radiation, and isotretinoin or Accutane, and only a few with MIBG therapy, again, because that had mostly been given for relapse, and these were patients who had survived at least 5 years with their disease. So these were all high-risk, super high-risk patients. And the most common toxicity, which I'm sure you're all familiar with, was ototoxicity, hearing loss, found in 66% of patients, many of whom required hearing aids. Cardiac and pulmonary problems were lesser. Endocrine problems, including growth delay, short stature, hypothyroidism, and infertility, were also quite common after all this high-risk therapy. Secondary cancers are deadly, but happily in a fairly small percent of these survivors. So what can we do with all this? And our next goal is now to take these results and try to see how we can prevent them. Daniel just spoke to you about whether there are some patients where we can lessen the high-risk therapy. We would love to do that if we knew how without lessening survival. For the ototoxicity, the deafness, people are trying to learn if some more local therapy would be helpful, because we're worried that systemic therapy that blocked this drug would also block the anti-tumor effect. So this is just one example of ways we'll try to overcome, but I think we have a long way to go. So our non-high-risk ongoing study is called ANBL 1232, and Greg told you how these are named. So you can see this study was originally designed in 2012 and is still ongoing. And this was using both disease response and biology to guide therapy. And do you have a question? I'm sorry.
If you don't mind, sorry. Is TMA considered to be one of these toxicities, and is it something you track? How common is it? And is it something you're trying to prevent?
Yeah, TMA is a thrombotic microangiopathic angiopathy, is a very troublesome side effect that we see after transplant, both after single transplant and tandem transplant, and it causes renal dysfunction and breakdown of the red blood cells. It is not what I would consider a late effect. It's really an acute effect that comes on usually within a month of transplant. And there is a lot of study going on into what causes it. And we have an ongoing study at UCSF giving drugs to try to prevent it. But that is, it's not something we would see in the intermediate risk. It's really in the high-risk group who go through transplant. But it can be devastating because it can be ongoing for several months, and it can interfere with your desire to give immunotherapy. So in this non-high-risk study led by Holly Meany and Naveen Pinto and then Jed Nuchtern, a surgeon, it builds on our prior study, and it's really focused on children who do not have MYC gene amplification and who are less than 18 months of age at diagnosis. They can have either localized invasive tumors or the 4S MS type of neuroblastoma, which occurs in infants with liver metastases and a little bit of bone marrow disease and skin. So in this study, as Ami showed you, we had an excellent survival in patients with very minimal therapy, better than 90% for most groups, except a little bit lower for the metastatic patients with unfavorable biology. So based on this, we did a new study to try to further reduce therapy for infants under 12 months who presented with localized L1 tumors, shown in the upper panel there, non-invasive tumors. We do not even do a biopsy. We showed in a prior study if they were less than 6 months of age with a small tumor, they did not need any therapy. These tumors would spontaneously regress. Now we've extended the age to 12 months, and we are also, as shown in red, studying not only tumors that arise in the adrenal that are quite typical, but also tumors that arise in the chest or pelvis. And those patients do not have to go through any dangerous procedure, no surgery, no biopsy. Then we are also, in a slightly greater leap of faith, looking at infants and toddlers under 18 months of age with more invasive tumors that we call L2. And you can see in the lower panel the cross-section of such a tumor arising between the kidneys and surrounding in white the blood vessels next to the liver and between the liver and spleen. And in the past, we thought these were unfavorable, but if these tumors have a benign appearance under the microscope, do not have MYC amplification or segmental chromosome abnormalities, we are now trying to avoid surgery, which can also have late effects in these very young children, and simply observe these tumors, and if they do not grow, they will not have any intervention. This part of the study is still ongoing. We still need to get more patients, as I think people are a little nervous about doing no therapy in this group. And then the other group on this trial are the MS patients with metastases to liver, skin, and bone marrow. And again, if they are asymptomatic and their tumors have all favorable biology, they are simply observed and we wait for the tumors to mature and go away. If they are symptomatic, which usually means they have trouble breathing because of a large liver which can cause compression of the lungs, then we immediately treat them with low doses of outpatient chemotherapy, and as soon as their symptoms resolve, we stop the treatment and observe them. Any tumors, however, with unfavorable biology would get chemotherapy until the tumors regress. So for the rest of the time, we'll be talking about what most of you are most interested in here, which is high-risk disease. In our ongoing open trial, 1531, led by Steve Du Bois, Emily Greengard, Tracy Easley, and our statistician, Arlene Naranjo, is trying to see if adding MIBG during induction chemotherapy will improve the long-term outcome. Additionally, for the first time, we are treating patients who do have a tumor with an ALK mutation with an ALK inhibitor right from the time shortly after diagnosis. So in this study, as it was designed, you can see at the top, the patients would enter on study here. They would be tested for ALK mutations, and if they have an ALK mutation, they would be treated, they were treated with crizotinib, the first generation ALK inhibitor, along with their chemotherapy throughout the treatment, and get standard induction, harvest, and tandem transplant radiation and immunotherapy. Patients whose tumors did not take up MIBG, which is about 10% of neuroblastomas, would go again onto standard induction and tandem transplant and immunotherapy. The rest of the patients who were MIBG positive were initially randomized between 3 arms, either standard treatment with tandem transplant, induction with MIBG after the 3rd cycle of chemotherapy, and tandem transplant at the end, or induction MIBG therapy and a single transplant with busulfan melphalan, based on some of the SIOPIN data where they felt that was a better approach than our consolidation. At the first planned evaluation by our data monitoring committee, we had to close the arm with busulfan and melphalan because those patients were actually having more relapses, doing more poorly. So currently the randomization is just between MIBG with induction and tandem transplant, or no MIBG. We also then decided to move to a better ALK inhibitor that works on resistant cell lines. So Yael Mose and Kelly Goldsmith led a study in Nantes showing that lorlatinib, which, got my buttons mixed up. Lorlatinib, given in a resistant ALK mutation, could make all the animals survive with that ALK mutation, whereas crizotinib improved the outcome but was not as good, and with no inhibitor, the animals all died in preclinical work. So lorlatinib had been well tested in adults, and in the NANT we tested it in children, and are now testing it combined with chemotherapy and showed that it was tolerable. So we have now amended our study to give patients lorlatinib instead of crizotinib who have ALK mutations. And then in addition, as I said, we will no longer do the Bumel arm, and all patients will be randomized between these 2 arms. So we expect to complete this study, I think, in about 2 years, and hope to then, a few years later, have an answer as to whether using MIBG upfront like this will improve the outcome for patients. We are also trying to further improve our chemoimmunotherapy. We know that chemoimmunotherapy, as you see here in this study that was run by Rajan Modi, in relapse patients showed how effective giving dinutuximab with irinotecan and temozolomide much improved the outcome of patients, and we saw 40 to 50% responses in relapse patients compared to another agent given with this chemotherapy. So we are now trying to see if we can actually give this chemoimmunotherapy after transplant instead of what we are now doing, which is the antibody with just retinoic acid. So this is a small study for patients who are not on the current 1531 but have not relapsed and gotten to the immunotherapy stage. They will be eligible to get the chemoimmunotherapy. So they can't be on a different study, and they can't have had progressive disease. And they will then get their induction, consolidation with transplant, and then get temozolomide, irinotecan, GM-CSF, and dinutuximab for 5 cycles, and then get their isotretinoin as they do now. So really this study is being done right now just as a pilot to show whether this is tolerable after patients have had a tandem transplant and all the other therapy. So we hope that at least 75% of patients or more will complete 5 cycles of the chemoimmunotherapy within 30 weeks and have less than 10% unacceptable toxicity. This study only needs 40 patients to show it is tolerable, and we hope to complete it in 1.5 to 2 years. So far we have 22 patients enrolled, so hopefully in another year this will be completed. The other study, which Daniel mentioned, is our ANBL 1821 study, which is a randomized study for patients who've had first relapse. And this patient is looking at chemoimmunotherapy with the addition of DFMO. DFMO is an ornithine decarboxylase inhibitor, which an ornithine decarboxylase is very important in the pathway for MYC-N and stimulates cell growth and proliferation. So using an inhibitor, both in the lab and in a recent NANT trial, does induce responses and stop the growth of neuroblastoma cells. Also, Mike Hogarty has shown that DFMO alters the immune microenvironment, so it may have some kind of immunotherapy effect on the neuroblastoma as well. So for this study, patients must have either detectable disease by PET avid disease or biopsy or MIBG, and they have to be over a year of age and have no prior history of anti-GD2 therapy with chemotherapy, and no prior irinotecan and temozolomide. So this would not be for a multiply relapsed patient. This is for first relapse. So in arm B, the experimental arm, they get the DFMO for 3 weeks, and they get the usual 5 days of temozolomide, irinotecan, 4 days of dinutuximab, and the GM-CSF. So far, again, we have 51 patients enrolled, and this is a nice trial option where patients don't have to travel. They can get this at their home COG center. And we are doing many correlative studies to look at the mechanisms, the immunotherapy mechanisms. Another pilot, which has just completed accrual, is a pilot study to assess the feasibility and tolerability of chemoimmunotherapy. Again, you've heard allusions in many of the prior talks to starting antibody therapy with dinutuximab during induction instead of waiting till after transplant. And this has been a very promising approach in this single institution study at St. Jude's led by Wayne Furman and Sarah Federico. You can see the improvement in outcome shown in patients who received this chemoimmunotherapy right through induction as well as post-transplant, though in this study they also had some NK cell therapy. So based on this, as well as our success in our chemoimmunotherapy trials, we have done this induction trial pilot led by Sarah Federico and Wayne Furman, Susie Schusterman, to assess, again, the small trial to look at feasibility and tolerability as a basis for a new randomized trial. So here, unlike the St. Jude's trial, we are not starting dinutuximab with the very first round of chemotherapy, which could be a disadvantage, but on the other hand, many patients with high-risk neuroblastoma present very sick with a lot of pain, high blood pressure, and other problems. So we did not think it was feasible to immediately start them on antibody therapy. And so this starts after the first 2 cycles of treatment and the stem cell harvest. And then with the next 3 cycles, they receive dinutuximab along with their chemotherapy, have their end of induction evaluation, surgery, tandem transplant, and then standard immunotherapy. So all the patients on this pilot study have completed therapy. I believe this was presented at ASCO this year. And we showed that it is both feasible and tolerable, and it did not slow down or hinder any of the subsequent therapy. So based on this, we are in the midst of writing our new study, which was recently approved by the NCI to move forward. And this is ANBL 2131, so this has moved pretty fast, was designed in 2021. And our hypothesis is that the use of chemoimmunotherapy during induction will improve the outcome in newly diagnosed patients with high-risk disease, builds on all the studies we've discussed, the relapse study, the St. Jude study, and our pilot. And it will be a randomized, controlled phase 3 study led by Thomas Cash and Sarah Federico, as well as Carrie Strebe and Naveen Pinto. And on this study, again, patients will, with high-risk disease will come on study. They will be randomized right up front to be on the antibody arm or the standard arm. And after one cycle of chemotherapy, we will then add the antibody to the chemotherapy. And they will then go through their standard induction, have surgery, and so on. We have also, because we know all of you and we too are convinced that antibody is a very important part of therapy, and we don't want to deny children on the standard arm that option. So patients who do not have a good response will be eligible to cross over, which is a very tricky thing in a randomized study, but we will keep track. They will cross over and get a rescue with chemoimmunotherapy, as you see here. We do not have a written-in rescue for the patients on the antibody arm. They would go off study, but then be eligible to receive MIBG or other or experimental agents. So this is our hope for the future, and hopefully this will get started. We won't yet have our answer from the MIBG therapy, but when we get that, I hope we can somehow combine these if the MIBG adds further. And maybe with this armamentarium, again, we'll be able to eliminate the high-dose chemotherapy for some patients. So I'd like to close here, and most of all, thank our patients and parents for their support. We would not have any progress without you, and we would not be happy as physicians without the joy of seeing our patients and sometimes making them laugh. It's always my challenge when I went into a room. And I'd like to thank Ro Bagatelle, who leads our Neuroblastoma Disease Committee and graciously asked me to present this data for you. And our statisticians, the research coordinators, the institutional doctors who lead these trials locally, our reference laboratory, but also, of course, not least, Pat and the CNCF and all of you for your participation. Thank you.
Thank you, Dr. McLean. Anyone have questions? Go ahead. You're getting pretty bold now.
I know. It's 2 questions one day. Whoa. So our daughter is intermediate risk. And so I was wondering if you could kind of go into detail on what you guys mean when you say observe.
Oh, that's a very good question. Depends on how nervous we are. So it really depends on the patient's overall presentation. So an intermediate risk patient who is an infant and has a small tumor that we're not going to treat at all, we would usually, and who is asymptomatic, we would usually see that patient monthly at least. Maybe more often the first few weeks when they're seen anyway. We would see them monthly, do urine catecholamines, do ultrasounds, and then periodically repeat scans. For a patient who was on chemotherapy with the L2 tumor, with the big tumor, again, I think we would, I believe the protocol calls for scans every 3 months. I would probably initially want to at least get ultrasounds every month again in those patients, since this is a new approach. And then we would periodically do MIBG scans in those patients, as those kinds of tumors we'd be more concerned about spread.
Okay.
I think, again, in the new thing we're studying in the newborns with neuroblastoma that arises in the chest, those patients have never before just been observed without surgery or biopsy. So I would be quite vigilant with their follow-up.
Okay, she's had 9 cycles of chemotherapy, and she just has a tumor in her neck. And so when we started, it had gone to the bone marrow, but now it's clear. So we're just treating the one tumor. But I'm obviously nervous to just watch her neck.
It is difficult, and I think it needs to be watched closely if she had spread before, but again, without seeing all the scans and biology, I can't say, but I think that's what I was saying earlier to Dr. Yannick when I was asking about MIBG scans. In these young patients with favorable tumors, the MIBG often stays positive for a long time, even after the tumors are maturing. And sometimes, again, we get a PET scan to see if it's metabolically active and is likely to spread. So if I were concerned about something, that's a possible avenue of investigation.
Okay, so multiple types of scans, you would say?
If necessary,
Okay.
yes.
Thank you.
Anyone else? Another question?
This isn't directly part of your talk, but you did mention the microbiome. And I was wondering, could you explain the connection between the microbiome and neuroblastoma?
I can't.
Okay.
I mean, I think that's
there
a
seems to be
wonderful
theory.
There's terrific research going on. We have a lot at UCSF studying the microbiome in relation to various diseases. I am not familiar with any of that in relation to development or progression of neuroblastoma. Did you have something specific in mind?
Oh, just that there seem to be some trials where there's medicines, even DFMO, that do something to the microbiome, and that's thought to help the disease. So I was just trying to understand what the theory was.
I think there's definitely investigations going on, but I
Okay.
don't know of anything proven. But again, it's the bacteria that inhibit our body, and those can be good for us or bad for us.
Okay.
And we need to learn more about it.
Okay, can I ask a second unrelated question, since that one didn't
Since
go
I didn't
too
know
well? I don't
anything.
know.
Okay.
When they do autologous transplants, what about patients like my son that had like almost 100% of the bone marrow having tumors in it? Can you explain why that shouldn't be a concern?
That's a wonderful question, and there was an early experiment from St. Jude where they marked the cells, the neuroblastoma cells, and they found that after the patient was transplanted, some of those cells were circulating. So a theory developed, or hypothesis was put forward, that when you do an autologous stem cell or bone marrow harvest, there are certainly going to be some contaminating tumor cells in there. And is that causing the relapse? So in our first transplant study that I actually led back in the 90s, where we showed that patients who got high-dose therapy and autologous transplant from their bone marrow had a better survival than those who got standard chemotherapy, we purged those bone marrows. In other words, we took those bone marrows out, we shipped them to a laboratory where they were treated with monoclonal antibodies to remove the tumor cells. And we did that to all the marrow. This was an expensive, you can imagine, and risky procedure. There was one child whose bone marrow was lost on the way, which was devastating. So we really didn't want to keep doing it. So in our next trial in the children's study group, we did stem cells because they give a richer harvest and they engraft faster, and and they're less painful to do. That's why we changed to stem cell harvest. We did stem cell harvest and we randomized patients. Half the patients had their stem cells purged with monoclonal antibodies against neuroblastoma, and half the patients got their stem cells back without purging. The outcome was identical. The relapse rate was exactly the same in both groups. So that didn't really answer your question, but what it told us was that the relapses we see are not just due to contamination of tumor in the stem cells, and the benefit of using the stem cells for this procedure was greater than going through the additional risk of a transplant from a different donor. We did test those stem cells by a more sensitive method called PCR, which I guess you all know because of COVID now too. And we found that even in the marrows that we thought were clean microscopically from doing very sensitive testing with monoclonal antibodies, by PCR there was probably still a little bit of tumor in there. And I know Brian and his group at Sloan Kettering have used that test for a long time to test for microscopic residual disease in patients. So they may be getting a little bit of tumor back, but we hope that we're cleaning it up with the immunotherapy. And again, because of graft versus host and other issues with allogeneic transplant, plus toxicity in the early trials, we've tended to stay with the autologous. In Europe, they are so worried about this that they will not do their harvest until the end of induction therapy, till they feel they've maximally reduced the tumor. Because of our approach with tandem transplant, we prefer to do it after just 2 or 3 cycles, when most patients have reduced the tumor in their stem cells to the point that we don't detect it, because we get many, many more stem cells and have reserve in case for tandem transplant, for MIBG therapy, or other rescues if the patient relapses.
You don't think that's related to that whole Curie score greater than 2, though? Maybe it wasn't broken down by the patients that they didn't analyze it by patients that might have had more stem cells or something like that. I don't know.
Oh, no, but again, on that original Curie score paper, that was from the study where we tested all the stem cells for tumor. And we did not use any stem cells where we detected tumor by what's called immunocytology. So we didn't analyze in that way.
Can I just comment about 2 things? Microbiome. At Sloan Kettering, we have a laboratory dedicated to studying the microbiome. And we're studying our patients with neuroblastoma and their microbiome. And it's an important part of our evaluation because certain profiles of the microbiome are shown to boost your immune system. So if you're doing therapies that are based on the immune system, for example, antibody or vaccine, the microbiome is of some interest. And some of the, I'll refer to it just briefly in my talk. If we get to that slide, it's further down the road. But the microbiome is a big concern of ours, and we're finding some really interesting results in our evaluations. And number 2, in terms of collecting stem cells, I'll talk later, we don't transplant, but we do collect stem cells. And unlike in COG, they collect stem cells after 2 cycles, the same combination of chemotherapy. We always collect after at least 3 cycles. So the patient's already been exposed to 2 different combinations of chemotherapy, one of which tumor cells might be resistant to one, but not to the other. So maybe it's a better chance of having less occult or hidden neuroblastoma cells in the stem cell collection.
Thanks, Brian, for the information on the microbiome.
We get tons of cells anyway. And there's another reason why we collect after 3 rather than 2. When you collect stem cells, it takes some time. And we want to get our chemotherapy in as soon as possible, including the combination that's going to kill cells that were resistant to the first 2 rounds. So we don't want to defer that. And I'll mention that something called the Goldie-Coleman hypothesis of rapid administration of chemotherapy reduces the chance of spontaneous mutations that can confer resistance. So there are two reasons at least why we collect stem cells after 3 or more cycles of chemotherapy rather than just 2.
Okay.
Thank you.
All right. Anyone else have a question? All right. Last one. All right.
Last question. Okay, on the studies that you mentioned, quick question, are there any preliminary results on the ANLB or ANBL 1821? That's one. And then every time I ask Dr. Marichelli and she comes in the clinic, she's like, no, nothing yet. The second one is, today's the day. Does adding, or is there any initial data that adding MIBG therapy before bone marrow or stem cell transplant could cause more complications during stem cell transplant?
Thank you so much. In answer to your first question, we have an independent data monitoring committee that monitors all. You have to have it on any clinical trial, and of course we have it on all our COG trials. And they do look at the data that we running the trial are not allowed to see. So there may be some data on 1821, but what I can tell you is if there's anything that tells us we should change, for example, put everyone on DFMO or stop DFMO because of an adverse effect, they would have stopped the trial. It's so interesting because in a recent COVID trial, they were testing vitamin C, and the trial was stopped because they actually found the vitamin C arm did worse. So these data monitoring committees are very important, and that's what stopped our current MIBG trial, stopped the busulfan melphalan arm, not because of toxicity, but because more patients were relapsing or not responding. Your other question, I'm sorry, was? Oh, yes. So we did, Greg Yannick showed you a couple of the early trials we did putting MIBG right with transplant. And what we found was there was maybe a very slight increase or proportion of patients who got a complication called veno-occlusive disease. But it was very small and did not hinder us going on. We then did a large multi-institution pilot trial in the Children's Oncology Group where patients got induction, then got MIBG therapy, and then got a rest, and got about 6 to 8 weeks later, got high-dose therapy and transplant. And we actually, this was based on a pilot from Europe, but they never published their data. And when I went back, it turned out they were giving patients a much longer rest than we had put in. And we were, again, had a couple of bad veno-occlusive disease patients. So we prolonged the rest. And in the end, we decided it went fine. Patients did not have too many complications. We showed it was feasible. But we didn't see a great outcome in this pilot study, and we think it was just what Brian was talking about. When you have a long gap in therapy, it's not a good thing with these patients. And that's why we decided to move MIBG therapy up early. And we have, again, with the blessing of the data monitoring committee, we have not had an increased risk of adverse events so far or toxicity on that study. And there are some small pilot trials done in Europe at single institutions where they gave MIBG right from the beginning. I think Greg or Daniel mentioned one of those. And one of the nice things was it seemed to shrink the primary tumor dramatically so that they were getting better results at surgery. And that was one of our hopes by putting the MIBG earlier in induction. Thanks.
Okay. All right. Thank you very much, Dr. Mathey. We'll go ahead and take a 15-minute break. I think there's pretzels or something like that out there, some soft pretzels. So see you back here in 15. We're going to go ahead and start with our next speaker. Okay, we're running a little bit late, so we'll see. We'll get through. I know Dr. Kushner's got a lot of slides, so we'll get through as many as we possibly can. Our next speaker is Dr. Brian Kushner from Memorial Sloan Kettering in New York. Dr. Kushner went to Harvard College for his undergraduate studies and received his MD from Johns Hopkins University in Maryland. He did his residency and fellowships in pediatric and pediatric hematology oncology at Columbia Presbyterian in New York. He was also at Children's Hospital in Boston and Sloan Kettering. He has been a member of the Sloan Kettering staff for over 30 years, and his research specialty is obviously neuroblastoma. He has received numerous awards and has authored numerous articles on neuroblastoma and pediatric cancer. His talk today will be an overview of some of the clinical trials now available at Memorial Sloan Kettering. Dr. Brian Kushner.
All right, anyway, great to be here. Thank you very much for coming around and maybe listening to what I have to say, and I'd love to hear feedback from everybody. I'm trying to move ahead, so, because time's an issue. And I want to just, these are our major goals: to cure, including refractory and relapse disease, and to avoid side effects, minimize side effects. So we do not use chemotherapy as a standard or radiation therapy for non-stage 4, subsets of stage 4. Non-stage 4, no cisplatin. We no longer use cisplatin. We do not do transplant, and we use lower doses of radiation therapy for high-risk disease, and I'll go through these things. I should note that at Sloan Kettering we have a team that focuses only on neuroblastoma. It's a large team. Everybody, all the patients are shared among us. We discuss them. We're fortunate to have great nurse practitioners, teams that administer antibody, social workers, senior attendings. Dr. Modak is the current chief of our whole service. In the past, Dr. Chung was, and Dr. Kramer's been a member. We have great laboratory support behind the scenes to help us understand how our treatments are working. We have many patients that come to us. We're a single institution, but patients, we have a large number of patients come. Most of our patients come from around the United States or elsewhere. Excuse me. Let me just count. I just started a talk. I'll talk to you. Okay. Love it. My daughter, one of my daughters. So we get children from around the country. Most of our patients are from around the country, and among the 20 to 30 children we see every day in the clinic, very few are actually from the New York area. Patients come for all sorts of reasons. Some are listed here. And it's great to have it be at a center that is just an oncology center, Sloan Kettering. And being a group that focuses on disease, we have able to carry out our own studies in the institution, evaluate them all the time, and we can immediately institute changes that we think will improve the treatment. We're also staffed so that we can carry out scans at the drop of a hat, surgery, and get treatments going really immediately. And there's institutional support so that we can make changes to deviate from a clinical trial because the priority is the child, not the protocol. And as I say, the institution is big support for that. I'll just keep going. Again, our guiding philosophy is use as little therapy as possible to avoid toxicity and side effects, and we're always looking for ways to do that. Every child, lots of children come to us, but each child is unique. We brainstorm about each child. Our whole team sits down and goes over all the details about that child's particular situation, past treatment, age, and so And then we come up with a plan that we think might be best, and it might be chemotherapy, might be surgery, might be MIBG therapy, antibody, or we love this when we do careful observation alone without any treatment. We have no bias towards any given type of therapy. Whatever is shown itself to be good, that's what we're going for. Just a quick throwing out a Latin phrase that has inspired us through the years, primum non nocere, first do no harm. And it's not always how do we treat, but do we treat? Is this going to act like a cancer, meaning proliferating endlessly to cause a mass and then spread throughout the body? And many neuroblastoma subsets do not do that. And here, the clinical stages of neuroblastoma. Neuroblastoma has a sort of I think, a cloudy reputation among childhood cancers, but I like to point out that stage for stage, it's by far the best. The problem is that the majority of children with neuroblastoma, in contrast to other childhood cancers, has metastatic disease. But metastatic disease for the other childhood cancers is not curable. It is curable for stage 4 neuroblastoma because of antibody and MIBG therapy and other aspects. So even metastatic stage 4 for other cancers, neuroblastoma has the advantage. And then if you have a localized neuroblastoma, stage 1 or 2 or 3, in the old terminology, usually it's managed with surgery alone, plus or minus some minor chemotherapy, in contrast to, say, rhabdomyosarcoma that is localized, hadn't spread, but isn't unresectable and requires high doses of radiation and strong chemotherapy. And then you have many subsets of neuroblastoma, like the 4S, S standing for special, and spontaneous resolution, which is pretty amazing. And it's amazing that the first person to identify that as something that happens, you take it for granted now, but Audrey Evans, who was a pioneer in the field of neuroblastoma many years ago, was astute enough to identify that a child with extensive disease, often the disease can spontaneously regress. Talking quickly about the non-stage 4, the localized neuroblastoma without MICA amplification. And our starting point, this goes back to about 1990, honestly, is no treatment at all. We call those newly diagnosed patients with stone cancer, we call them N0. And we call patients that refer to us who started chemotherapy, we tell them they don't need any more chemotherapy, we call them N-stop. We've published on this for, through the years. And this no therapy plan is even for patients with stage 3, which is often treated elsewhere as high risk. Dr. Modak, for example, summarized our experience some 10, 12 years ago. And this applies with these no therapy even for patients who have an incomplete or no resection, often to avoid injury to nerves affecting the legs, if there's a pelvic tumor, for example, or the arms, if there's a tumor in the base of the neck, and so on. And there are some recently described prognostic markers, so people try to sort of fine-tune how many cycles of chemotherapy or whatever for a non-stage 4. And we go back, as I say, to the 90s, for example, before some of these prognostic markers were described, and the outcome was great with or without, with or without knowing about them. So our starting point still is no treatment. Here's an example of differences between how we do things here and maybe elsewhere. Here's a patient who was considered high risk. It was a localized neuroblastoma, 18 months of age, bad age, unresectable at diagnosis, was enrolled on the high-risk COG protocol, and then came to us for a second opinion. And after several cycles, they came for a second opinion. We stopped, no further therapy. So didn't go through transplant and radiation and antibody and so on. Here's another example of a patient that was started on high-risk protocol aiming for transplant and so on, came for with this quote-unquote unresectable tumor, but our surgeons are extremely talented, and Dr. LaQuali, Dr. Gerstel are able to do kinds of resections that on tumors that other people tend to think are unresectable. They took this tumor out, or Dr. LaQuali took this tumor out, and it was observation alone. No further therapy. Infant stage 4, this is a fascinating aspect of neuroblastoma. We can have massive amount of disease, and it's cured with mild chemotherapy. It's just really amazing. It's great that the COG study and the European study showed beautifully how low-dose chemotherapy, which has modest side effects, is so successful at curing this disease, this kind of neuroblastoma. For us, the only issues really are how many cycles, and we'd like to, again, minimize chemotherapy. And the standard, at least in the United States, still includes doxorubicin, and we don't use doxorubicin. Doxorubicin can hurt the heart, for example. Even in low doses, why use it when you have another combination that's just as effective, maybe even better, cyclophosphamide topotecan, and has literally no risk for doxorubicin. So any cycles in the standard COG protocol, we substitute cyclophosphamide topotecan instead of that. And it's great. These children, these babies, and no radiation therapy, no antibody, and sometimes we don't take out the primary tumor. We just, it's regressed. It's shrunk with the chemotherapy. We'll just leave it there. And again, no radiation therapy or antibody. Now the question came up before, why less than 18 months is so important. No one really knows. I mean, but it's a fascinating aspect. But MYC amplification, and one of the pioneers of identifying that as a marker, Robert Seeger, recently passed away, and miss him dearly. And MYC has such an impact on these children less than 18 months. I like to show this slide of two infants. Both were 11 months old and came in with maybe a week or two apart. One had with the child on your left had visible masses on her skull. She had tumors around all over her head. And the other child, as you see on the right, she actually looked okay, but she did have a large, I don't have a pointer here, but she had a large abdominal tumor. But we knew right away one was high risk and one was not, because LDH, this is a blood test, a simple blood test that tells you right away that if the LDH is super high, it's going to be MYC amplified. If it's not so super high, it's not. And the one on the left, we knew right away she had like a normal, not very elevated LDH. The one on the right had a very elevated LDH, and sure enough. So my point is that in the outside world, when someone's less than 18 months of age, they all start, as a rule it's been, maybe it's changed, they start the intermediate risk chemotherapy until the MYC result comes back. And it usually takes 1 to 2 or 3 weeks. We know right away at diagnosis when they come in the door from the LDH, which it is, so we can start right away the appropriate treatment. Because if it's MYC amplified, you kind of want to start treating it aggressively rather than just with intermediate risk chemotherapy. So here's one of these amazing responses to low-dose chemotherapy. You see on the left, MIBG scans lights up all over the place, skull and backbone and so on, and it clears, complete response. But in contrast, here's one, this baby, is 11-month-old or so, 11-month-old, came in with massive disease. Her whole body, if you look at the MIBG on the left, was MIBG showed disease. That includes not only all her bones, but she had it in her lungs, she had it in her liver. And she got chemotherapy. And after that, we took out the tumor. After that, her MIBG was still the same. It was all over the place. But the bone marrow by morphology was negative. And we assumed that we had a good, as I say, we thought that even though the MIBG is still terribly abnormal, Curie score, I can't remember what it was, but probably, I think it was in the 20s, it was not active disease. We did a PET scan, and it was negative. We've been studying PET scans in neuroblastoma since the late 1990s. PET scan was negative, and we stopped therapy. And she's great. And this is kind of a more extreme example of MIBG positivity, but not active disease. But it's kind of a dramatic illustration of that. 4S, just quickly, the 4S, the special infant stage 4, we try to minimize therapy. And for us, if you have a life-threatening enlargement of the liver, we usually do a quick dose of radiation therapy to stop its growth, occasionally 1 cycle of chemotherapy. But we've also expanded the definition of 4S because it usually excludes bony lesions and some other unusual sites. Our starting point, again, for something that looks like 4S might be observation alone. Here's kind of a nice situation. just to show the contrast, on top is a 4S with multiple sites, a big tumor around the spine, a pleural lining around the lungs, abdomen, liver, lymph nodes, even the scrotum, and some bone marrow involvement. That child, you know, we just observed and disease regressed. In contrast, we'll get now to the high-risk situation where massive disease is such a challenge, because to cure a cancer, a true cancer, you have to kill every single cancer cell in that body. And I'm still amazed that it's possible, but it's increasingly possible. In fact, with back in the day when I started back in the late 80s and so on, my goal was to cure one child with high-risk disease. And nowadays it's gotten to the point where if we don't cure them, we wonder why our treatments weren't successful. So that's unbelievable progress. And definition of high-risk neuroblastoma is there's some things are very clear-cut, make an amplified disease, no doubt about it. But there are the patients fall into sort of a gray category between 12 and 18 months, maybe a little older, stage 3, but don't have to get into that right now. But fortunately, neuroblastoma is very chemosensitive, dose responsive. Here's an MIBG on the left, and on the right, after chemotherapy, kills a lot, but it's not curative. And I was mentioning before, quickly, the Goldie-Coleman hypothesis. This drives us a lot in terms of the idea that spontaneous mutations develop when they're in tumor cells. And just by chance, some mutation might confer resistance to chemotherapy or other therapies. So you want to get rid of those, you want to get rid of cancer from the child's body as soon as possible. So that might reduce the risk of emergence of new drug-resistant mutations, as I say there. So we start cycles initially as soon as the counts recover and the child's ready. It's not, some protocols, it's fixed. Every 21 days, that's it. Often we start our cycles on day 18. Now, does that make a difference? I don't know, but I'm always thinking there's cancer cells in the body that are dividing. I don't want them to, if it's Friday, say, well, why don't we wait till Monday? I say, no, I want to get it going right now. I don't know what's going to happen Saturday and Sunday. There's also child might have a fever or have a problem, couldn't get the chemo. Bird in the hand is worth two in the bush. Kill those tumor cells as soon as possible. Dr. Chung back in the day did a huge analysis of clinical trials that showed the benefit of increased dose intensity, meaning getting chemotherapy in as soon as possible and high doses if possible as well. Now the drawbacks of our NA is how we call it, our standard induction in the past, and the COG induction, we would say we've developed a new protocol for high-risk neuroblastoma. Now that I think about it, some of these slides are missing. All right. Okay. Actually, I wonder where those are. Yeah. Okay. Anyway, so ototoxicity, hearing loss. It's been referred to as a major concern. We did a big analysis of impact of cisplatin because we had an experience with patients getting 2 cycles, 3 cycles, 3 cycles plus transplant with carboplatin. Yes, we used to transplant. And we found that even though you only had 2 cycles of cisplatin and no transplant, still a fair number of patients still had significant grade 3, 4 within up to a quarter of the patients. So we want to kind of reduce that. The other issue we would say is that doxorubicin, which is the backbone of the chemotherapy, does not get into the central nervous system. The central nervous system is protected in many ways from systemic therapy. And we worry about, and we've seen relapses only in the brain, and we want to prevent that. Are there ways to prevent that? So we developed a new treatment program. We have a treatment program now that involves only 4 cycles of induction chemotherapy. I'll get into those. We do not do transplant. We stopped doing transplant almost 20 years ago. I'll go into that a little bit more. And that's followed. So the 4 cycles of chemotherapy is followed by the antibody radiation and so on. I'll go through these things. So this current program we have for high-risk neuroblastoma is aimed at achieving, as I said at the beginning, cure with avoiding side effects. In terms of chemotherapy, initially, some years ago, we were using 7 cycles of induction, then we cut it back to 5, and it did show that, and without transplant, and it did show that caused less toxicity, less hearing loss, Chemotherapy can give rise to leukemia, so cutting back on chemotherapy really made a big difference in that. And no transplants, less chemotherapy, maybe less infertility. In the new N9 pilot, as we call it, as they say, there's only 4 cycles of chemotherapy, and you'll see the details. Even less risk to kidneys, less risk to heart and hearing, I should say. In terms of radiation therapy, way back in the day when we were coming up with how to use radiation to prevent relapse in neuroblastoma, we looked through a lot of things, and one of the things that impressed us was that in preclinical, meaning laboratory studies, when you did radiation twice a day rather than once a day, had less effect on normal tissue. So our long-standing standard of doing radiation therapy involves twice a day treatments. But then we're interested in decreasing the dose because even though we don't use very high dose of radiation, 2100 is standard, might have less of a side effect, especially the impact on linear growth, how tall somebody grows. And we did a study showing that 1800 was safe, and now we have an ongoing trial down to 1500. And proton beam, which is sort of a hot item, I don't think it always makes a big difference in some neuroblastoma, but we do have that option and are quick to use that. And then in terms of immunotherapy, there have been no long-term toxicities identified. People say we don't know yet, but we've had patients that were treated 30 years ago, literally, and they haven't had any long-term side effects attributable to antibody. So we really kind of think that it's, unlike chemotherapy, radiation therapy is really a big advantage in terms of avoiding long-term toxicities. Dr. Chung developed the original mouse version of 3F8, called 3F8 in those days, and undertook a way to humanize it, which does have some advantages. We've always just used antibody with GM-CSF. In the past, these anti-GD2 antibodies were used with interleukin-2, which had some toxicity. It's dropped out of use in the United States, and I think worldwide. A randomized trial actually in Europe showed no advantage of using interleukin-2. And then in terms of immunotherapy and maybe improving things, we hope that adding a vaccine after completion of anti-GD2 antibody will improve things. So some differences, just quickly summarize a couple of differences in first-line therapy for high-risk disease from our center. The others, just in terms of number of cycles of induction chemotherapy. I actually mentioned a little while ago that we collect stems. Even though we don't do transplant, we like to collect stem cells, and we do it at least after the 3rd cycle because the stem cells might be less chance of having occult or tumor cell contamination, and also to continue with dose intensity so we don't delay that 3rd cycle, which again uses chemotherapy that could kill tumor cells that were not killed by the first 2 cycles of chemotherapy, which is the same in the COG and Sloan Kettering old protocols. Transplant, outside world does transplant, we do not. I also want to mention timing of antibody and radiation. In the outside world, radiation is the first step after transplant, and then people get to antibody. To us, that doesn't make a lot of sense because it leaves the bone marrow untreated, the systemic disease untreated. So what we've always done is as soon as people recover from their chemotherapy, last cycle of planned chemotherapy, we do a round of antibody, and then literally the next week we do the radiation therapy, and then they do the 2nd cycle of antibody. So we're covering the whole areas, all areas at risk for disease in a really timely way. And then antibody. Dinutuximab is a great antibody. We have it. We use it all the time in our patients. That we think that makes more sense than naxitamab for various reasons as we analyze each child and as they go along. And we're really, it's just such a great. Both the antibodies are approved by the FDA, which says a lot for them. And then GM-CSF, the agent that actually makes the antibodies work by attracting white blood cells to kill the tumor, to kill the neuroblastoma. And GM-CSF makes those white blood cells better killers. It hypes them up for better killing. And we found that in laboratory studies some years ago, and it was a dose response kind of thing. More GM-CSF, better killing. So way at the beginning, when we first started, even when GM-CSF was just coming available for patients with neuroblastoma, we had this plan of, we didn't just use the standard dose, we used a higher dose called stepped up dosing. And again, a big focus is on reducing late side effects. I mentioned no cisplatin, no transplant. We really expect that that's, we don't see children with hearing aids. In our patients, patients do not have hearing aids, with extremely rare exceptions. Also, we once upon a time had problems with secondary leukemia. We were using at that time 7 cycles of induction, and the more chemotherapy you were getting sets you up for leukemia. When we cut back the amount of chemotherapy, we really don't see secondary leukemia it's extremely rare. We're hoping that one of the important side effects of treatment for neuroblastoma is decreased height, decreased linear growth. And that's especially true if you have a child who's 1.5 years or 2 years old getting radiation to the site where the tumor was, and it affects the vertebral body, so the vertebral bones of your backbone don't grow as well. And short stature can be a problem. And we're hoping that with the lower dose of radiation therapy will reduce that problem. It's great that we have a long-term follow-up clinic. We call it it's a survivorship, meaning we have so many survivors, and it's so great that we have specialists that are there to evaluate them to make sure that if there are side effects, interventions can be carried out right away to try to minimize the problems. And we're hoping that the less treatment allows better fertility. We certainly do have a number of patients that are now parents. So again, only 4 cycles of induction chemotherapy, and what are they? Our first and 4th cycles are high-dose cyclophosphamide, topotecan, and vincristine, and it's again, those are agents that do not affect major organs and might have better CNS penetration to the central nervous system. Cycle 2, instead of using cisplatin, we use this combination, call it ICE, based on the initials ifosfamide, carboplatin, etoposide. Carboplatin in very, very high doses can hurt hearing, but in these sort of what we call conventional doses, it has minimal effect on hearing. And I'll talk about that a little bit more. And then we still use at least 1 cycle of sort of a backbone treatment of the high-dose cyclophosphamide with doxorubicin or adriamycin and vincristine. We do a prolonged infusion of the doxorubicin. That goes back some years ago, thinking that that might not only reduce cardiotoxicity effect on the heart, but might have a better anti-tumor effect. Never proven, but there's some laboratory studies that suggest that, so that's why we stick with that. Now, what's the rationale for the cyclophosphamide, topotecan, and vincristine? We have a very extensive experience with that. I should mention that because patients come to us in all different situations through the years, we've developed novel therapies based on what they went through before and trying to maybe give them something novel. And this was one of the combinations that we developed some years ago. And we think it has some advantages over the standard cyclophosphamide doxorubicin vincristine, such as I say, penetrate the blood-brain barrier. That's the protective structure, the structure that protects the brain and spine from chemotherapy. And we don't want that to be active, and topotecan can cross the blood-brain barrier. This combination, I say, is not toxic to major organs like the heart, and it causes little, if any, mucositis. That's not the main concern, but it's not bad to avoid mucositis, which is often caused by doxorubicin. And then advantages over the cyclophosphamide topotecan that's used in the COG protocol. The dosage is more than 2 times as high, and there's even a higher dosage of topotecan, so maybe it gets more rapid cytoreduction. The rationale for the ICE, the ifosfamide carboplatin etoposide, compared to, say, cisplatin etoposide, much less ototoxicity, meaning hearing problems, maybe has better penetration, maybe better for preventing relapse in the brain. And you can't say for sure, but it might have better anti-neuroblastoma activity. So again, overall, less chemotherapy. We're very happy to use less. We stopped using transplant. That's a myeloablative chemotherapy, is a fancy word for transplant. I'll get to that a little bit. And basically our extensive and unique, I'll mention why it's unique, experience shows no survival advantage with transplant in the year of anti-GD2 antibodies. And we think that less chemotherapy is, without compromising survival, the key thing is realistic because of the advances with anti-GD2 antibodies, whether it's in combination with GM-CSF, which is very effective, or using it with chemotherapy. Extremely effective against disease in bone or bone marrow. Again, it's kind of nice to show that the humanized 3F8, naxitamab, Danyelza, was approved by the FDA. And here's an example of what antibody and GM-CSF can do. On the left, you see a terrible MIBG scan, and on the right, this is what happens with rapid response, and it's just so great to see a normalized MIBG scan after just getting immunotherapy. Another somebody, I don't remember who it was, did comparisons between the different antibodies. Dr. Morgenstern included the versions of CH14.18 dinutuximab and dinutuximab beta. And what can I say? One of the things that, now I should say this, that we are, as I say, we have no bias towards any therapy, and whatever we think will work best, we will use. So these antibodies have never been compared one against the other, but when we developed the humanized 3F8, Dr. Chung carried out a number of tests in the laboratory that can reflect advantages or disadvantages of different antibodies. And the profile that came out for the humanized 3F8 was advantageous. And then we put it into a phase 1 trial, meaning looking to see the side effects of it. And lo and behold, we found that based on, as predicted by the laboratory test, we could administer very high doses of the humanized 3F8 safely. And in laboratory studies, the amount of antibody to tumor cell, higher amounts of antibody per tumor cell increases killing. So we were really hoping that we would be able to get by with really high doses of antibody. And indeed, we went up to 2.5 times the standard dose of these antibodies with tolerable toxicity. In the end, we capped the dose not because of toxicity, but because the serum levels, the amount that's circulating in the body, leveled off. So there's no reason to go higher doses. But it's really nice that a very an antibody that's extremely active in the laboratory could be given at 2.5 times the dose that's standard with other antibodies. And because it stays in the bloodstream for a while, you don't have to do it every day. So we eventually settled on a Monday, Wednesday, Friday schedule. So it's only three doses per cycle. I can also say that we are also, when you give an antibody, it looks foreign to a child, and the child can form an antibody against it. That's the normal reaction when something foreign goes into a person. And an antibody against one of these antibodies would block these antibodies. We routinely check to make sure a child does not develop that. In the outside world, it's not routinely done, and maybe there's some issues that can compromise therapy when that antibody is present. You might not want to do the treatment because the treatment has less chance of working. Outpatient versus inpatient, and high-dose GM-CSF versus stent. But let me move on. Yeah, so here's about the GM-CSF. I was mentioning that we use the high dose because, it's it's an agent that is easy to use and has really few, if any, side effects. Doesn't have the side effects, for example, that were notorious with interleukin-2. And as I say, in laboratory studies, we saw a dose response. So when we first started using antibody, we routinely, we started the standard dose and then step up during the treatment with the high dose. And we're constantly evaluating our results, and we can do it in real time. And we evaluated how things were going with the mouse 3F8, and we found that the use of the GM-CSF was really dramatically improved things. And we've also investigated exactly how it does it. But the bottom line from everybody else's point of view is that it really helps. And actually, it's kind of unfortunate that in Europe they did not have access to GM-CSF, and only, for example, interleukin-2. And interleukin-2 in the European experience didn't show any benefit. So I kind of always feel bad about the children in England and Europe not, getting antibody, dinutuximab beta, but not being able to benefit from the GM-CSF. Now, what about radiation therapy? I mentioned that we were always worried about the side effects of that. And I mentioned before, in terms of timing of the antibody, we do not, we do the antibody, we do radiation therapy virtually the same time as we do humanized 3FA. And again, we're trying to cover all aspects, all parts of a child where there might be neuroblastoma lurking, and we want to eradicate them, not give them time to lead to relapse. And as mentioned, we decreased dosing from the 2100, that's a dose, to 18, which is say 15 and so on. That's going on right now. And as I say, and so the radiation is nice. It's done over only 5, 6, or 7 days. And we were always, radiation primary site was shown. Relapse in the primary site was maybe about 1 out of 3 children would relapse in the primary site. And adding radiation to there reduces relapse in the primary site to maybe less than 5%. So it's a really, really nice thing. We also radiate sites that we evaluate as being worrisome for relapse. We always look at a child at time of diagnosis and so on and say, what sites are down the road, what sites are we worried about relapse? And say somebody comes in with a large mass growing out of the skull, or extensive liver involvement, or that raccoon eye caused by a big mass behind in the orbit. We really are interested in being able to irradiating those sites, even if they clear up on scans, because we're still worried that a relapse can happen. And there are ways of irradiating these sites in a way to minimize side effects. And we have a big experience with that. Now, chemoimmunotherapy is a hot item. It's been discussed before in this room. With the lower part is what's used in the outside world. Dr. Modi pioneered that, at least was the senior author on the studies, using irinotecan, temozolomide, and dinutuximab with GM-CSF. And we also use this chemoimmunotherapy, but I'd say there's some differences in how it's done. Just for example, if you look up above, and I'll go on the next slide to show some differences. We use a higher dose of temozolomide. We actually pioneered the use of that combination years ago, using that higher dose. Later on, COG carried out reported on it as well, but used the lower dose. And the thing is that always struck us in terms of the COG's way of doing it is that they get the antibody and chemotherapy, and then later on get the GM-CSF. GM-CSF activates the white blood cells for better killing of the neuroblastoma when the antibody's there. So we kind of think that maybe it'd be what we thought when we developed our chemoimmunotherapy was to do antibody during the chemotherapy and also antibody with the GM-CSF. Since we use such a high dose of antibody, we can split it and still give significant amounts of antibody with each part of that cycle. And this summarizes just that the antibody is infused with both the chemotherapy and with the GM-CSF, and the antibody that we use is the dose is 2.5 times higher than the dinutuximab, and as I say, the temozolomide is also 1.5 times higher, our use of this chemoimmunotherapy is outpatient. Now, we've also, don't just stick with just irinotecan and temozolomide using antibody. And so we often use dinutuximab or naxitamab with chemotherapy. Besides that, we use it with cyclophosphamide topotecan, and we use it with low-dose ice. And again, with naxitamab, it's an outpatient treatment. Dinutuximab, it's an inpatient treatment. But there are plenty of children that we think that it's that a different combination of chemotherapy might make sense. And in fact, generally speaking, you know, somebody might have gotten a lot of the irinotecan and temozolomide with antibody, and then keep going on that. But we think that maybe altering the chemotherapy that's being used with antibody might make some sense might kill tumor cells that are resistant to the other combination. And again, when we do it with this chemotherapy, the antibodies are administered with the chemotherapy and with the GM-CSF. Getting to the MIBG therapy, I kind of mentioned this very quickly. This is, we are very happy to do MIBG therapy, again with vorinostat. We've published on how it can be administered in a regular room, child being inpatient for only 2 or 3 days. And I didn't even think that places elsewhere do not allow parents in the room at the same time. But our parents are there even as the treatment's being done. Now, I can also say that the standard of using with MIBG therapy is administering stem cell rescue 2 weeks after the treatment to prevent the drop in blood counts. Now, we've always taken a different approach. We don't automatically give stem cell rescue at 2 weeks. We actually hold off on that, and then after an evaluation at 4 weeks or so, if there's been a response, we'll do the second cycle, and then later on deal with stem cells. But also, before we give stem cells after MIBG therapy, we always administer a cycle of chemotherapy. The counts are already low. They're going to get stem cells anyway. Let's keep going after that tumor, that neuroblastoma. So our routine is to do MIBG therapy, and then before we end up doing the stem cell rescue, administer a cycle of chemotherapy that might be most appropriate for that child's situation, using a combination of chemotherapy that we think might be really helpful. So I'll get to the point at how we don't do transplant now, but I should say that once upon a time we were eager and really enthusiastic about doing transplant. And we had a big experience with transplant. But you know, we stopped doing it, and I'll explain why in a minute or two. I'm just trying to show again that we have no bias towards any given type of therapy, and if transplant seemed good in our eyes, we'd be doing it. But here's the rationale. I'll go a couple slides about why we do not do transplant. And just as a background, it was once considered an exciting treatment for many solid tumors in children as well as adults. But it stopped being, it dropped off because it proved to have no benefit and a lot of toxicity, except for neuroblastoma. We'll get to that. It's worth reading this Emperor of All Maladies. It's a very well-written, exciting, a very interesting book about treating cancer in general. Now, it goes back to the 3 randomized studies that showed an advantage for transplant. These were carried out a long time ago. And we kind of think they're of questionable relevance now because they did not include key treatments that have been used at least since 2010 for all high-risk patients, meaning really good induction chemotherapy, local radiation therapy to the primary site is a standard, and antibody therapy. So the results from those studies, they're of interest, but are they really relevant to current situation? So down below, okay, so I list some of the additional drawbacks to those randomized trials. One is in the first and third studies that were, they compared transplant to either no transplant or little therapy. Then there was different cytoreductive regimens. You know, it's not like you say someone's getting chemotherapy and not paying attention to what's in the chemotherapy. If you say the chemotherapy is effective, you want to know, well, which agents? So in those 3 trials, they all use different combinations, including total body irradiation, which of course is not used anymore. And then one of the studies showed good preliminary good results at 3 years, which is an important marker. But long-term follow-up showed the same survival. So it didn't even show an advantage in the long term. So that's something to keep in mind too. So continuing the rationale. We say that we would postulate that there's little chance that the transplant chemotherapy can kill neuroblastoma that had already survived the high dose of chemotherapy used in induction. And we interpret this well carried out elegant trial by the Children's Oncology Group in which half the patients had purging and half did not, and showed no benefit from purging, suggesting that it's not the stem cell rescue necessarily that is the cause of relapse, or it's the same for everybody, but it's the agents that were used to kill the neuroblastoma, the chemotherapy, the cytoreductive regimen, was not enough to kill the neuroblastoma. And then moving on, in recent years, people see response, have refractory disease. So they get chemoimmunotherapy and have a great response, and then they go back to transplant. But they had chemo-refractory disease, and transplant is just chemotherapy. So we kind of missed the rationale for that situation. Now, in terms of toxicity, we know there's tremendous amount of, there's a risk of real serious toxicity to the liver. And people mentioned the TMA that can damage the kidneys. Now, not to mention, having a problem with death, although sophisticated support in transplant units these days minimizes that risk, but it's still a risk. But if you have some of these problems, it delays the next step in therapy. And we've seen a number of patients that 2-3 months later couldn't get further therapy because of the toxicity to transplant and had a relapse, either in the bone marrow or primary site or both. We work to carry out antibody in some of these patients that still had lingering effects of TMA, and I'm knock on wood, fortunately we've been able to do that in a number of patients. And then of course there's long-term toxicity from transplant. People now, carry out this, the big trial, big study looking for long-term side effects. I have to say, in our patient population not going through transplant, a lot of, some of those concerns are really not relevant to our in-house group. But there's that concern about pulmonary failure and infertility, and some concern, in the outside world, I think the issue of toxicity is gaining increased prominence. Okay, so here's our own experience. So we stopped doing transplant, as I say, in almost 20 years ago, because we carried out, at our hospital, we had series sequential clinical trials with transplant, with antibody alone, with transplant plus antibody, with antibody plus GM-CSF, and so on. And we carried out a multivariate analysis involving more than 170 patients, a big experience. And when we went over and our results showed that there was no advantage to doing transplant. So that's, and then as I said, we reviewed the 3 landmark randomized trials that, that supported the use of transplant. So we stopped doing transplant. And since then, we're constantly analyzing our results to be sure we're okay. Now, I would say it's a unique experience because transplant is used everywhere else. But what's our unique experience? Well, our in-house patients get antibody without transplant, but a lot of patients have been referred to us through the years after transplant, and get the same antibody. So we can compare the outcome with patients that are getting antibody and GM-CSF, whether they had a transplant before or not. And again, we've seen no advantage to the ones that had transplant. And of course, that's a select group because the patients that had too much toxicity, or sorry to say, died in transplant, aren't in that analysis. So so far our ongoing evaluation shows that there's no advantage to doing transplant, and that's why these are some of the reasons we don't do it. I'll move on to the vaccine, which has become a standard part of our treatment. The overall goal is to induce a child to make their own antibodies against neuroblastoma. Okay, let me just, okay. So the vaccine itself is constructed on site at Sloan Kettering. We have our center has a facility for constructing vaccines. And the vaccine includes 2 markers, GD2 and GD3, which are highly expressed on neuroblastoma. The antibodies that people get dinutuximab, et cetera, attached to GD2. But neuroblastomas also have GD3 on their surface. So we include both antibodies, both markers in the vaccine. And then there's some agents that colleagues of ours at Sloan Kettering identified some years ago that strongly stimulate the immune system. So, and have very few no side effects. So these are the agents that go into constructing the vaccine, which is, again, it's constructed at Sloan Kettering. Now we use an agent called glucan. Glucan is a substance that's in, it's a class of substances that's in a lot of foods. And some years ago, it had a reputation of boosting the immune system. Now we're always open to ideas about things that people think might help. And if it can be studied, we'll be glad to do it. And Dr. Chung and Dr. Modak carried out laboratory studies using glucan, certain kinds of glucan, and indeed it showed that it improved the effect of antibodies directed against neuroblastoma. So that led to us using glucan in patients to see what the tolerable dose is and what kind of regimen and so on. And so we came up with the dose that we ended up using with the vaccine. Now I should mention, it came up a little bit while ago in terms of the microbiome, meaning the bacteria in our intestine, which is normal, have an influence, it's called the microbiome, have an influence on our general health, including the immune system. So we did some pilot studies with the microbiome, studying the microbiome, and it seems like possible that the glucan, which you take by mouth, also can alter the microbiome. So it's an important part of our evaluation about how our vaccine works. Glucan is pretty easy to take by mouth. There's no major toxicity. And we actually have a special gel form of it. We provide it to all the patients. So we did report on a big experience of patients that had at least one relapse, got back into remission, and then got the antibody. It's 102 patients. That's a pretty large number of patients for a single institution who had been who achieved a second remission or later. Actually, almost more than a third had multiple prior relapses, so they're really at high risk. And we saw a very interesting, some progression-free survival and good overall survival. So it seemed like it was advantageous it gave some hint that maybe the vaccine's improving things, since even one relapse historically has been deemed to be inherently, invariably fatal, as quoted in a review of neuroblastoma some years ago. But we don't find it to be invariably incurable. Some of the key findings in that trial was that it's really, we're always studying what's happening in our patients. And we found that if the vaccine is successful to elicit an anti-GD2 response, then that child has a much better outlook. Then we also found that, I should have mentioned that the glucan in the initial trial was started at week 6 weeks after the first shot of the vaccine. Why at 6 weeks? Because glucan, we thought, increases the effect of antibodies. We want to give the vaccine time to induce antibodies in the patients before we start the glucan. But what we found was that either by chance or whatever it was, after starting glucan, there were really marked increases in titers. In other words, the level of antibodies against the neuroblastoma. So it kind of was of some interest. Then there's also a role for various, how glucan works. There are receptors for glucan. In other words, glucan would stimulate certain immune cells. And we were able to identify a specific kind of marker that is more associated with the a helpful effect of the glucan. And then we were interested to see how long the antibody responds, stays present, because the whole point of the vaccine is to induce these antibodies against neuroblastoma so that if there's still neuroblastoma lurking in the body, these antibodies induced by the vaccine can kill those off. And we do see persistence of the response, but it does fall off after they stop getting their boosters at 1 year. So we made some changes. We did a randomized, first of all, we did a randomized trial to study the effect of glucan. As I mentioned, the standard was starting at week 6. Well, and we saw an increase in the effect on antibody responses against the neuroblastoma. So we said, let's start right at the beginning. So half our patients were getting the glucan right at the beginning, and half got it at week 6. And we did find and that's 107 patients over about 2.5 years. And the starting early was very helpful. Increased the levels of the amount of antibodies against neuroblastoma compared to starting at week 6. And there are no added side effects with that. So in our current trial, and again, inducing antibodies against neuroblastoma was highly associated with a favorable outcome. Now, we have an ongoing trial now. We opened, gosh, maybe the latter part of last year, in the last fall. It's using the vaccine and glucan, but we want to study GM-CSF. Does GM-CSF improve response? Again, GM-CSF clearly improves the effect of antibodies against neuroblastoma. So it seemed like a logical thing to add it in. And it might have other effects as well that might be beneficial, but it also might have side effects. So it's a randomized trial. So half the children will get the GM-CSF with the shots, the vaccines, and half will not. Another change that we made is that we do give boosters. The original trial in all the year was 7 shots basically over 1 year, 3 at the beginning and several boosters. But we now add a booster halfway through the second year and at the end of the second year, and then again at the end of year 3. And again, the major aims of the trial are to see if GM-CSF improves the antibody situation. Some general observations about vaccine and glucan. You really need to do a randomized trial to see if it really makes a difference. Oh yeah, so there were vaccines that were used in the past without the use of glucan that had similar components to our antibody, our vaccine, and they did not elicit a robust antibody response, so suggest that glucan might be an advantage in terms of inducing the effect that we want in our patients. And we would say that, again, the advantages of having active immunity, meaning the child making their own antibodies against neuroblastoma, might be advantageous compared to passive immunity, where you're giving a patient antibody, include that the antibodies the child makes might have go after different parts of neuroblastoma. And it also means those antibodies against the neuroblastoma are present for a long time and might be able to ablate tumor cells that escape the antibodies that were administered. And it's also possible that it's immunological memory that can respond in the future. Maybe there's working against other tumors that have GD2 and GD3. It's fun to think that maybe oral beta-glucan will be proved to be worthwhile in all vaccines, but maybe I'm going over. Am I going over time? Yeah. Okay. Too bad, because, yeah, just quickly, advantages of close monitoring. Very quickly, we include head MRIs because some MIBG scans do not pick up small CNS lesions. We develop salvage regimens, I say, because patients come to us in all different situations, so we've developed different kinds of rescue chemotherapy regimens, salvage. The chemoimmunotherapy, I mentioned before, different use of chemotherapy. Bertamab, key agent, monoclonal antibody that is radiolabeled and used for treating CNS disease. We have a great salvage program for CNS relapse. And we also study genomics, genetic abnormalities that we could target. This is another way of doing MIBG, systemic radiation therapy. Copper sartate is a very active trial that we have going on for resistant disease. And we do think this is cure. I have no disclosures. Some of my colleagues do disclosures. Thank you.
Sorry about rushing you. It's like we're about a half an hour late, though. Does anybody have any questions? Yeah, please come up to the microphone.
So my son did maybe a handful of 3F8 cycles last summer, and unfortunately he had to stop due to what ended up being a false relapse diagnosis. And so we started him again this past spring. Unfortunately, in his first round this spring, he was starting to get allergic reactions, and they ended up being HA positive. So I noticed you mentioned that the 3F8 is 2.5 times the strength or dose of the previous. Do you guys have any studies showing that maybe if you did the cycle at a less intense amount of 3F8, a lower dose, is it still effective and maybe will prevent you from going HA positive?
HA positivity really just depends on if you're exposed to the antibodies. It's not a dose-related thing.
Okay.
Now we do have treatments to do what we do if HA is positive and gets in the way of treatment. We have ways of bringing it down.
Okay.
I don't know if your child had that. Rituximab. Rituximab is a monoclonal antibody. It's easy to administer. It's used for a wide variety of diseases. And it knocks out the B cells, the agents that produce HAHA. So if someone's HAHA positive and can't get treatment in a timely way, we'll treat them with rituximab and usually maybe some low-dose chemotherapy sort of as a maintenance. And it's a very reliable way to bring down HAHA and then continue with the
And
therapy.
so that will reduce the chance of having allergic reactions and going into anaphylactic shock? Or?
No, just the HAHA.
Okay.
Just reduces HAHA.
And so if HAHA continues to be a problem, is the mouse version still available?
No. No. And we would expect that if someone's HAHA, human antibody, that's what that stands for, they would have the same have the same situation with the original version mouse antibody. But we are very careful to monitor HAHA, yeah. And as I say, we have ways of bringing it down, the rituximab.
This may be a bad question, so forgive me, but I'm not too familiar with the clinical trial approval process, but is it out of the realm of possibility to do some sort of randomized trial, with cooperation from COG and the MSK, different standards of protocol? Because I know as a parent, it's one of our decision points at the beginning of treatment. It's very, very hard to decide. And has there been any discussion on the two joining together to do some sort of randomized trial?
I'm not aware of anything seriously going on in that regard, but we try to share our ideas.
I mean, I think to answer that, I think as I said, the Children's Oncology Group is beginning to discuss how could we think about addressing the question about high-dose chemotherapy. The challenge that we have is how to take results from a single institution or two institutions, because we know that lots of the factors that play into outcomes for treatment are much harder to control when you're doing a study across multiple sites. So, just one example, we know that at MSK, they've had a series of exceptional surgeons who are very aggressive in how they go after any remaining tumor. And so that is likely to be different from most other hospitals, including, my own. And so it may well be, therefore, that it's difficult to immediately take those results and to translate them to other hospitals. And so I think it's hard to imagine simplistically it's attractive to say, let's just randomize that way versus this way, but it's hard to take into account all of the components of that treatment.
Any other questions? No one? Okay. Thank you, Dr. Kushner.
Okay.
We're going to take a 5-minute break. We have to load a presentation, and then we'll be closing out the day with our neuroblastoma survivor.
Yeah, exactly.
Oh, I do have an announcement to make. There is restorative yoga, all levels, all bodies, 4:45 in Cypress A. So if anybody's interested, Lori Zucker, ma'am, she will lead the classroom. Thank you. Next. Oh, it says next. Next, back. Okay.
Okay, so that's for like the slides when I just.
Yeah, yeah.
Okay. Should I just stay up here?
Yeah, sit down. Relax. Oh, dear. Okay, we're getting ready to close out the sessions, and I wanted to introduce a young lady that I met. She randomly emails me, and we got to be some friends here and everything, and she's a neuroblastoma survivor, and I would like for her to tell her story. We met, via email a couple months ago or whatever. So, and I'll let her tell you the story a little bit further. Alexis Grand.
Hello, everybody. I'm Alexis. So me and Pat met. It was my senior year of high school, which I'm graduated now. And I was doing a capstone project, which is something, I went to the Cecil County School of Technology, where I studied biomedical sciences. And we did these capstone projects, which is basically we started with an idea. We came up all by ourselves, something we were passionate about. And then we went on and we created whatever we wanted with it. So I'm very passionate about cancer. And when me and my mom first started talking about it when I was younger, I don't remember our first conversation, but as I got older and we started talking more about it, I always remember being super curious and always having questions. So I decided to do my capstone project on neuroblastoma, and basically, how does education impact the willingness to donate, which it's kind of cool because when I was talking to Pat, they were researching the same questions too. So I was like, oh my gosh, this is perfect. So I held a whole donation at my school. I created a slideshow about neuroblastoma, and I went around and I taught 8 different classes. And then I went in the lunchroom and I had donation boxes, and depending if I educated them or if I didn't, and seeing how like the money varied. So just start showing. So I'll start showing the pictures so you guys can start looking at them. So that was how I met Pat and got invited here to speak here. So my story, I was about 1.5 years when I was diagnosed, so I really don't remember a lot, just pretty much based off what my mom has told me and what we've talked about, what I've looked into, and based on these pictures. So yeah, I was about 1.5 years when I was diagnosed. It started out with a fever. So my mom had noticed I wasn't feeling very well. She was giving me medicine. My fever just kept going up. I was at about 103. And it wasn't going down. So that's when my mom took me to the ER. And from there, they did the chest x-ray, and they seen a shadow. So they had asked if we had more time. So I had gotten transported to AI, DuPont, where they did all my studying there. I had my surgery. I was there for 14 years of my life. So we went to AI. And sorry, I'm a little nervous. So we went to AI. They did 2 weeks of straight testing. It was nothing but testing, just trying to figure out, because all they seen was the shadow. So they knew it was a tumor, they just didn't know what it was. So after 2 weeks of straight testing, they finally diagnosed me with neuroblastoma. I had immediate surgery once they found out. I was in the hospital for about 3 to 4 days in recovery after surgery, which this shows kind of the setup of where I was. So you can see all the monitors. Down there in the picture on the bottom, that's where my drainage tubes were. So in later pictures, I'll show you the scarring that I still have, which I have like a dent in my back from the drainage tubes being in there that you can still see today. But that's kind of like the setup of how everything was. And then just closer up pictures of kind of how I was laying in the crib. So you can see that I look very miserable. I was on a lot of medication, so I didn't really have much of an idea of what was going on most of the time. But I was very excited to leave when the time came, nothing but smiles. So then this is just close-up pictures. So you can kind of see in the picture where I'm sitting up, the scarring, and then that big white patch is where the drainage tubes were. So just a closer up look, and which you can kind of see in this picture here, the drainage tubes. And then that's me coming home, very happy, ready to be out of the hospital. So that's me coming home and still doing normal things, still going outside to play with the dog. I was a wild kid. I still went out in the dirt, rolled around in it, did a bunch of crazy stuff. So this is the scarring. It might be a little hard to see, but my scar is pretty decent sized. It's not as, can't really see it as much now. My mom put medicine on it, so like it wouldn't be very like purple, and you couldn't really see it as I got older, so it kind of like faded with my skin. And then you can see the dent at the lower part of my back. That's where the drainage tubes were. So that's what you can still see today. It's not bad. So I'm glad that I still look very okay. So, and then I just wanted to put a collage of things that, even though I had cancer and I don't really remember much of it, I didn't let it stop me. I still went off and did anything I wanted to do. And so you can see I played basketball, I was soccer, varsity lacrosse. I still went to school dances. I was still involved in all of school events. I graduated from 2 schools, so the Cecil County School of Tech, where I did the biomedical sciences, and then I graduated from my high school. And then I was also an officer in the National Honor Society. So I just wanted to put these up here because I just wanted to show that, like, don't let anything stop you. You can still do everything you want to do. And I just want to add too that really family is your strongest supporter. My family, my mom and my mom's side of the family, amazing people, and they were there by my side through everything, always supported me no matter what. They pushed me to do more than what I thought I could ever do. And it's led me to where I am now, being able to talk to everybody here, and was invited to this. And it's just amazing because I remember being younger and I was always so curious, and I was like, I want to do something involving cancer. Like I want to do a fundraiser. I want to do one of those 5K runs, like just anything to get me involved. And I was like so sad because I never knew like how to get involved. And it's like this capstone project came up my senior year, and I didn't expect it to be anything more than just a project. Especially didn't expect to be flown out to Chicago. So it's been really exciting, and I'm just finally glad to feel like I'm a part of something, which is great because I really do here. Everybody is wonderful, and thank you, Pat, again. She's amazing. But yeah, family's your strongest supporter, so just always be there for them, always show them that you care. And this is just showing where I've been, and I'm going to college to major in nursing. I want to do pediatric oncology, so I'm still going places. I'm still going. So, but that's all I have, short and sweet.
Thank you.
Thank you.
You did an awesome job. Yeah. Okay. Yeah. We have a second speaker coming. You did awesome. Nobody has questions? No? Okay. Our next speaker is Theo Yanis. You've spoken before at our conference, have you? Or at our gala? Yeah, okay. He's a local family here, and we would like Theo to come up and tell his story. And again, if you have questions of Theo, please feel free to ask him. Theo Yanis.
Hello, everyone. First, I want to thank Ms. Pat for inviting me to speak at this year's CNCF conference. My name is Theo Yanis, and I'm going to my senior year at Fremd High School in Palatine. So in May 2011, when I was 6 years old, I was diagnosed with stage 4 high-risk neuroblastoma with main tumors in my adrenal gland, my left elbow, and underneath my left eye. I was treated at the University of Chicago Comer's Children's Hospital, where I received 6 rounds of chemotherapy, surgery to remove my primary tumor, 2 stem cell transplants, 12 rounds of proton beam radiation, and 6 months of immunotherapy. My treatment finished in the August of 2012, and next month I'll be celebrating 10 years of being in remission. Fighting cancer is hard, scary, and unpredictable. My family and I attended the same CNCF conference the year I was diagnosed, so in 2011. I remember meeting other kids who were fighting neuroblastoma too in the playroom in the back. My sisters and I participated in activities while my parents listened to presentations from doctors. During that conference, they also connected with other families who shared their experiences and offered them advice and comfort and hope like you guys. And that's why I'm here today. It can be very difficult for kids and parents to picture what life will be like after chemotherapy, radiation, and all those hospital visits are no longer needed after treatment. I'd like to share with you what I've been up to since I completed treatment 10 years ago in hopes that it'll give you guys a little something to look forward to. I love sports. Ever since I was very young, I've played almost every single sport, including basketball, soccer, hockey, golf, and baseball. The only sport my parents would let me play was football because it was too dangerous. We agreed to disagree on that one, though. Being active and staying in shape has always been super important to me. Even when I was in treatment, I convinced my oncologist to let me continue playing soccer, and I was that bald kid on the field that scored the winning goal during the last game of the season. Today, I play varsity golf and baseball at my high school, and I plan to play basketball in the rec league this winter with my buddies. Although I have a passion for sports, education is and has been my top priority. I'm a pretty good student and mostly take advanced honors classes. I've made the honor roll each semester, and I will also be inducted to National Honor Society next month. Like Alexis, I'd like to share with you a quick story about one of the classes I took, which was similar, the AP Capstone. The class I was centered around a 9-month research project where I had to investigate a unique topic that no one else had ever published before. And my research centered on childhood cancer survivors and how they perceived their social status in high school compared to kids that were never diagnosed with cancer. I gathered and assessed data from 150 childhood cancer survivors in the Chicago metropolitan area and 200 non-cancer patients in high school. I submitted my report to the college board and received a score of 5, which is the highest possible score that qualifies for my college credit. I sent a copy of my report to my oncologist at U of C, and maybe one day some fellow will also want to investigate my topic further and get it published. In addition to academics and sports, I've always been drawn to music. I play the piano and I played trumpet in jazz band. 2 years ago during COVID, I joined my high school debate team. My debate partner and I not only made it to the Illinois State Championships, but we won first place 2 years in a row. Yeah. My Greek culture is a huge part of my identity. I'm very involved in my church and serve as an altar boy captain. I attended Greek school and was a part of a Greek dance troupe where I performed at festivals, weddings, baptisms, and museums. I've also gone away at Greek Orthodox camp in Wisconsin for the past 7 summers, where I've met some of my greatest friends. This summer, I got my first job as a tutor in math and English, and I'm also starting to work on my college application and essays. So next year, hopefully, I'll be heading off to college. I'm pretty much a regular teenager. Many people I meet now are often shocked to find out that I had fought cancer. It's not something I really lead with. Cancer is a big part of me, but it does not define me. Over the years, I've been active in helping raise money for childhood cancer research, speaking at events like this one, and supporting organizations like CNCF, Bare Necessities, Alex's Lemonade Stand Foundation, and others. And when I share my story, I'm living proof that clinical trials and more research can help to improve survival rates and better outcomes for these patients. And obviously, the last 10 years have not been perfect. I've faced some long-term effects from my cancer diagnosis and treatment, both physically and emotionally. And while my visits to the hospital for scans went from every 3 months to 6 months to a year, and now none at all, I still make an annual trip to my oncologist and frequent trips to specialists to make sure that everything is okay with me. As a result of my treatment, I have neuropathy in my hands and feet, which I'll always deal with. I have high-pitched hearing loss, and I do wear hearing aids. I have scoliosis, high thyroid levels, scars over my body, and even some areas where my hair didn't grow back completely. I almost didn't get braces because my teeth have very short roots because of the chemotherapy, but luckily I found an orthodontist who was willing to help and work through the risk to straighten my teeth, so yeah. Like most teenagers, I'm pretty stressed, but unlike most kids my age, I get anxious and overwhelmed when I think about the fact that I had cancer. And as I've gotten older, the more I realized how big of a deal my treatment actually was. I sometimes feel alone despite being surrounded by lots of people who care about me. And what I went through and what you and your families are going through is pretty unique, and it's a journey that no child should obviously ever have to make. Even though I have these long-term effects, I've been extremely fortunate to overcome so much. And when you think about all the chemo I had, the 2 stem cell transplants, the antibodies, most people would say I wasn't supposed to be a 2-sport varsity athlete. I wasn't supposed to be in the 99th percentile academically, and I wasn't supposed to be the obnoxious extrovert that I am today, but here I am. Every day is a blessing, and I'm so thankful for everything that has happened to me. I wish you and your families the best, and I hope today is just as rewarding for you as it was for me 10 years ago. And on behalf of my entire family, we wish you health, healing, and happiness always. Thank you.
Does anyone have any questions? Nope, no question. Oh, one question.
First, I just want to say thank you to you and Alexis for being here. I know it means a lot to every person in this room to hear from you guys, so thank you for that. And the other thing is the paper and the research that you did comparing students in the Chicago area, I don't know how long ago you wrote that paper. You may not remember, but was there any, I'd love to kind of hear any insights you had from your research.
Yeah, so that was my sophomore year. It was a little less than 2 years ago. Basically, what I had to do was find something that had not been researched before, and I knew that, like Alexis, it was something I wanted to do something with childhood cancer. One thing I found was finding something where there was differences, and I could tell that there was a difference between myself and someone else. So the whole idea with social status was that the way kids that had cancer thought about themselves in a social setting. So I broke down PTSD, depression, anxiety, extrovert, introvertness, and any physical long-term effects that they may have and how that affects it. So what happened was I took 150 kids I sent out a survey and 150 responses I got, and I also took the control side, which were kids that never had cancer. And I asked them questions based off of depression, anxiety tests, PTSD tests, and found how they changed or how they were different between these childhood cancer survivors and kids that never got it. So the 2 really big things that I got out of it was your subjective social status, or the way you perceive oneself on a social setting, is a lot lower for childhood cancer survivors. And those were caused by 2 reasons. One was extrovertness. So on net, what I found in my study was that childhood cancer survivors are not as extrovert and don't really put themselves out there in high school. And it was also big for depression. So depression rates were a little bit higher, and that kind of went along with PTSD and anxiety, but the results that I got from PTSD and anxiety were not large enough for me to make a clear indication. So I did submit that to my oncologist at University of Chicago. I haven't gotten a response back on whether or not that will be published or anything, but I did receive the 5, which got me some college credit, which is nice.
That's awesome.
My daughter lost some of her hearing as well. Do you wear your hearing aids often or every day? Because I have problems getting her to wear them, even though she cannot hear you. She will stand there, she would nod, she would sometimes read your lips and act like she hear you, but she don't or even don't care. Yeah. So do you wear them like you're supposed to, or are you just like, I'm just going with the flow today?
No, I don't. Not how I should. But I do wear them in school, and that's where I really need it, because the whole idea, if I'm speaking to you personally, I can hear you just fine. But the problem comes when I'm speaking to you and somebody's speaking behind me, and then everybody's in public, and I get overwhelmed and I can't hear you. So that's where in a school setting, especially at lunch or in a classroom where we're having group activities, that's where it really helps me. I don't wear them at home because I don't need to. But yeah, I think it's not just your kid. I think it's a lot of kids just don't wear their hearing aids or don't wear their glasses or whatever. But yeah.
I already do that. I put Alexa all over the house, so now she has.
Yeah. Oh yeah.
Any other questions? Okay. Thank you very much, Theo. It was a great talk, you and Alexis. This ends today's sessions. We have dinner tonight and DJ, so get your dancing shoes on. We'll have dinner. Everything will be back in Junior Ballroom A at probably around 6:30. So take a break, get a little rest, and then come back around and get ready to dance. Thank you.